simulation lab, which is revolutionizing the scope of healthcare services. A very simple idea with a very huge impact. My dear friends, introducing one of our superheroes who traveled through this groundbreaking initiative. We call it as Coma to Community, adding life to years. Thank you.
Thank you very much, Dr. Saril, for a wonderful innovation to remind all of us that in the chase to seek higher and higher technology, we have to be inclusive in healthcare. And it is a statutory law by our nation now, right of people with disability. So we have to be very, very clear that this is our responsibility. We are not doing any obligation to these people. And really a great presentation. Open to jury, please.
How long does it take, sir, for somebody, you showed that example, how long did it take for him to reach that level of independence?
Yeah, that's a very good question. Thank you. So we categorize patients. So we are an acute neurorehabilitation center, which means some of them start as a complete comatose stage. So as they start showing significant changes in their coma part of it, and they become, we categorize them as functional patients. And from there, usually we involve the family and the patients as what was their lifestyle before. What is that you want to achieve? Maybe you just want to hold a newspaper and read the newspaper, and that's what important thing for them. So that is prioritized above rest everything. So it is based on each task one at a time, trying to achieve, or a simple thing like at least, wash the face. And that gives them an immense satisfaction. So each task sometimes takes 1 or 2 weeks is what is our experience, but it depends on the task complexity also. Thank you.
Just, I join, sir, in congratulating you on, first of all, taking something which is so important, but mostly forgotten by most hospitals and highlighting it. Thank you so much.
Thank you.
Thank you for your wonderful presentation. One question here is, what were the exclusion criteria? Whether you have taken all comatose patients or have you excluded?
Yeah. So patients who have not reached at least 8 on a GCS is not definitely part of the project. And people who have got cognitive challenges, which is really a significant issue, there the cognitive rehabilitation team works on them. And the third category is people who have got mental disorders, where it is very difficult to kind of, get them to do the daily. Like, for example, cooking, it involves heat. So safety has to be prioritized above everything else. So these are the 3 categories of patients we could not take up. But then we focus on the emotional aspects by a clinical psychologist or a cognitive aspect by a neuropsychologist, more on them. Once they come to the inclusion category, then we start prioritizing their daily task activities.
Thank you for the clarification.
Thank you.
Thank you for
Thank you very
focusing
much
on patient outcome also.
For
Thank
a
you.
great topic chosen. Thank you.
Is there another question?
Okay. Coming from Tata Medical Center, a very, I think, honest acceptance. Despite continuous monitoring, medication error system documentation has seen a rise in error. I wish all of us accept it, and so that the mistakes can be improved. I invite on stage Mr. Mani Deepak Ghosh.
Dr. Yakuta may be ready for the next presentation, please.
Thank you, CAHOCON, to giving me this opportunity to present our project. This is a study on reduction of occurrence of medication error. So, despite of continuous monitoring in medication error system, we found that from the starting of the 2024 that the absolute count or number of medication error is increasing than 2023. Then only we have think it about that we have to work on it. So with the aims of to achieve in reduction in errors of higher harm risk score set, we have set our objective to reduce the medication errors. We have objective that to minimize the medication prescription and administration error. We have to reduce the administration error for higher risk score as close to 0 as possible. and the reduction of prescription error by 75%. As so many instances, the administration error also leads to prescription error, and we have to establish a blame-free reporting system for the awareness among all healthcare workers. So, as part of methodology, we know that prescription medication error starts from prescription to till the administration error. So we have emphasized few areas where the probable cause of the medication error has been affected. So these are the few red boxes where the medication error is being done. We have work on these specific areas. We have monitored that prescription when the after prescription error, during administration, how the process is being done by nurses, and for pharmacists also we are monitored when they are dispensing the medication and all. So from that process map, we have identified few root causes. As part of medication error, the non-uses of generic and brand name, which mismatch so many times, therapeutic duplication, doses error we found. And from nursing perspective, during administration error, so many times the nurses are not following all the 10 rights, especially the right dose, duration, and for the high alert drugs, they were not using for the cross-checking methods. From the pharmacist prospects, we have seen that during dispatching of medication, the wrong identification were there. They are only going for the bed numbers, not the registration and name. And as a part of environment and process, we have seen that our hospital is cancer-specific hospital. So we have 3 areas for medication preparation area for chemo drugs. So from the ward, it is a long distance where the medicine is being transported. They are prepared. They are coming back. So in that transporting time, so many times we have seen that the errors have been found. So from that, we have identified that main 4 key areas which on we need to work on it. This is the awareness among doctors, awareness among nurses and pharmacists, and identification of near miss error and development of blame-free culture report. So for the based on 3 key drivers, we have done the intervention. Mainly for the awareness among doctors, we have done the spot correction by the clinical pharmacologist and clinical pharmacist team. Immediately, whenever they are identified, the error is happening, then and there, they are with proper literature, they are informing the prescriber and correct the errors. Among the awareness among nurses and pharmacists, continuous training was going on for the individual staff interview, and we have spot correction also was done, and we have implemented that the sharing communication on actual event for the new joinees during the induction period, so they can identify how the error is happening and they can reduce it. And next one is the identification of more near misses. So we are as a part of medication management team in our hospital, it is a complex team for pharmacists, nurses, hospital quality, and clinical pharmacologists. So we have a reporting system through HMS, and we are motivating our staff. If simple event also is there, they should inform. From there, we are identifying the near miss errors, and we are preventing the adverse and sentinel events. And the last one, and we are, though in our hospital, as perspective of treatment protocol guidelines are there, but for the nurses, there is no written protocol is there about the dilution, which all drug they can prepare. So we are doing these things for handbook form, so that when the nurses are working on the field, they can take the guideline for these things. Sorry. So as a part of result, we have seen that the things we have divided in the 3 phases for that pre-implementation, during presentation, and post-implementation. Now, pre-implementation from 23 to May 24, we have seen that there is a mean average of 152. The error was there where the prescription error was more. Then we have started our implementation during the month of June 24. So June 24 to 25, throughout the hospital, training of doctors, nurses, we were there. So from there, the reduction rate was reduced from 80% to 60% for prescription error. Then for administration error, the absolute number reduced from 30 to 20. So after that implementation, our sustaining program, sustaining management was there. So there we have seen that the higher harm risk score, that is for administration error category D and E, it has been reduced from 16 to 2, and for the category E, which actually reaches the patient and requires monitor, that is also has been reduced from 16 to 1. So our main goal is to sustain that things. We will not reach the high risk score for the medication administration error. This is just one photo evidence where the correction is being done during the intervention. Now, as an impact, it is that it is directly impact on the patient satisfaction, which also lowering the risk of the patient. Now, as a recommendation, we have observed the length of stay also will be reduced for the reduction of medication error, and based on the drug specific module, the nurses also will be hands-on, do the hands-on training, and they can reduce the careful about the reduction of error. Now, for the challenges we have faced during this
Kindly
program,
conclude.
that mainly the spot on training and the reporting of blame-free report. So that is our key learning for that project. From that, it is a actually continuous project. We are going on for this project to maintain that sustainability. So this is about the all things, and here this is the things. In this graph also you can see that the reduction of error is also being there. Thank you for listening to me.
Thank you very much for reminding us that process mapping is the main thing, and then training, staff training. Thank you very much. Open to jury, please.
Your objective was to reduce the prescription error by 25%.
Yes.
So what has happened?
Yes, sir.
No, has it been reduced? Did you show the data on that?
Sir, actually through prescription audit also we are collecting the
This process improvement should reduce your 25%, reduce to less than 25% of prescription errors.
yes, sir. 75%. Why we have chosen it is the human
No, has it
error.
happened?
Yes.
As it happened,
Was
was there any data to justify it?
No, 75%, 75% we reached towards near about, I have told that this one 60, till now we didn't reach to the 75%. We are near about 60 to 65%.
Thank you very much for a very nice thing. And
We
now
got-
may I call on stage Dr. Nisha Nair.
It's Dr. Yakuta from Access Clinic, Dubai. Will be presenting the last presentation on enhancing value-based care in primary care using center criteria for antimicrobial stewardship and better outcomes.
Good morning, everyone. My name is Dr. Yakuta Muzammil. I'm working in Access Clinics, UAE. I'm here presenting this research, which was led by Dr. Suleiman Ahmed, but despite of strong visa efforts, he was unable to make it. So our aim of the study was to assess the impact of center criteria implementation on reducing unnecessary antibiotic prescriptions by about 20% within the Aster clinics. We made sure that we have 90% compliance to both our standards for our study being satisfactory. The center criteria has 4 main points: tonsillar exudates, tender cervical lymph nodes, fever of more than 38 degrees Celsius, and absence of cough. So this project was carried out in Al Quoz and DIP clinics, Dubai, where we included adult patients, that is more than 18 years of age, and those who presented with sore throat and fever with no cough. Our exclusion was pediatric patients and those having recurrent tonsillitis. So this study ran from June to November 2024, and it had 2 arms, the prospective and retrospective arm. In the prospective arm, we saw 81 patients post-implementation of the criteria within the next 4 weeks. In the retrospective arm, we have 85 patients who were managed without implementing the criteria in the 6 months before the implementation of the criteria. So upon analyzing our study, we noted that in the retrospective arm, there were 85 patients, amongst whom 66 were prescribed antibiotics. A number of them came back for follow-up due to unresolved symptoms. Here, the physicians reported that there was a difficulty in distinguishing viral from bacterial infections. In the prospective arm, amongst the 81 patients, only 15 were given antibiotics in the first visit who had a center criteria of 3 or more. Here, 11 patients came back for follow-up who had unresolved symptoms, out of whom, again, only 2 were prescribed antibiotics. 46 patients were sent for throat swabs, and none of them tested positive for group A streptococcus. Here, the physicians reported an increase in confidence in decision-making, and they found the criteria to be helpful in guiding their antibiotic prescriptions. So to assess the impact that it has, an average antibiotic course in UAE is about 60 dirhams. In post-implementing the criteria, we see that the cost comes out to be only 900 dirhams, while before implementation, it was nearly 4,000 dirhams. The number of prescriptions were about 70%, 78% post-implementation. Pre-implementation, pre-implementation, it was about 70% and 19% post-implementation. We had placed an image of the criteria in each physician's room to make sure that they adhere to the criteria. Our action plan forward is to promote antimicrobial stewardship, to maintain, to give patient education programs. Because even patients, we have noted that patients need to be educated upon the misuse of the antibiotics and also about the emerging resistance to antibiotic. We need to also make sure that we have continuous feedback loops and auditing systems so that the physician can be educated about this. And also we know that the physician is adhering to the guidelines. So we did have some scalability challenges. First was clinician training. Even though they were trained, there can be a discrepancy in the clinically assessing the symptoms. Also, the patient population, this is a fast-paced clinic, and the population is such that there can be some variations. There is a difficulty in standardizing audit tools across many settings. Thank you. To conclude, these are my references, and thank you for your engagement.
Thank you very much for a very nice concept. Open to jury, please.
Did you look into those 2 cases where it was restarted after 3 days, whether the initial criteria were correct or not?
So, sir, based on the criteria, because these criteria are based on the physician's judgment. So initially, they were not given antibiotics, but as you were asking, on the second visit, they had unresolved symptoms and they had other symptoms as well, which made the physician give antibiotics.
Yeah. No, why they were missed in the first instance? Did you had an audit of these cases?
So, sir, in the first visit, they didn't have any of the criterias. The center score was less than 3, where we did not give antibiotics. But on the second visit, they did start showing symptoms and which required the physician to give antibiotics. Because this is sir, because the center criteria is a subjective criteria where the physician has to monitor the symptoms and assess the symptoms and as per that give antibiotics.
Okay.
Thank you.
I think with this, thank you very much for a very innovative project.
Thank you.
I think with this, we come to the conclusion of our session. I thank you, all the participants, CAHOCON team, for bringing out a lot of innovative ideas and reminding all of us that healthcare is about taking care of small things. Even adhesive tapes quality can make an impact on the final outcome despite using the latest technologies. So energy saving is a reminder to all of us that we are a part of a very large ecosystem and our social responsibility cannot be undermined. Similarly, ADL concept to make healthcare inclusive for everyone. And I also thank Dr. Chabda. And we had done a study on nearly 220 odd topics, and ultimately these were the 14 best. Yeah, invite all the jury members also. Please come on the dais, please.
So, so we come to an end of this competitive session, and in fact, as was mentioned by my co-chair, Dr. Deepak Singla, all the 14 presentations, in fact, may be called winners because they were screened after a detailed evaluation criteria from amongst more than 230 abstracts. So big round of applause for all the presenters, please. A big round of applause for the jury also, who devoted their time and made the session very interactive through their questions. So with that, the results will be declared, I believe, in the valedictory session. Over to the
Thanks a lot.
organizer.
I'll request the jury to come forward to the stage so that along with the chairperson, we can have a photo op. Thanks a lot. It was a wonderful moderation from the two chairs, Dr. Singla sir and Dr. Chavra sir, and the eminent juries who spend their morning out here. Thanks a lot. I'll hand it over to the MCs.
Ladies and gentlemen, a very good morning to all of you. With these technical and scientific presentations winding up, we would like to start our sessions for today. You must be wondering who's this beauty and the beast. So I am Dr. Sameer Singh, and along with me is Ms. Bobby Ramesh. She needs no introduction. We begin without much of ado. Session 10, Patient for Patient Safety. For the session, I'd like to invite the speaker for today, Dr. Ezequiel Garcia Elorio. Sir, if you could please come. He's from the Department of Quality, Patient Safety and Clinical Management. He's Director for Healthcare Quality and Patient Safety. He would be speaking on global perspective on patient engagement. Dr. Elorio. Along with them.
Good morning, ladies and gentlemen. May I invite on stage our moderators, Mr. So Mitchell, Chairman, Patient for Patient Safety Foundation, former President and Chairman, NASCOM, Dr. Bhupender Kumar Rana, Chief Executive Officer, Quality and Accreditation Institute.
Thank you.
Dr. Laurie, if you have a talk you'd like to give, sure. Mic is all yours.
So much. Well, good morning. Thanks for being here this early. Again, it's a pleasure to join you for this conference. It's been a learning experience in many ways for me. And I'd like that we have been invited to present in this important session that relates to one of the critical components of quality of care nowadays, which is the global perspective on patient engagement. So this should work. Can I try the... Hello? I'll do it from here, if it works. So I try to be brief, so we have more questions, we have more time for the panel. So I will try to present just 10 slides, making a short description on what is patient engagement and trying to, I would say, make the case that I believe it's already made in many ways. But first, just trying to define what is patient engagement, just mentioning that it's a process of facilitation and strengthening the role of those using services as co-producers of health and healthcare policy and practice. Remember, we are the few industries where the users, the patients and families, are not that much engaged as in other industries. And that's particularly curious of us. So the topic is named A Global Perspective. And of course, all of us know that it's easier said than done. And again, there are not many reports on the level of patient engagement around the world. So I maybe couldn't describe much on the title of the presentation. But again, there is a big challenge that we need to go through. And later I will say why. But we need to find a way through everywhere for everyone all the time. Because unfortunately, patient engagement for the moment, it's a luxury of few. And hopefully we can change that. And why patient engagement? Well, I mentioned here that it's because it works, it's shown by the evidence, and it's the right thing to do. Why? Because it's so obvious that we need to include users in decisions for them to be more engaged and have a better results. There is no matter of discussion. And there I leave some references I found about systematic reviews on the patient engagement effectiveness. Of course, it's variable in every setting, but it's clear that there's a positive effect that hopefully could be explained better in the future on what are the critical factors to make it happen. And again, it's something that it's somehow all news for the world. And finally, on the right, you'll see that probably, I don't know if he might be the guy presenting this, because CAHO created a report that was recently launched on the critical factors for patient engagement in India. So probably not the one that I should share this with you, but you have the evidence, you have your own reports adapted for the culture of India. So my sense is that there's not much need to describe why we should be doing this. And how we should conduct patient engagement. I like to use references in whatever I say. So this is a paper from 2012. Okay, so again, all news. And here I just mentioning for your reference later, I understand that slides will be available to you, just 3 tables that describes the domains of patient engagement. One is health literacy, how we can help patients and families to understand what is the process of care. The other one is shared decision-making, because if we don't help patients and families to contribute to decisions, things will continue the same. And finally, there are a number of interventions that helps, again, the process of care to be improved, because we are one of the few industries where process of cares are not designed with consumers. And that's, again, curious. So we have literacy, health literacy, this is shared decision-making, and different process of care. But this is from 2012, and this has been the guide for patient engagement for many years. but things changed. And how they change? Because now we talk about co-production and co-design of healthcare. So for that, you may have heard from Peter Lackman. I don't know if he made it to the room yet. So co-design is a phase where users, before deploying services, they work in trying to understand and trying to contribute to the process itself. And this came from something called Design Council. Design Council are engineers. They're people that work in design of services and products. And that's the double diamond of design that I leave you as a reference. And on the right side of the screen, you will find one of the conceptual papers from Paul Batalden, which is one of the inspirers. You just celebrated Duran 2 days ago, when Batalden is maybe more recent in time, but he's one of the key people in quality of care around the world. And he developed this framework for co-production and co-design. So recapping, the evidence is there. We need to work on health deterrence interventions. We need to work on shared decision-making, and we need to engage patients and families in process design. And I will give an example at the end of my presentation. And here we have the concept of co-production and co-design with their current frameworks. And also Peter mentioned to you yesterday, and I want to revisit that concept, is that, you know, of course, every health system is doing the best they can, and probably we're all facing in different phases. So we're all facing at different speed, but you have quality 1.0, which is based on inspection, which is, of course, had made a lot of contributions. Then you try to work on reliability, how to make the process stable and have less defects. That's 2.0. And finally, you have co-production of health. So you will see more and more that patients and users are more engaged, are more involved in the design phase, and that's 3.0 for the moment. Eventually, there might be a 4.0. But this is where we all should aim. And it doesn't matter that we're still in phase 1.0, but we need to transition in engaging more patients and families. And this is another resource that you have in your slides that came from another service design company in the UK that's called the co-production ladder. So up in the ladder, you have the ambition that we're all looking for. But look, this is, you can see there in what stage you may perceive yourself. Care done to me, you're just a passive actor. Care done for me, you're somehow start to engage the patients, but the last steps of the ladder are nothing without me. So these stages of coercion, education, informing, consultation, engagement are phases that probably represents what we are now, and eventually we'll get to the co-design and co-production phases. So again, I'm just leaving you these references for your consultation afterwards, but you have your own resources from CAHO now. So it seems that you are on the right track. So just getting to the end of my first section of presentation, we need to think differently about quality of care in general. And this is a framework that was created by Margaret Crook from, in that moment, at the School of Public Health in Boston, in Harvard. And she created this framework describing that health is the most important output of the health system to be hopefully achieved. And that's the aim for quality of care. We need to improve health. Then we need to improve confidence in the system. So users and families have to have trust in the system, and that's the confidence built by satisfaction, recommendation, trust, and care uptake. And the trust piece is very important. You will define the health system by the trust the users have for it. So there you have the critical point of having a clear understanding on how people see their own health systems, and probably how that's related to the engagement they have had. And finally, economic benefits. because bad health systems impoverish societies. And that's a critical point to have in the future. So finally, short story. I came from Argentina, the other side of the world for you. And there's a province called Mendoza where the wine is produced. So if you see wine from Argentina, it's produced there in Mendoza. And we are doing now a clinical trial back at where I work in the Institute for Clinical Effectiveness, where we're trying to redesign care for diabetes. So you see there that we're trying to co-design with providers, decision makers, but mostly patients, how the care model should be to improve the adoption of evidence-based interventions for diabetes. So this is a good example on how we're just trying to translate the evidence and the theory to practice. So that's another example for you to have. So finally, that's a picture of a house in Austria, in Salzburg, where this concept of nothing about me without me, that is the motto for engagement, was created in 1998. So we have been trying for almost 30 years to change the way we deliver care, having the users with us engaged. But keep that in mind, and I believe it's a good summary on how engagement should be defined. So with that, I have tried to talk about what is engagement, why engagement should be used as an intervention to improve healthcare. We have visited some of the big domains of engagement, shared decision-making, health literacy, and interventions to design care. We have went to the concept of co-production and co-design. I gave an example from work that we're doing back at home, and then summarizing my intervention with this phrase, nothing about me without me. With that, I end my presentation. I have one more thing to say, and there you have my email in case you need to reach out for me. Thank you. So I need to do something with you for people around India and the world, and it's to share something that ISQA recently produced, led by an Indian fellow colleague from ISQA. So I invite the stage to Dr. Anu Pichumani. We're good? Yeah. So, Dr. Anu Pichumani and Dr. Sinu Shira, that I also invite to the stage, are part of the authors of a report on how to make patient safety more impactful in different settings. We have the action plan from WHO, but some experts from ISQA have tried to work together in creating a new contribution to the cause of patient safety, what is so dear to CAHO. So us, the ISQA people, plus, well, BK also a member of ISQA and our facilitator, would like to give CAHO a copy of the report. So I invite, if you're here, Dr. Vijay Agarwal. Okay, thank you so much. I don't know Dr. Lalo Joseph is with us yet. No. Okay, she might be elsewhere. She's doing a lot. So Dr. Vijay will represent CAHO. And so good morning. You look great as usual. Well, thanks again. Thank you. So this report is available on the website of ISQA for you to download and to hopefully use in your settings. More pictures, okay. I never thought I was going to be in so many pictures as Jeffrey, but it's no, it's not a competition. There's no chance. Thank you so much. Well, thank you very much. Well, if we're good with time. We did very well. Thank you.
There's just one question to you, and we didn't get started on the panel. We're talking about patient engagement, and we talked about global perspective. Here we have a situation where the ratios between the nurses and patient, doctors and patients is very less. I believe that doctors, say in the West, may see 10, 12 patients. In here, we have 60 patients. How do they engage? So the model and standards have to be different.
It's not possible. The ratios in more resource settings from nurses to patients is 1 to 6 in the floor, 1 to 2 in ICU. So it's very difficult. I hope that at least it can provide basic care for those 60 patients of shift. It's,
So I think between CAHO
but
and
sorry, but one thing, engagement is not only for hospitals. Remember that most of the care is being given at the primary care settings, and there hopefully ratios are a little bit better.
so I think we try to find our local solution. So between CAHO and Patient for Patient Safety, now we are creating 4-5 minute videos where if the doctor doesn't have time to explain the procedure, the risks, right? At least they will be able to see the video. So I think we have to find ways and means of, we can't increase the doctor suddenly. So we have to find ways and means of saving time of the healthcare professionals so that they are not stressed and we can find technology to use it. And I hope they can. Can you all please move forward, because it'll be nice if you're all here up front. Yeah, sorry.
But no, but adding to that, of course, what's happening is that patient care should not be centralized in physicians or even nurses. It could be also delivered by social care workers, by the different professions around healthcare that they are more trained to to engage people and to deliver simple interventions that hopefully will help people to. There are 3 questions. I don't remember them all now, but if you look for this, nothing with about me without me, it's called the Ask Me 3 questions. 3 questions that every patient should ask to the health provider. So that's 3 questions could be an example, a very simple intervention that could be used.
Thank you.
Thank you.
Thank you, Ezekiel. As always, a wonderful, terrific presentation. And I want to make use of this opportunity of your presence in person. We talk about co-production, co-creation, and there are several stakeholders involved. But to my study, what we have done is that very few participate in that. So what, in your opinion, are the key stakeholders who really actively contribute to co-design and co-creation activities?
Well, first, people like him, because you're finding ways to tell people that they can really be engaged and participate. Then, as usually, whenever we're facing change, we need opinion leaders that share with peers that it's possible. This works and this is important. But I have the sense that all should be, I would say, working in an ecosystem cultural ecosystem where people are not afraid to speak up and to be engaged. Because there's another concept I haven't mentioned, which is how is to be an activated patient. Activation, it's another well-known concept that describes that activated patients do better. So we need to share with people that if they are activated, they will do better in the care. So hopefully that message.
Yeah,
arrives.
thanks so much,
Thank you
Khalid.
so much.
Thanks, Ezekiel. Thank you.
Can we have the rest of the panel on, please?
Yes, you can.
Thank you so much, sir.
Can be here.
That's right.
We would request the moderators to stay back and
The session continues. May I invite on stage Dr. Charu Singh, Professor and HOD Pain and Palliative Medicine, Amrita Institute of Medical Science and Research Center, Dr. Jeet Patwari, Managing Partner, Pinnacle Healthcare Consultants, Zonal Chairman, CAHO East Zone.
Ms. Sheetal Agarwal, Founder and Director, Counselors Foundation, Dr. Malati Murugesan, ID Consultant and HIC Officer, Meenakshi Super Specialty Hospital, Madurai.
People were with you? The people that were talking, they were with you? No. No. So thank you very much for all of you here. Thank you, CAHO, for giving patients the platform, right? I think you mentioned about nothing about me without me, and here we are. But you know what? You are a doctor, but not a doctor. But there are here 3 doctors here. But actually today, they are not in their capacity as doctors. We have a very unique situation. We have 3 doctors who are patients and another person who is a healer, right? So they're all attending to doctors. But today, they're going to be speaking in their capacity as a patient. And they're going to share 2 things. That during their healthcare, when they went through their journey in a hospital, how could they prevent harm? Because they knew. Because they were doctors, they knew and they could stop and prevent harm. And the other they're going to share with you is that in spite of their knowing and their warning and cautioning the healthcare provider that a potential harm is happening, it still happened. And I think this is a learning for all of us today because you relate to it. All of us are only in one of the three categories: patient, would-be patient, or a caregiver. And in all those three, it's very important for us to hear their stories. And thank you very much for being so open. We had this discussion yesterday. I was really touched that you were willing to share. So could I start with you, with your story? You have a mic next to you. I'm sorry we have given less time to all of you. So try and do it in 5 minutes and then we'll have another discussion. Thanks.
Thank you so much, sir, for this honor of being here in this panel. Yeah, so I have spent 54 years being Charu. I have spent about 35 years being a doctor, but I have spent half of my life being a patient. And I want to say this is all my episodes happened in accredited hospitals. My first encounter with healthcare happened when I was 26 years old, and I underwent a diagnostic ERCP and ended up with pancreatitis. And it was because I was a second year MD student and I had my medicine well. I was able to diagnose most of my symptoms. Only 1% of patients survive pancreatitis. And I think I am sitting here because I would tell the doctors that I'm having perioral numbness and please check my calcium, or I'm having a catch when I'm breathing. So there is probably a pleural effusion. Please get an X-ray chest. And I was treated very condescendingly. I was not given analgesics. I was told the doctors make very bad patients. I was told, be a patient, don't be a doctor. And and I think I survived only because I was giving them symptoms much before they would become signs or they would get investigated. So, and the last 26 years, I've had multiple hospitalizations because of intestinal obstruction. And I'm going through nutritional deficiencies and my quality of life is completely shattered. I can't wear a sari because I can't stand long enough to wear it. I can't wear heels because I lose my balance. I have fogging of memory because of the medications I have to take to suppress my pain. And I'm still judged.
And were there instances that you tried to convey and they didn't listen?
Oh, yes, all the time. My father had to run I used to get one single injection for pain the whole day. Now I think everyone knows pancreatitis is a severely painful condition and you need round-the-clock analgesics. My father had to go and the doctor told him that your daughter is acting. She's doing a drama, that she's in pain. This was told to my dad. And every night, my father had to run to find a senior resident to get me painkillers. So, but this was not the only situation. I've been into the ICU 3 times. And there was a situation where I had episodic pain. And I was not given painkillers again. 26 years after my first encounter with pain, I was still not given pain medicines. And when I got upset, they gave me a patch. Patches are becoming very popular, but I'm a pain physician. And my 15-year-old son came in the next day and he told my husband that, Dad, you need to call a neurologist. Mom's hands are very clumsy and she's slurring. And then it suddenly struck me that I've got a patch on. So in an accredited hospital, there was no handover by the doctors or by the nursing staff that I had a patch on. And I could have ended up with respiratory depression. My respiratory rate was 10, I believe, that night.
It takes a lot of courage for somebody to come and speak up. And this happens to be Dr. Give her a big hand. Thank you.
Thank you so much. This is the first time I'm sharing my story with a crowd here. And trust me, this morning I was a little emotional and teary-eyed. And I think my fellow panelists.
You make us as well. Jeet.
Thank you, sir. Myself, Jeet, I'm here not as a doctor, but as a patient. I'm going to share my experience. I already have had undergone 2 major surgeries, one for my cardiac problem and another for my L5S1 spine. When it comes to the patient engagement, we speak volumes about, we have to engage patient, we have to do that, this, do that. But when it comes to the practical part, that is where we have, I think there is a big difference or gap. Because when I go to a hospital as a patient, I never introduce myself as a doctor. It's Jeet Patwari, what I write. Because number one is I don't want to take that undue advantage, or maybe I don't want them to know that I'm a doctor, so that they are more cautious. So the first thing that comes is the consent signing. I'll tell you about my experience. I was given the form, 2 languages, one in English and Hindi, but I was never explained that these are the things. यहाँ पे sign कीजिएगा. I signed. I was admitted in the IPD and I was wearing a full sleeve pullover. 2 young nurses came to collect sample. And I asked, what do you want to do? They said, they showed me the vacutainers. They didn't even have time to, explain. So, and they said, pull up your sleeve. I did. And instead of a tourniquet, they tied a glove, hand gloves here. I did not want to interrupt, just wanted to see what they were planning to do. And they were trying to find the antecubital vein here. They could not. I could see the needle going inside, coming out again, going inside. No blood was there. And finally, they did a double puncture and there was a hematoma. And that was enough, I said. I said, ma'am, why don't you try on my other hand or call somebody else? Get a proper tourniquet and then tie it up properly, check the antecubital vein and then collect the blood. They said, okay, sir. And somebody came. Again, tourniquet was tied. They did not, I asked, for what do you want to collect the blood sample? They said, we want to do some tests. They did not have the patience to, the previous day I had my CBC done, the LFT done, my renal function tests done. They drew the sample, they did not explain. They drew the sample again, they took the sample again on the second day, I'm in the hospital, and my tests were done. So there was a repetition on this. Now, my question was, why do I have to donate blood twice? And I'm sure there are instances where, people are exposed to, unnecessary radiations in the form of X-rays and CT scans and those things. So I feel that right now also we are, going to share our experiences, but I think that this should not be confined to the 4 walls here. People who are involved, I teach quality in many institutes, and few of my students from IIM Shillong are here. We had detailed discussions on this, but I feel that I, as a patient, I have felt or experienced what we teach and what we actually follow in the hospital. There's a big gap. We talk about NABH, the full accreditation, we talk about JCI, people from ISCO are also here, my respected seniors are also here. But I think there's a big gap in this, and that is where I think we should focus on. So at the end of the day, we are working for the patient.
Thank you so much. Thank you. And I think this is a great point that made. I believe that in India, the attrition rate in hospitals could be anywhere upwards of 30%. So when we have an accreditation process, everybody is very alert. They are taught about accreditation and what to do. But then newer people are always coming. They're not ingrained in the culture. So this is a constant journey. It's not a one-time accreditation or not a one-time audit that we go through.
By the way, this was done in one of the best hospitals in the country, located here in Delhi NCR, and NABH full accredited under JCI hospital. JCI was, they got the accreditation later, but when I was admitted, it was NABH full accredited hospital.
Thank you. Malti, can we shift over to you? You're far away there, but share your experience and.
Hello, everyone. So as everyone said, like I'm here as a patient. I'm a known case of Crohn's disease. I'm on triple immunosuppressive therapy currently. I don't know whether you believe, maybe you will think that I'm looking slim and thin now. I was 35 kg before 1.5 years, but actually I'm gaining weight. So when people look at me and say, you're thin, actually I say, I'm gaining weight and I'm happy now. So, but what went wrong? We are all here to talk about a patient point of view. What went wrong? Every time when I visited the clinician, that something is wrong in my body. As a patient, he or she who owns the body will know something is wrong. It's been 8 years. Every time when I visited the emergency department, the gastro department, I was telling that something is wrong, wrong, wrong. But every time I was told it's normal. Everything is normal. Your blood investigations is normal. Your imaging is normal. You look normal. You come to duty. You're working normal. So please go back. It's nothing wrong. And every time I was loaded with a lot of morphines, a lot of sedatives. And after some point, they said, go to a psychiatrist. They said, you are an anxious person. You are hyperactive. So you're thinking too much. That's why you're not coming and accepting that you are perfect. So as I was put upon antidepressive, I was put upon anti-anxiety drugs. And after some time, when I ended up in the emergency department for laparotomy, where I have lost now my 2 feet of my gut, then they accepted. So at the point in the ED, I asked my consultant, you never believed me. I said something was wrong. So as a patient, I request all the healthcare professionals here, always please listen to your patients. We know something is wrong. Yes, maybe some investigations may show normal, but you have to believe in your patients. We have been told from childhood that we don't lie to doctors, we don't lie to lawyers. So a patient will never lie to a doctor. So that's the major problem. If I would have been diagnosed 8 years before, I wouldn't have landed up in surgery. So that's the take-home message I wanted to convey to every healthcare worker here. Please listen to your patients so that we can avoid major complications. If I have time, another major point, I was in ICU for 60 days. I was in hospital for 3 months and I was in deathbed. But I wanted to get the word from my consultant, whom I believed a lot. Every day I wanted to see him, at least once in 2 days. When I begged to see him, I could never see him because if I see him, I feel like I'm seeing a God who tells me whether I will live or not. So the opportunity to see whom you want, which consultant you want. As a patient, I have the rights. I want to see this person. A junior comes and says that you're okay. I don't believe that's a patient point. Yes, I'm a healthcare worker. I know that something is wrong or bad or good, but I want to have the belief and confidence to survive back. The same for caregivers. Please ask the doctor to talk to the caregivers. My mom and dad was crying. My twin boys came and they cried seeing me in the deathbed. If the doctor would have assured my mom, dad, and my twin kids, they would have been satisfied. So that assured, I know we can't assure 100%, but the conversation should go beyond, which is being neglected, especially if you're doctors. The presumption that we know everything and the lack of communication is a major problem for us, especially those with chronic disease. So that's the message I wanted to share.
Thank you. Thank you so much for sharing this. And I think this is a great segue, right? You mentioned about empathy that, you would have loved if the doctors and the nurses there had come and spoken and given comfort to your parents. And I think empathy is a very important thing. And I think, Sheetal, that's a very good segue for you to come in. She's not a doctor, but what she does is healing. And she has her own way and she runs this nice company. And you talk about it very briefly and then talk about what's the impact that you have seen.
Hi, good morning. So it's a non-profit that I run. It's called Counselors Foundation. The therapy we do is called medical clowning.
Can you put it up a little up?
So the first thing, let's start with a simple truth. Patients are not just cases. They are simple humans who are extremely afraid and in a deep need of connection. So the first thing when a patient enters a hospital, the first thing they lose is a smile. How many of us actually see a patient smiling? So when as a medical clown, I walk into a hospital and in wards, I don't walk in with a stethoscope, but with a red nose. If any of you have seen a clown, this nose is our smallest mask. And how does it help? Why does it matter when we talk about patient safety or patient-centric care? What does that mean? Why is it important to bring patient to the center? Because healing is not just emotional well-being. Healing is not just physical recovery, but also emotional well-being. It is a mind-body connection. And if I have to share, so we've been doing clowning for 8 years now. And we have had so many experiences where we've seen healing happen. So every Saturday we visit this hospital called Chacha Nehru Bal Chikitsalaya, where there was this young girl who we were told that she will not survive. She had multiple failures, and one thing that stayed constant while her health was deteriorating was that she was always asking for the clown, and she wanted us to dance on a Salman Khan song. So if you remember that Tal step, so that is one step that she wanted all of us to do. So there came a time when she could not even move. She would only blink, and all the clowns had to be around her bed dancing for her. After 3 months, she actually went back healed, and she walked out of the hospital. This is the same person who we were told will not survive. Did clowning heal her? Definitely not. But it gave her strength and something to look forward to every week. And that helped her fight with the disease. Why does this matter? Why should we look at emotional well-being or about this whole healing? Because like Sir mentioned, it is about empathy. We are dealing with people here. So if we keep looking at the disease and if we keep treating the disease, we are missing out the person. But the moment we start looking at the person, the healing will happen. How? Because when a person is feeling emotionally safe, like even when ma'am was sharing that nobody was listening to her despite being a doctor, or both the doctors when they were sharing, there is this sense that we are not in control of the situation, and we are constantly feeling that there is kind of a distrust that happens. But the moment we start feeling emotionally safe in a hospital, trust starts building. Cooperation will happen better. And then the body will respond better, simply because of mind-body connection. And that's where medical clowning meets patient safety. And as a medical clown, when we enter a hospital ward, we give control to the patient. So it's up to them whether they want to engage with us, they want to just watch, they want to laugh. And we kind of try to match their energy. We don't try and perform for them. We don't say, hey, look at us. So a simple act like this. Hi, sorry, I'll use you again. Hi. 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 Oh, hi. 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 So something as simple as this. But it is actually giving the patient the control to what they want to do. If they don't want to play with us, they will not play with us. So for those of you who do not know what medical clowning is, it's a therapy wherein we dress up as clowns, just the wig and the nose. We have some puppets, we do some storytelling, and we try and engage with each patient one-on-one for 3 to 4 minutes. The idea is that they should heal, they should start smiling, and they feel better. And for a little moment, they gain control of how they want to feel. When we talk about healing, it's a holistic approach. We are not just saying that there should be medical clowning, but arts therapy, music therapy, sound healing, any of these therapies could come in. So now we have also started training medical professionals into these approaches, which ensure that empathy is embedded in the healthcare system. So it is not just looked at as an add-on process, people coming in and doing it. So it's not just a business for us, but people who are inside the system are actually focusing on the human. When they enter and start doing the procedures, they smile and they speak to them. And that would change something in the healthcare system itself. So in the end, I would just want to say that when we are giving out prescription, can we also give prescription for doses of laughter? And as a reminder, and laughter always acts as a reminder that healing is possible. So for me, my hemoglobin for 30 years was 9.5. No amount of beetroot juice, carrot juice helped. At 30, I started clowning. And now my hemoglobin is 14 or 15. It has not gone down. So that's the power of laughter.
Thank you, Sheetal. I think when you, all of you as healthcare providers, when you now see a doctor, think of her, smile, remember the red nose, and I think you would be, your emotions will be very positive. I have a question to the three of you, not to you, Sheetal. You've been doctors, you're also patients. Every person in the hospital actually wants to serve, right? The nurse comes in to serve, the doctor comes in. What holds back? What holds back the engagement? And anything else that you wanted to add?
I'd like to use Dr. Ezekiel's presentation that it is patient engagement and nothing about me without me. And yes, Mr. Mittal, you had mentioned that doctors don't have enough time. And I would like to again point this presentation that there is a team. You can utilize that. Psychologists, social workers, dietitians, and doctors. But being doctors does not stop us from being a psychologist or a social worker or a dietitian. And we have to be open to learning everything every day. And I think a positive regard for your patient. He may know more than you. Because yesterday when we were planning the session, I learned a couple of things from Mr. Mittal about MRI. I wish you would share that. So that was a learning experience for me. Please be open, listen to your patients. They may know more. Empathy is very important. I think teamwork is supremely important. And it is all about the patient, isn't it? So it's
Last
a
5 minutes.
patient-centric treatment that we are supposed to be giving.
I would request this is the last
Thank you
5
so much.
minutes.
Yeah.
I feel there are three factors which can be considered. In our medical college, we were taught about anatomy, physiology, biochemistry, medicine, surgery. We were never taught about, how to deal with the patient. What we learned is what we saw from our seniors. Number one. Number two is the attitude which we as clinicians have. Maybe we do not want to spend too much time with the patient at times. Number three is, and maybe especially in the government hospitals across the country in India, we have huge patient load. A few of my seniors, they have to, attend to somewhere around 60, 70 patients within a span of few hours. There's no time for, to explain what is there. Also, it depends on the attitude. And for the nurses also, this is something which I have felt personally. Because the shortage of nurses maybe, or maybe because of the training and the other things which are imparted to people. We were never taught about this. Now that this NABH and the accreditation and all those things have come, we have got the further figure of quality. Geda Gyani sir, Tupil sir, and other people are here. I think that the wave that has been created in the last 2 decades, it has changed. But I come from a tier 2 city. We still have the same kind of, except for Guwahati, which has got the largest number of big hospitals and accredited hospitals. The other cities are still lacking. There's nothing, we still follow that conventional kind of practice.
Well, we can just briefly mention.
So with regards to chronic disease, engagement of patients is more vital than any other acute disease. So right from the planning of therapy, where we have multiple options of drugs, the patient should be engaged in choosing the right drug with why this drug, is there any alternate options, what are side effects, because they're going to take the drug for quite a long period, maybe till death. So patient engagement starts from the treatment planning. And follow-up is a major problem in chronic diseases. Patients, once they feel like I'm feeling normal now, I may not go back to my consultant. How to engage the patient? Who is going to contact? So like we have somebody called IBD nurse. They call me every Thursday. So that's the way the nurse engages me and reminds me that whether I'm okay, I'm taking drugs. So that's how we can engage from the hospital point of view. Otherwise, in the disease schedule, we forget everything if we are normal and happy. So that's most important for chronic diseases to engage.
Thank you very much. Yeah, there was this whole question on time.
No, just want you to, thanks again for presentation and contributions. I'd just like to mention that, after my colleague question about what we can do, I have the sense that we need to let go the intention that care is only provided by one person, either a physician, nurse, or social worker, or whoever. We're a team. And we are also teams inside health systems. So as time went by, I still practice. I try to tell the people that trust me as patients that not being cared by me, they're being cared by a system. So engagement will do better whenever we don't rely on one people, but on a system of people or teams. Hopefully that happens. That's one thing. So and also volunteers, as you were saying, that people that are not probably trained as clinical providers, but they do a lot in different ways inside care facilities. And just to mention, I look for this simple intervention about engagement, which this ask me these 3 questions. I don't know, are these in the report? Are these in the real report? They asked me 3? Okay, well, so read his report, okay? The CAHOCON report of patient engagement has these 3 questions that should be asked every time we see a healthcare provider to understand better what's happening to any of us.
Thank you. And since you mentioned it, I went for an MRI myself about 6 months back, and I was very tired running around and I'd come empty stomach, and I was feeling very thirsty. So I asked the technician, "Can you get me a glass of water?" And he said, "Sorry, you can't drink water." But I said, "I'm parched." So he said, "Okay, take a sip. It'll wet your lips, but don't drink it." And I asked him, I said, "I've never heard of not having water." He said, "Sir, we're doing your MRI and I have soft tissues. The imaging will get affected if you drink water because the water molecules affect." And that was knowledge for me, right? And hence, I think this technician engaged with me, asked me, when I asked a question, he didn't say, "Google pad ke aaya hai, kya hai," he actually answered, and I'm educated, not that education, I don't have to get the MRI again. So this has been a great session. It's never enough to hear patients' voice, and I think that's it. But I'm going to ask Dr. Rana to do the tough job of summarizing what we could pick up.
Thank you. Thank you, Somsa. Thank you, everyone. Thank you, Educal, for your presentation and all. Thank you. Actually, thank you, all of you who are here in the early morning to be with us. And there are several stories similar to them. But the thing is, are we learning from them? We keep talking, and I'm very blunt on that. I'm sorry to say that. We can continue talking for decades, and we have been talking for decades in the last several years. Anything changed? Yes, things change, no doubt about it, but those changes are in tune with what we supposed to have those changes in place. And it's very difficult, as you said, sir, to summarize what, but I think it's my job at the moment is to really, acknowledge your contribution, not only for yourself, your family, but the whole of the society, which are looking for the volunteers like you to come forward and share your stories. So I would like to briefly say some of the points as takeaways. And it's up to you whether you take it or you leave it here. It's entirely in your hands. So first thing, listen to your patients. And that is missing. And I have been patient many times, and I have not that severe, but close to that. So please listen to your patients. Whatever they say, don't think they are saying something nonsense. Maybe for a healthcare professional, they sounds me something nonsense, but not for them, not for us as a patient. When we call a nurse, "Hey, I'm having pain." "Oh no, it's happened. It's usual in this type of problem." Maybe different, maybe something else. And we had a very good discussions. We are not able to produce everything here in this short time, but those are the things which we need to consider. And again, I think we have been talking about patient-centric care, but do we realize what is patient-centric care? Patient-centric care means what we shifted from a disease treatment to a person-centric care. So person-centric care or people-centric care means the patient in the center, the family around, and the community around. It's not just patient, because many times patient is not in a situation to listen to your comments. The family does. So we need to engage with the family as well to really provide the patient-centric care. And empathy has absolutely come forward. Empathy is need to be embedded in our healthcare delivery systems. And also, what we talk about is that many times we feel these are normal things for your as a healthcare worker, as a doctor, physician, nurses, or whatever it is, because you are doing the same job, maybe with different people, correct? So you think it's my another day. But think about the patient. For them, it's the only day. And they are different. Every time they are different. And you should not think, oh, I have been collecting blood for last 20 years. Maybe I'm not having that much of blood in my body, like you said, multipunctures, you know. So I think these are the things which we need to look at. So we are talking about patient safety, how we engage with patients in the better care and the safer care of the patients. And if you remember what WHO DG, Dr. Tedros mentioned a few years ago, is if it is not safe, it is not a care. It's a very powerful statement. If it is not safe, it is not care. And I think time has come, we have to start, act now, not tomorrow or day after tomorrow. We have to start from now. And I would urge every one of you to have a commitment before you leave this hall that yes, we would work all together, committed together for making life of the patient more safe. Thank you very much.
Thank you so much, sir. We would request the moderators to please wrap up this session as we have to run into another one. Can I request all the moderators and speakers to please assemble for a group photo? And can I have the photographer as well? Thank you, Dr. Ezekiel. Thank you, moderators. Thank you, speakers. I would request Dr. Som Mittal to please stay back. So I think the new definition for democracy in a hospital is to the patient, of the patient, for the patient. That's how I would like to summarize this session. And before we go into our next session, we have a quick launch of what Mr. Som mentioned, is the launch of a patient consent education material, which is done in 7 languages. For this, I'd like to invite the lead, Dr. Adil Khan and his team. Dr. Adil represents Tulu Health, which is an initiative of Patient for Patient Safety Foundation by CAHO. Request Dr. Adil.
Before that, may I request the audience to greet each other, because Sheetal was mentioning that each person needs 8 hugs a day to feel good. So either you hug each other, the person sitting next to you, or at least greet each other. Audience?
Can we have everybody just stand up and probably give a warm handshake to the person next to you? Or if you're still afraid of
Welcome
COVID,
to the nonprofit digital patient consent and patient education platform, a collaboration between CAHO and Patients for Patient Safety Foundation, powered by Tulu Health, India's first AI.
Dr. Adil LT. Thank you, Mr.
We
Sok, for
understand
facing this
preparing
stage.
for surgery can be overwhelming at times. Obtaining informed consent is crucial for every procedure. It protects both patients and healthcare providers. To help you feel more confident, we provide consent forms along with educational materials to keep you informed of every step in your own language. It's about empowering patients to understand their care, treatments, and options. Our platform simplifies this process, combining education and consent into one seamless, patient-friendly experience. Patient can simply find a procedure they are undergoing and download the consent form either in text or audio format for free. We offer patients tailored educational materials about their procedure or treatment in the form of videos, infographics, and easy-to-read documents in their language of choice. Healthcare providers can find consent forms for any medical interventions like blood transfusions, invasive procedures, and even certain high-risk treatments like chemotherapy on this platform in multiple languages, starting with English, Hindi, Marathi, Kannada, and Telugu for free. On top of that, we also have the latest version of the standard operating procedure for creating consent forms, which was prepared by the Institute of Medicine and Law. Using CAHO's digital consent and patient education platform will ensure that every patient is fully informed, reducing risks and improving compliance.
But here are ready-made videos that are here. So instead of spending the time, I think you have infographics, videos that will be on the websites of CAHO. Everybody can access it. Hospitals can download it. So you don't have to spend time to do it. And I just heard these gentlemen talking about that these videos and text is going to be produced in various languages.
Yeah, so we have just made sure that anybody, even without proper health literacy, can actually access this consent form, because that's the biggest pain point. Patients tend to sign those consent forms without any knowledge what's written in those consent forms. As a result, there's misinformed decision makings and even end up leading to medical legal cases against doctors. So our consent forms are not just in multiple languages, but on top of it, they're also in video formats, so that patient can actually just listen and see without even literacy to even read it. So we are making sure that patient makes an informed decision. We are empowering them, and at the same time, we are making sure that doctors are safe and reducing the medical legal risk. I hope you all use it. It's a free solution available on CAHO's website. You can find the link, and looking forward to your feedback. Thank you.
It has got three parts in it. One is your about the disease in a descriptive way. Then there is one which is in a form of pictures, which the patient, anybody can understand. And then we have the consent form and a small video link, which the patient can see. That's the four parts of it. Thank you.
Thank you, Tulu Health. Thank you, Swam sir. With this, we proceed to session 11.
For our next session on collaborative research to enhance quality and patient safety, please join me in welcoming our moderators, Dr. Rahul Deshmukh, Medical Director and HOD Anesthesiology, Medcare Orthopedics and Spine Hospital, Dubai, UAE, and Dr. Pratish Ravindran, HOD and Professor Neurosurgery, Deputy Medical Superintendent, Super Specialty Services, Mahatma Gandhi Medical College and Research Institute, Puducherry.
Along with this, the topic is collaborative research for enhanced quality and patient safety. I'd like to invite the moderators, Dr. Dato Ravindran Jagasathi, Counselor and Chief Surveyor, MSQH, Professor Satish Chandra, Professor, College of Medicine, Regional Director, Medical Research, Johns Hopkins Medicine, and Counselor Seha, Middle East. Dr. Joseph John, Professor and Head, Department of Clinical Hematology and Bone Marrow Stem Cell Transplantation from CMC Ludhiana. And Dr. Chinmay Shah, Professor and Head, Department of Physiology and Additional Medical Superintendent, Government Medical College and Sir T Hospital, Bhavnagar, Gujarat. Moderators, stage is all yours. And please keep a watch on time. We have 40 minutes for the session.
Good morning. Firstly, thank you to CAHO for giving us this opportunity to share our thoughts on collaborative research. Because this, I believe, and I'm sure the entire team believes, that this is the need of the hour now. We are dealing with increasingly complex healthcare city or healthcare situation and with limited resources. Day by day, the resources available for healthcare and for research are shrinking. And hence it is very important to join hands, not only amongst ourselves, but with academia, with industry, and come up with how do we make our patients more safe. Obviously, we spoke about patients for patient safety. This is next step of that, to come up with more research, not only in the field of pharma, but also in fields of healthcare quality and patient safety. And that's the aim. That's the aim of this session as well. We will be sharing, obviously the panelists will be sharing their views on collaborative research. How does one go about it? And what has CAHO done so far, and what are the further steps for collaborative research? Thank you.
So good morning, everyone, and welcome to the session. As Dr. Rahul explained, now we all as hospitals and in healthcare workers and the entire, all the healthcare professionals involved in quality and safety, we do a lot of things through the day and night, which is impacting patient quality and safety. But then when you look at the larger picture to actually get the things implemented, we have to go about it in a little methodological. The methodology has to be proper. And when we talk about research as a word to healthcare professions and all that, even amongst clinicians, it is something which is a little uncomfortable because it's a wide field and there is a lot into it. But there is a little bit of difference and quite a bit of a difference between the kind of, although the basics are the same kind of research we talk about, which is related to patient care and about quality and safety. So there's a difference. So now our aim through this discussion would be to make things a little easier for you to, so that you get a kind of a view from the top as to what does research actually mean in with respect to quality and safety. And specifically when you have not just clinicians or nurses, then there are so many professions who are dealing with patient care. How do each of these verticals and how do so many professionals collaborate with each other? Because that is the future and that's how we are going to actually improve and have a major impact on patient care. So with that, I'd like to give back to Dr. Rahul.
Dr. Ravindran, if I may come to you. Obviously, you are an obstetrician and a very veteran, well-known veteran from the industry. Can you tell us how better can collaboration be done with the academia, with other research institutes, and of course, among the healthcare professionals themselves?
Thank you. I will use my experience as an obstetrician and gynecologist who became involved in quality work. And I'm also now the chair of the International Advisory Committee for the CAHO. And I have some fair idea of what is going on here. And I think I will start off with just the previous session, right? Where the patients spoke of their experience. That is already now evidence-based, as presented by Dr. Ezekiel in the previous session, that patients' experiences and involvement of them in the care does contribute to better care. So now is the matter of operationalizing what you have heard to your daily practice. And also I heard many sentiments being expressed. Accreditation cannot be the answer to everything. But I think it forms the base from which you improve. And you find that as accreditation standards evolve, they involve viewpoints from many sectors to develop the standards. And patient involvement is also now part of many standards of various accrediting bodies. And at least you have that in place, then you improve on it in future. And I think basically, I will use one Malaysian example, where patient engagement was started about, I think, 20 years ago, when in a similar conference like this in Malaysia, there was a patient who came up to the stage and spoke to the conference about what happened to her. And there was a powerful message that was delivered. And slowly, patients became involved, and it became a regulatory requirement that patients must be involved in boards of the hospital. And that became part of the accreditation standards of that country. So that is how the evidence became translated into practice. And similarly, I am part of an involvement of the confidential inquiry into maternal deaths in Malaysia. So at one time, we had about 300 to 350 deaths of mothers in a year. Now it is down to about 200 to 250 mothers who die out of about 500,000 deliveries in a year in the country. But there is an anonymized investigation of every death, whether in the private sector or whether it's in the government sector, where all factors are revealed. And from there, various steps are taken. For example, in one case, there was a mother with a triplet pregnancy who came, had an emergency cesarean section, and she died, and the 3 babies died. All right, and that the reason was acid aspiration syndrome, because at that time there was no protocol for acid aspiration prophylaxis. But as a result of this case, it became a national protocol that it must be started. And now it is commonplace everywhere. I'm talking of an incident that happened about 20 or 25 years ago. And now it is standard practice. Similarly, there are many, many things that become involved, changed over time. So I think in the interest of time, I will stop there for further discussion. But basically, the message I'm getting across is that you have to look at your context in India. And I think CAHO has got this vision to reduce medical errors. And I think it can be done, but it is going to be a slow process with involvement of everyone, including the patients. And that movement has already started. So I'm glad to see part of it.
Thank you, sir. So what I understand, you're telling us that, based on the experiences of the thing, based on the context, generate the evidence, and then build up on it to actually lead it to practice.
Yes.
All right. Thank you so much, sir. So my question would to Dr. Joseph John would be, as a clinician, as a hematologist, and when we take that set of cohort of patients into view, there are a lot of patient safety implications. So just as a clinician, what would you be thinking in terms of collaborative research when there are a lot of everybody is involved in patient care? What is your experience about patient safety, and what could be the implications of a kind of collaborative research in that?
So from a hematologist point of view, safety and, it is extremely important, especially because our margin of error is very less. And when it comes to overall, your question is 2-3, aims are there in this, how to do collaborative safety, what is the utility of it, of doing it. So if you ask the question why, I would say it is important for people to understand to improve the outcome. For improving the outcome, we need to have the structures and the processes in place. Now, question is, there are so many areas you can do which you don't require research to understand that is important. For example, empathy, you don't need to do a research to see whether empathy is important or not. It is extremely important. But there are certain things you may have to do a research, and that is when whether to do a research only within my institution or should I collaborate and generate an evidence so that we can change a practice. So in my mind, research has 2-3 advantages there. One is, apart from giving this evidence to the world to say we must change, everybody should change, the person gets an importance and recognition of having done something good. More importantly, when a research process happens, the entire team is now alert on doing things correctly. So when there is a measuring process happening, it is important. For example, when I joined and started the hematology process, and started in Punjab. Nobody had heard of transplants there. Hematology, the protocol, febrile neutropenia, you have to immediately give antibiotics in culture. It was kind of a alien coming and talking, and a lot of errors. So all I did was last 15 years, we said, okay, let us collect the near misses at every point. And that was a simple thing which we have done. And that has held initially, nobody would volunteer. Everybody would want to cover their mistakes at all points. So that is one, I would say, simple. It is not a research, it is a data collection audit, but subsequently it got an opportunity for a nurse to put it up in one of the posters in a conference. And then it became her baby to do it subsequently, and it's pulled out. Absenteeism. We just started saying, okay, let us collect and give everybody red, green, blue on their timings of coming, red, green, yellow. That itself, we didn't do any consequence, but giving the numbers back to them, each person's data, made them started coming little earlier. Our greens are now going up, red is coming down. So I'm just saying, of course, when it comes to collaborative research, asking a bigger question, prophylaxis, for example, is it important? What is the evidence? What is the consensus? And there is definitely a role in collaborating with other centers to ask a question. That our questions can be as simple as how to improve. One of the classic examples we know from Atul Gawande's checklist manifesto. That is fantastic. So it has come out in a big way. Yes, we must collaborate. That's my.
Thank you. Thank you. Let's go on this side of the stage now. Professor Satish, you have been working with Hopkins Research Institute for some time now and across countries or across nations or continents for that matter. So could you tell the audience as well that what are the challenges that one faces when it comes to collaborative research?
Thank you, Dr. Rahul, for that question. In fact, when we talk about collaborative research, I think we take it very lightly. We think, I pick up the phone and call somebody else across the continent, and somebody's always ready to answer that call and collaborate with me. In reality, that doesn't happen. First of all, we have to understand, research revolves around a significant parameters of patient safety. Okay, the subjects who are involved in research has to be kept safe, or the consequences are quite bad. Okay, the study could stop, or you could have other cascade of consequences that follow. So you need to be making sure that every collaborator will ensure that you have systems in place, you have patients who are aware to be enrolled in collaborative research. So let's talk about the different types of collaborative research that we can engage in. One is the disciplinary research, then there is multidisciplinary research, transdisciplinary research, the multiple forms of collaboration. Now, the opportunities are abundant because if you have patients, if you have a rare genetic disorder, if you have an oncology patient that you want to really improve the quality of life, there are abundant opportunities for collaboration and across nations, across continents. The downside is when, like I said, you need to take a systems approach. 9 out of 10 times, most collaborative research, especially among physicians, happen just because of personal relations and it's not structured. I would suggest one of the pertinent challenges that we face is because of the lack of a contract, a lack of an agreement, lack of rules of engagement. For example, if I engage in certain kind of research and my institution is well known to conduct a certain test or a certain genetic analysis of certain patients, or say for an SNP mutation, if I am good at that, I am one of the masters in doing it, and my collaborators looking at the quality of life of these patients across the continent, I need to have stringent forms of engagement. What I will be doing, what are they supposed to be doing? In case something new comes out of this engagement, how are we going to handle it? Many a times the challenges are like, we are not prepared to answer these questions. In my opinion, it has always helped us, like Dr. Rahul, you mentioned, because we work across continents, across disciplines. We have always sought the help of legal entities to come and define our contracts. So that is progressive, and it is also meaningful for both parties to engage. And also at the same time, you need to know if you are shipping tissues, cells, samples, genetic material across continents, there are stringent regulations across the continent in different countries. This cannot be done, that cannot be done. So you need to have the help of legal entities who actually can define this for you in your multi-engagement pattern. This is what I think is a major engagement. There are other personal issues which I think is all over the globe, and this can be managed, and that can only be managed by conversations and dialogue. And then if you have students and residents involved in collaborative research, there's another component, whether you can transfer them across the institutions so that they can conduct research in other facilities, because licensing, credentialing, privileging, these are other issues that you will face if these guys have to engage in research, or research that they really need to engage with patients in another setting. So I think, in my opinion, these are the major challenges that I face. I think most researchers face when engaging in collaborative research. I hope I have been, my answer has been quite useful. Thank you.
Thank you so much, sir. My next question would be to Dr. Jagsuti. So you mentioned about the context-specific research. And in the setting of clinical research, a lot of research that has been happening, mostly we get it from the developed world. And so a major challenge, even if you look at quality and safety perspective, is something which is what's implicating the global south, and how's patient safety and quality been there. And so there are two challenges. One, maybe the load of these patient safety issues and the quality issues are more. And we don't have systems whereby which although we are developing in a very rapid strides we're taking with regards to getting implementation guidelines. And with regards to the global south, the developing world, how do you think, compared to the traditional research, the context-specific research will actually help? Could you delve further into what you mentioned earlier?
Yeah, I think basically context-related research, I think will also come about if your governance structure facilitates that. Because I believe, I'm not from India, but I believe health is a state function here, right? Whereas in some countries, health will be a national function. So it becomes easier to manage, to have priorities for research debated at the national level and then filtered down. But whatever it is, I think each state will then have to be briefed about the requirement for patient safety and other priority health issues, which they will then prioritize in their own context. And then it is left to the doctors, the clinicians, the academia in that state to debate what needs to be done for that particular issue. And I think, again, if it is a priority issue, it will come up because the doctors will talk about it. Again, I go back to obstetrics. For example, if eclampsia is a major problem among pregnant mothers for morbidity and mortality, then it will become a priority issue. And then you will debate how to improve the multi-sectorial management of preeclampsia of a pregnant mother throughout her pregnancy, whether it be at home, in a health center, or in the tertiary hospital. And that is how I think context-specific research has to be evolved here. But each state then may debate various other issues which are not national issues. And then I think the issue will become the funding aspect of it, whether there is a national budget for certain research activities to be carried out, and so on. But I think the major problem that anywhere else we face is translation of the research into practice. When research comes out as a paper, how widely it is then translated into practice is the critical point. And that is where international organizations, the WHO and so on, get involved. And that is where the Global Action Plan for Patient Safety came about. And now you have ISCOA getting involved by trying to operationalize it in a better way at the local level. And now India has to now adopt that and see what further local actions can be done at the local context. So I think although we debate about context-specific research and global research, all are interrelated. There will be context-related problems which will become a global problem, because they never recognized it before, but it evolved from the ground. That is my take on it.
Thank you, sir. So as sir was rightly saying, it's a global as well as local, both issues. The only advantage that we have at India as such is the number of patients that we have. So it's very important that we cater to the requirements of the patient in this particular setting. Our context, our setting needs to be established, and that's why it is important that we conduct this context-specific research. Sir was also referring to implementation of that research. And that's where the clinicians come into picture. If I may go to Dr. Chinmay, please. So how do we ensure participation by clinicians in the research, particularly collaborative research in the fields of quality and patient safety?
So if we look at the quality and patient safety, the major concern comes is a collaboration. See, this is, I can say, a first conference where a clinician, nursing staff, paramedical, engineer, all are coming together, working together. So first of all, we need to have such platforms where people can collaborate. At a ground level, we have observed that even we are working on a clinical settings, there is a conflict, and who will take a share of what is happening. So first of all, we need to develop that mindset that this is a collaborative research when it comes to quality and patient safety. Secondly, as a quality and patient safety not only involved government organizations and institutions, there is a one important thing which is missing now, and as per the ICMR guideline, we need to have a development of an ethics committee. Because when we are going for a research and publication, it comes into an action. So we need to have some initiative from, we can say, CAHO, or we can talk with the ICMR that what to do for the private institution, because we have observed at ground level that when private practitioners or a private hospital goes to the government hospital, they look like this, that why you are here and what you are going to take out of us. So in that case, that mindset need to be then. Secondly, on similar terms, when we go for a publication, see, yesterday we have a launch of CAHO journal. So there are very few journals who will at present promote quality and patient safety. So that also need to be taken care, that we have one ISQA journal, and I think we have a CAHO journal which look for the quality and patient safety. So the recognition and spread of the research is also important. Thirdly, in pre-conference workshop, we have seen a lot many best practices. Yesterday also we have a presentation. So we need to develop a culture of scholarship, that whatever best practices we are doing, in such conference, we come together and start multi-centric research and collaborate. So there are two types of collaboration: interdisciplinary between medical and nursing, paramedical, and inter-institutional. So such collaborations are needed. And if you go through all these things and have some platform, we will be definitely able to go for a collaborative research, specifically in quality and patient safety. One more thing is, if you take from the previous panel discussion, there are PROMs and PREM. Now we are coming up. So if we take care of that also and try to develop some metrics and some mechanism, how can we convert that into a research? Again, it will need a collaboration. And as we have seen, together everyone will achieve more. As a team, as a collaboration, we can do a lot many things. Thank you.
Thank you so much, Dr. Chinmay. If I could just ask one more question to you with regards to when you talk about clinicians, they already have some during their undergrad training and all that. There's some kind of background with research where people are actually trained in that. Same thing with nursing, although most of the undergrad courses do have a kind of a research methodology, would be a portion of their studies. So when you look at a majority of the workforce that is involved in quality safety implementation would be non-clinicians. Clinicians are coming to the fore. So if you want to address all the students who are here and people who are in the various other departments who are involved in patient care and who have a major impact, what would be your take-home message to them as to how do they get into the research aspect of it?
Yes, excellent. So the thing is, to treat the patient and to get involved in research is totally altogether a different game. So definitely, yes, we need initially to start with a small course or small certification in a research, because when we go for research, there's something known as sample size, then methodology, then informed consent, and all that things require, which we doesn't teach in day-to-day life, or even if it is there, it is skipped because it is not going to ask in the exam. So for all the professionals, so here comes the word interprofessional education. So we need to take care of IPE And we can develop such course on research methodology for interprofessional education, right? How you can work together and how you can take part as one of the team member in a research. So such courses are required. So there is one of the important aspects when we want to go for collaborative research.
So Dr. Pratish, can I just add on to that context specific collaborative research? So global surgery has come up with a research multi-institutional on surgical safety checklist and surgical site infection rates. That's simple question they're asking. How many of them are going through a checklist or they are just writing it without checking it? And are they changing the gloves before the final suturing is done? Some early data, fantastic results. But that has come out of a systematic way of answering that question. I think that is context specific. Again, malaria related research which can be done in India. So LMICs. So this actually global surgery is doing in LMICs, our institution being part of it. I'm from the background, I'm seeing this. The surgical team is driving it. It is one of those examples I can think of. And I mean, similar to that, I think simple questions can be asked by very many people on the safety issues and the complications which we see. It, from a hematologist perspective, it could be time to first antibiotic in a first febrile neutropenia. That can be a data which can be collected and noted that the delay can cause more worse or early intervention can improve.
Going back to Professor Satish again. So what are there any research initiatives taken by CAHO itself? And can you enlighten us about it?
Dr. Rahul, that's a very interesting question. I think we have lots of delegates in the audience. I'm going to ask, if it's okay with the chair, I'm going to ask the audience, how many of you believe that CAHO has embarked on this journey of research and there are certain research projects that have been funded by CAHO? Please raise your hands. I think there is a general lack of awareness. In fact, CAHO in the last couple of years have been funding research significantly. Significant amounts of money has been given out as research funding. And let's look at a couple of projects that CAHO has initiated. First and foremost, Dr. Rahul, you know very well about the patient-reported outcomes measures, which is a stark flagship project of CAHO, followed by the patient-reported experience measures. Now, for those of you who do not know what is PREMS and PROMs, these are patient-reported outcome measures where you talk about, it is used for both for clinical evaluation and service evaluation. And also the experience measures are when you take into account the patient's understanding of experiences that in the treatment plan that they go through. So both these have been flagship projects for CAHO that has been initiated last couple of years. There are abundant anesthesia, surgery, multiple disciplines have come together to address these PREMS and PROMs project in the PREMS and project. And there is, I believe there is a paper that has been communicated, right, Dr. Pratish? There's a paper that has been communicated. I am not going to say the name of the journal, but it's been a highly indexed journal. That's one thing. And secondly, there has been a project on chemotherapy in these patients, and they were looking for an infusion therapy. That is also the second project. And there are a significant amount of nursing projects that has been also approved by CAHO. And I am sure in the subsequent years, following this conference, I think you will see an abundance of projects coming up where the primary focus will be to address the needs of the local needs, which sometimes do not get attended in terms of quality, in terms of patient safety, in patient preferences, patient experiences. I think these are the projects that would be encouraged by CAHO in the future. And I think we just have to keep our eyes open, and this should be happening very soon. Thank you, Dr. Rahul.
Thank you, sir, for the explanation. So what we've understood so far that we've looked at specifically, as Dr. Jagsuti said, about the context and then the clinical aspect of it. And so I would like to ask Dr. Chinmay, and Dr. Satish mentioned that, we have to go about it in a structured way. That so it's all right that, okay, we do the first step where we understand all this and then we go about, let's say, the research and finding evidence and getting the solutions. But then what do you think, sir, is the way forward for getting the results that you get from the bench to the bedside? So what are the different ways in which that this research evidence and it starts benefiting patients?
So ultimately, our goal is a patient safety. So as we said, that once we do such research, and with the help of platform like CAHO, we need to reach to a more audience. So for example, you publish in a journal, you publish in a platform, and now we have something coming up, a video paper. Like for example, you have a research and you make a video of 1 minute, 2 minute, which addresses your video, and it goes on the social media like our Insta and Facebook and everywhere. So now it is, I will be ambassador of my own research. So once we start doing it, there is a buzz coming in that, okay, such study has been done at one institution. And when we are going for a collaborative research, multiple institutions are starting it. So one more thing is, one is dissemination, second is incentivizing. As we give lot many awards, so similarly, if a best paper is given an award, he will get and boost that, okay, I will publish it more. And so such things will help to ultimately develop a guidelines. So because we all are here to have some research, if multicentric, then goes for a systemic review and then ultimately converted into guideline. So we starting with the bench, we can reach up to the bedside by helping our government, our major institution to develop a guideline for a patient safety.
So coming back to you, sir. If you were to choose some topics for future research, what is it that we should be looking at, and how can we go about from a collaborative research point of view?
Of course, it's very wide field that is open to you all for whatever you want to research. But if I'm talking from CAHO's perspective, it will be on various aspects of patient safety. And I think that's where research should follow standard procedures. So there should be a research committee that looks at it. There should be an ethics committee, validated questionnaires, and so on, so that the research that is conducted is sound. So I feel if you look at CAHO's vision and mission, I think many aspects of patient safety can be researched in the local context. And some meaningful interventions can be implemented when it translates down to the ground level. And I think the other thing that we should realize is that to translate research into effects on the ground will take some time. It will take years. So it has to start sometime. The starting point is now, if it's not already started. And I think the journal is one good initiative. And I think even publications of all the free communications in a supplementary journal would be good, so that is widely disseminated. And then research topics can be further developed. And of course, one other area that I just want to briefly touch on is continuous professional development of all the categories of staff in India. That should be voluntary, of course, if necessary, but maybe needed some regulatory requirement, so that the minimum standards are there by regulation to get your license to practice in the various professions, so that people continuously improve, because knowledge doesn't stay static. It always evolves. So that was my brief point.
Thank you so much, sir. So I think we are going short on time. So one last question to Dr. Satish. So as Dr. Jagsoti mentioned, so we seem to be on the right line when he mentioned about continuous professional development, the journal publications and all that. So the track seems to be right. So as someone spearheading the research department in the CAHO and the committee and thing, how would you like to address the team here about how do people approach CAHO and how can they be a part of the research journey of ours?
Thank you, Dr. Pratish. And that's a very significant question towards the close of this session. First and foremost, if you look at the major hospitals in the world, education, research, and clinical care has been the big triangle that they have adopted for excellence in their excellence model. And I think that CAHO has soon caught up with that wave, and we are into the research. Education has already been very active for the last couple of years. So education and the research is the new component that's the new blue-eyed boy in the fray now. And what we've been thinking is, first of all, we have a research committee that's been, many of us are members. I think we have about 18 or 20 members in that committee, and all experts in that area, where you could throw in your suggestions, give us, we have application forms online that you could submit, and based on that, the applications are evaluated, and you could be permitted to conduct the research, and in certain cases, we'd be funded also. And also there are opportunities for fund for publication, and there are, whether you publish internationally, locally, nationally, or in the CAHO Journal for International Patient Safety, you have abundant choices to publish. And coming back to, we also have provided masterclass series in the last year and a half. We have done a couple of masterclass series, as Dr. Chinmay was talking about, right from the methodology all the way to publication, how to write an article, how to critique articles. All this has been discussed, and there are videos available. If you guys want to take a sneak peek at those, that's available. And more importantly, I think, first of all, for any research to happen, it is a culture of research that is embedded in the team or in the population that you work with. I think CAHO has been successfully getting on board the paramedics, the nurses, the policymakers, and the physicians on board. And I think this is a journey that we need to watch out, because this could be a striking force in the future. And I don't think there's any other platform in India that has come up so successfully, trying to integrate multidisciplines together and trying to promote research for patient safety, quality, and anything that can change the lives of our patients and the providers. I think that's a great step forward. And thank you very much, each one of you, for those questions. And I give it back to the moderators. Thank you. And thank you for the audience too.
Thank you, moderators. Thank you, speakers. I think the way ahead is only collaborative research, which is the route which would hold the tree to, I think, quality and safety and safe outcomes. I would request all of you to please take the center stage for a photo op. Thank you, moderators, for a very well-conducted session. Thank you, speakers, for your insightful opinions. Dr. Lalu Joseph, to note that this is a very gender skewed panel. It reflects probably no women participation into research, which is not the case. So next time we will reverse the ratio. Thank you, speakers. Thank you, moderators, for a lovely session. With this, I would like to introduce the session 12, which is sharing best practices, breaking the silos. The chairperson of the session is Dr. Anupam Sibal, President, Global Association for Physicians of Indian Origin. He's also the Group Medical Director and Senior Pediatric Gastroenterologist and Hepatologist with Apollo Hospitals Group. Dr. Sibal, to please take the stage. Also is the chairperson, Dr. Sameer Singh, Vice President, Medical Services, CK Birla Hospitals Private Limited. Well, that's me. And the keynote address is by Mr. D.S. Negi. He's the CEO for Rajiv Gandhi Cancer Institute and Research Center, New Delhi, India. He would be delivering his keynote address on Together We Heal, Unlock the Power of Generosity. Mr. D.S. Negi. So I would request you to please come on stage. Please.
I speak from here. Yeah. Just this one. Yes,
this is for going forward.
Good morning, everyone. At the very outset, I'd like to thank Dr. Sibbal, the chairman of the organizing committee, Dr. Vijay Agarwal, the president of CAHO, Dr. Lalu Joseph, the general secretary, and I would like to really thank them for giving me this opportunity to talk something slightly different on generosity. Now, my topic, I think I'll just give you a bit of history about the Indian health scenario, how it started, and also a bit about, since I come represent a cancer hospital, so I'll be talking about the cancer data statistics and also the problems the patient face and how do we help really them, how we can help them without much compromising on your profit. Still, we can do a lot. So I think this is what I plan to do it. So going back in history, if you look at the Indian health scenario, really started with the board committee report in 1943-47. And Joseph Bohr was of the Indian Civil Service. In fact, he joined in the Indian Civil Service in 1902. And then later he was assigned the job of do a survey of the entire health scenario in the country before independence, before 1947. So this committee is a very monumental work. In fact, that's the basis or the edifice on which still the Indian health structure or the system stands. So board suggested that the system should be integrative, the palliative and curative should be integrated. He also talks about the structures of this, the primary, the secondary, and the tertiary sector. Then he also talks about the medical education in the country. So since then, I think the 3T system is still there. And at that point of time, 1947, we had about 700 primary health centers in the country, about 7,000 hospitals and dispensaries. So that was the scenario in 1947. I think since then, we have traveled along in the last 75 or 80 years, and we have reached a stage. Today, the most dominant part played is by the private health care sector. So these are the salient features of this, that the private sector provides 70 to 80% of the health sector in the primary health sector, about 50% in the secondary, and about 60 to 70% in the tertiary sector. And there are more than 500 government hospitals and government medical colleges in the country. And the next is the challenges we have. Though we have, in terms of the number of, the population doctor ratio, we seem to be doing much better than the WHO, because it says that we have about 801 doctor against 811 the people. But I think the whole scenario is skewed because most of these doctors and the nurses or the infrastructure in terms of healthcare are in the metropolitan city or the peri-urban areas. So still, I think the hinterland, the villages, you'll find really any good hospital or even a dispensary for that matter. So I think these are the great challenges. There's a great divide between the urban and the rural in terms of the health care. The next is cost. I think this is one of the most important, I think everybody will face. The cost is prohibitive today, is almost 60 to 70% of the total expenditure is out of pocket. In our hospital, in the cancer hospital, it's almost 70%. So how do they take care of it? The insurance is limited. I'll talk about the insurance, the flaws in the insurance and the problems in insurance. But I think these are the many issues. And there's fragmentation. I think this is one of the most important things, the fragmentation in the Indian healthcare. There are government hospitals, there are private hospitals. The patient goes to one place to another place, government to private, private to another private. And every that time, the patient is subjected to some test or some, and the cost keeps on increasing. So I think this is one of the major challenges. And how do we really bring down the patient burden or the disease burden is a major challenge. So if you look at the global scenario, the burden we find, there's almost about 20 million new cancer cases in the country. There's a 2022 data. About 10 million people die in the world because of cancer. And is projected the number of cancer patient is the rise is about 16.4 million. And the economic burden in terms of the treatment and the loss of productivity is enormous. I think you can well imagine how is this. So next is the world statistics in terms of the disease burden. You'll find that that lung cancer is on the top, prostate and colorectal, which is about 40% of the total number of cancer cases. And if you look at the both sexes, the male and female is about 34% is only in three. That is the breast, prostate, and colorectal cancer. That is the global data. Now the challenges in India, you know the data. There's about 1.5 million new cancer patients are detected every year. About 1 million patients died in the country, and the reasons are not difficult to find: late diagnosis, limited healthcare infrastructure, and high cost of treatment, and various factors. I think these are so this gives a distribution about the cancer, the causes of cancer, in fact, in the country. Some of the data of JNK is not there, but I think rest you'll find. And in 60% of the cases, the primary cause seems to be tobacco, which is, I think, preventable if you can do it properly. So this is the cancer in India. It's slightly better. I think the oral cancer, oral cancer is on the top in the males. Lungs is the next, and next is esophagus. And for the females, breast, which is about 26%, and cervix about 17, ovary 6.6%. So overall, about 34% of the total cancer is attributed to breast, lip, and cervix cancers. So I was talking about the cost of the treatment of cancer, how difficult it is. So we find that 70 to 80% cancer costs are paid out of pocket. We cited about Rajiv Gandhi, how this, and about the average cost of treatment of a cancer is about 7.5 lakhs. And because of the cost of treatment is so high, and the insurance coverage, of course, slightly increased because of the Prime Minister's, the Yojana, the Health Yojana, the PMJY, and is about 51% is coverage today. But I don't know how the rest will be taken care of. There's a major issue. And because of the low coverage of insurance and the governmental schemes, about 7% of the Indian population, about 10 crore people, they get out of, they get into the poverty line because of the cost of treatment of cancer. So I think it's a major, I think, problem. However, the newspaper highlight the total, the healthcare industry is booming with $638 billion in this country. So I think is a paradoxical. On the one hand, the industry costs are going up, the revenues are going up, but at the same time, the people are getting out of the income net or into the poverty net. So we have a data, recent data in the Times of India, in fact. So what is the coverage of insurance? Though insurance coverage is booming, but you look at, it's not as good as it should be. So in the last, this is I think figure of 2020, 23, 23, 24. The corporate sector is done very well because the number of coverage has gone up from 19.9 to 25.6 crores, and individual from 5 to 57 crores. I think that is the coverage as on today we have. But the problem with the insurance is the premium is rising very high. In fact, in 52% in the last year only, about 20, there has been an increase of 25% in 52 policy cases. So you can well imagine if somebody has a premium about 30,000 and goes to 90,000 in the next year. So you can well imagine how this can be sustainable or affordable to a patient. Similarly, the medical inflation in the country is probably one of the highest in Asia. It's about 14%. So this again telling upon the patient or his family. So about 68% of the policyholders have less than 5. That means a lot of under insurance. And many of them are getting out of because they can't afford the premium, so they're getting out of it. Almost 5% are getting out of the insurance net every year. And major causes again 90% rejection of the insurances. Wait, how was the time? Okay, sorry. So I think we're running short of time. I don't know how much this. So I'll come to the prevention part of it, I think. So how do we, reduce the disease burden? One, the most important is the preventable, how we can prevent this. 60% of the cancer can be prevented. This is all tobacco related and lifestyle related. This can be prevented. So we need to have a much better, improved coordination, and in our hospital, in fact, in our hospital, how do we really help the people, those who are needy? So we have created a corpus about 1,000 crore rupees. We propose to create, in fact, that's what we do. We have already created 3,300 crore rupees, and this is invested, and whatever revenue we get out of it, or interest we get out of it, this is supposed to be or proposed to be invested on the patient care. So we have free bed services, we have discount on case-to-case basis, home services. So in all, I think we spend about 115 crore rupees every year from our own kitty for the patient care. So this is how we try to sustain them, help them this. So since we are running time, I would only say that cost optimization for the hospitals will be very important. Unless we do the cost optimization, it will not be sustainable. It will not be affordable. So it will be very difficult for everyone to really run an institution when the patients are not coming because of the high cost. So value-based care rather than revenue generation should be the more. So I think with these words, I would only like to highlight that it's a difficult task ahead. The cost has to be optimized, and everybody has to take steps toward this. With these words, thank you very much.
Thank you, sir. I would request Bobby Madam to please invite the remaining speakers on
Thank
stage.
you, Dr. Samir Singh. As the session continues to discuss on leading by examples and to share their insights on how the hospital boards can foster a culture of quality and safety, it's my honor to welcome on stage Dr. Rakesh Gupta, Chairman and Medical Director of Sarvodaya Hospital and Research Center, Faridabad. Dr. Gupta happens to be my chairman too. And it's my privilege to welcome Dr. P.M. Uttappa, Dr. Group Chief Medical Director, Narayana Health, Bengaluru, India. Let's welcome Mr. Prashant Sharma, Managing Director, Charnock Hospital, SKM Group, Kolkata, and our esteemed speaker from Japan, Dr. Shin Ushiro, Deputy Director and Divisional Director of the Division of Patient Safety in Kyushu University Hospital, Japan. Let's give a big round of applause for all the esteemed speakers. Over to the moderators.
Thank you. Thank you very much. Good morning, friends. In healthcare, we've sadly had this issue with silos, private versus public. In hospitals, it's surgeons versus medical, it's admin versus clinicians, it's nurses versus doctors. And COVID was a great leveler because it just taught us that if we work in silos, we are not in the best position to leverage the strengths of everyone on the team. And it was really heartening to see that in India, the silos between private and public healthcare were broken during COVID. Because if we look at the way the care delivery was done, about 60% of all the ICUs, ventilators were in the private sector. When it came to labs, it was half and half. When it came to vaccination, it was 90% government, 10% private. But I think for the first time, we broke these barriers. And I think we have all benefited from this. And in keeping with the future, the expectations that patients have, we have to break these silos. To discuss that, we have a very stellar group of experts. And I'm going to, along with Samir, moderate this. So what we're going to do is going to request each of our panelists for their opening remarks. And then we'll have some questions directed at them. And if there's time, then we'll do a Q&A. We're going to start with Dr. Rakesh Gupta, who is an internist by training, trained in Rohtak, and then went on to establish a very successful practice and then created the Sarvodaya Healthcare Group out of Faridabad. He's chairman and managing director. So Rakesh Ji, for your opening remarks.
Thank you for inviting us at this CAHOCON. The idea is that it has to be collaborative practice. Their silos are there. The doctors are not talking to nurses. Nurses are not talking to technicians. We are not talking to each other. Even in a particular patient where there are multidisciplinaries involved, 2, 3, 4 doctors are not talking to each other. Then the patient is getting treated in silos and hence the complications. The idea is to get them together. For example, in our accreditation committee meetings, the NAVH committee meetings, what we do is that, for example, in HIC meetings, we'll hold a small brainstorming session together. We get the messages out over there. And then we call a larger forum like this and discuss the things with all the stakeholders so that then we are not working in silos. Everybody knows that what is being planned, what needs to be executed, how to take care of the patients in a multidisciplinary way. And then they can perform their own roles within the system. That is one thing which we do. Especially, secondly, that we have multidisciplinary team rounds on the floors itself, as well as in the ICUs, where the patients are complicated. To break the silos, we need to get together and create a platform within the hospital where everybody can raise their opinion, give their suggestions, and the execution is done in a combined manner. That's my idea. Thank you.
Thank you. Thank you so much, Rakesh Ji. And from Faridabad, let's go to the beautiful islands of Japan. We have Dr. Shin Ushiro, who is the director of the Division of Patient Safety at the Kyushu University. He's very actively involved with the Japanese Council of Quality in Healthcare. He's been a board member of ISQA and is a member of the G20 Patient Safety Leaders Group. I've had the privilege of working very closely with Shin at the World Health Organization. Shin, your opening remarks.
Do you want me to make a comment on inclusion of patient training?
Yes, please.
Oh, okay, thank you very much. Yes,
Could you just use the microphone slightly higher so that we can, because there's an echo. Yeah.
Okay, okay. Then thank you very much. I'm Dr. Shin Ushiro. I'm from University Medical Center as well as accreditation body in my country. I would like to focus on my experience in my hospital. First, we have a organizational structure to promote patient safety. For instance, we have division of patient safety. We have division of patient consultation. Those divisions collect patient voices, and those divisions collect data such as PROM and PREM, patient satisfaction, patient experience. And we also conduct the regular meeting with patient representatives. It is called Patient Safety Audit Committee, regulated by the government. And we communicate with the patient, and we incorporate outcomes into the improvement action for patient safety. And shared decision making that Dr. Ezekiel, the president of the ISQA, mentioned this morning is quite important. When you make shared decision making, the informed consent document form is quite important. In my hospital, we conduct standardization of informed consent to see if the consent form includes items necessary for explanation or the graphic figure for better learning for patients. And the medical chart disclosure is also conducted in my hospital. So there are a lot of confusion and misunderstanding between patient and medical professionals. So the disclosure of medical chart is quite helpful. And all those items are included hospital accreditation that my accreditation body provides. So going through accreditation is quite helpful. And when you go through accreditation requires you to produce patients' rights, so which is very helpful. Last year, WHO released the Patient Safety Rights Charter. So you may want to incorporate those patient safety rights charter. There are 1 to 10 items into your patient rights in your hospital. So those are I will stop there. Those are the activities and practices we have been conducting in my country. Thank you.
Thank you, Shin. From Japan, let's go down to Bangalore to Dr. PM Uthappa, who's a distinguished nephrologist, worked in England for a very long period of time, and then did the most sensible thing is to come back to India as we move towards our journey to become developed by 2047. He's the group medical director of the Narayana Health, and in addition to his role as a clinician, as an administrator, he also loves to run marathons and has completed the Ironman. So lots of admiration for that.
Thank you.
Your opening remarks, please.
Sorry, I didn't get the last bit.
Your opening remarks in terms of what do you feel in terms of breaking silos?
Yeah. I'd just like to go back to Narayana Health. We have around 20 hospitals, 25 managed care clinics, and now an insurance arm. So that means we have to see how the entire ecosystem of quality, safety, and governance works. So a couple of years ago, we started from a very blank page. We thought, how do we make sure we had two pressing problems? How do you make sure everybody follows guidelines and protocols and SOPs? And how do you make sure all our hospitals are aligned to do the same thing? So we created a very nice monitoring, measuring, analyst and analytic platforms, which helped us bring in some kind of uniformity across the group. And this was part of something called clinical governance. As one of the highlights of this topic is working in silos. What this governance framework does is it makes sure that every stakeholder in the hospital, whether it's a dietitian, frontline, the person manning the desk, or some ER physician, clinician, nurses, they're all part of the governance, and it's all calendarized and regularly monitored, measured, and analyzed to get some insight. So what happens with this is every month we go back and discuss this, and that's setting a culture where it's music to our ears now. When you go and speak in the hospital, the doctors talk about governance, doctors talk about quality, doctor talks about safety. So the key thing here is the measuring, the monitoring, and the analysis, being very consistent, going back and doing it all the time. Just to give one example, not very popular, but it's very important. A few years ago, our ALOS in lap cholecystectomy across the group was roughly 3.7 to 4. That's very high, you all agree? One of the hospitals, our hospitals, Narayana in Gurugram, the best ALOS was 1.5. So as I mentioned, we monitor on a regular basis. Every month, this was shown to all the doctors across the group. And now, after 2 years, our group average has come down to 2. So that's the power of measuring and monitoring, being very consistent and going back and showing to them, this is how we do it. There's lots of other examples, probably in view of the brevity of time, I will just skip that. Thank you.
Thank you. Thank you so much, Dr. Uthappa. I'm going to now invite Mr. Prashant Sharma, who's the Managing Director of CAHOCON Hospitals, part of the SKM group in Kolkata, for your opening remarks. What I want you to specifically cover is, because you're not medical, what is it from the other industries that you believe we can kind of learn and incorporate in our functioning?
Thank you, Dr. Anupam, and it's a pleasure to be here as always. Healthcare is part of the services sector. If you look at the services per se, there are multiple other industries or sectors which are participant in this. So we are a sort of a consumer service, whether it is other sectors, whether it is travel, whether it is airlines, whether it is airports, it is malls, it is education, it is hotels. These are all service sector industries. And healthcare, private healthcare in India started in the 80s, where Apollo came with one of the first hospitals. There were some hospitals before that, but the larger movement started around the 80s. So per se, we are about 50-year-old in a services sector. And since the last 50 years, we've been trying to evolve different models which will perfectly fit what is required in our country. The larger traction we can see is over in this current century, where specifically in the last 15 years, a lot of private action has come into private healthcare space in the tertiary quaternary space. Most of this is fueled by private equity infusion. And once the private equity infusion comes in, they also bring along with them a lot of global practices, because most of these private equity firms are global in nature. But let's take a step back and look at other sectors, what they are doing. Look at our airports. The kind of airports which we are building in our major cities are much bigger, much better, much more sophisticated than most of the rest of the world. When I say rest of the world, I mean the western part of the hemisphere. So if you compare our hospitals, our airports with the airports, perhaps in the northern American continent and other things, we can see it's much more efficient. The service levels, the way it is being built, the kind of volume it can handle is much more better than what has been done in the past. Similarly, in the hotels, if you look at the hotels in Asia, they are much more modern, more adept to today's requirements. Whether it is in India, in China, in Southeast Asia, our hotels, volume-wise, size-wise, is much bigger, better than what has been done in Europe, what has been done in USA. So I think this is a great opportunity for us to learn what has been done in airlines, in aircrafts, in airports, in hotels. A similar opportunity also lies in healthcare. We having a population touching 1.5 billion very shortly, also catering to some MVT. We have the opportunity to design healthcare in a very dramatic fashion, which will cater to the requirements not only of today's India, but tomorrow's India. And also taking a leaf out of learning from the IT services, what IT has done for India in the last 40 years, 30 years, whether it is a TCS or the larger companies, how they have completely transformed the way things have been done, not only servicing Indian sectors, but also overseas. So I believe that healthcare also has a similar opportunity to transform itself, taking learnings from multiple of these sectors and incorporating them, re-engineering itself, redesigning itself to cater to today's India and tomorrow's India.
Thank you. Thank you, Prashant. I'm now going to request Mr. Negi. Mr. Negi is an IAS officer of the 1975 batch, many positions across different departments. In fact, he was the Principal Secretary of Health, Government of NCT, and used to sit on the board of Apollo Hospital as well. And then in 2007, I have to say he would be definitely the longest serving CEO of a hospital because he's been CEO of Rajiv Gandhi since 2007. So Mr. Negi, in your two avatars, one as a senior IAS officer and then as a CEO, what are the differences that you found in terms of healthcare? Because when you first entered healthcare, you would have been surprised to see the kind of regimentation, the kind of silos, and what were the learnings that you brought from the IAS into Rajiv Gandhi, which others can possibly learn from in terms of breaking silos?
Thank you, Doctor. Thank you, Dr. Sibal.
It's a very relevant question. I spent about 35 years in the IAS and here 18 years in the health service. I've almost forgotten what IAS is, what administration is. I mean, looking. Only difference is when we were in the service, by and large, we were looking from a macro level, what's happening in the field, But once you come to hospital, then you have the opportunity to go through the micro issues there, which is very critical, very important, and which probably we missed in the service. So it's a great experience, and you're talking about the silos. I think is very critical. In fact, the silos in the health sector are fine. Is a steel silos, very difficult to break. I think we need to break it because it is ultimately in the interest of everybody, the patient, their families, and also the the care providers. So because what I always talk about is the cost. In the hospital, we find, especially in the cancer hospital, people coming from different walks of life, different economic backgrounds, social backgrounds. They have no alternative because they don't have the insurance. So they have to spend out of their own pocket. In many cases, I find that they sell their, the family silver, whatever they have, they sell their small piece of land because they think, that sometimes that life is totally eternal. So whatever amount of counseling you do it, but they always try to spend whatever is possible to them so that the patient survives. So the patient is not only physically traumatized, or the family is not only physically or mentally traumatized, but also financially traumatized. So I think the biggest the challenge to the health sector is how do we really keep the cost low? I think this can be kept low by breaking the silos, because we can have some sort of partnership hospitals. Why every hospital, for that matter, having cancer, the cancer hospital everybody should have a Linux. Why not have one hospital Linux and others use it? Like, for example, digital transformation. I think the hospital spends crores and crores rupees on the platforms. Why can't we have a common one and try, bring down the cost? I think these are the major issues, and this can only be done. It is really generally we have the intention to have collaboration. Otherwise, we'll keep on prying on each other. We'll all prying, trying to poach on each other, and this will really never help. So I think keeping the cost in the health sector is a major challenge. Otherwise, affordable apart, it may not be sustainable to many hospitals. After all, when the health inflation is at 14%, how many people can survive? Even the insurance people cannot survive. So I think this is the major challenge for everybody. We need to break the silos, and for the larger interest of everybody. So with these words, thank you very much, Dr. Zibbal, for giving me this opportunity.
Thank you, Mr. Negi. We apparently have about 5. How many minutes? 5? Okay. Or either we can do that, or maybe, we have some very brilliant people in the hall. Maybe we can ask if anyone has any comments or questions. We have 4 or 5 minutes to go. While we are waiting for anyone to come up with, Somji, if I might actually, ask you for your comments. And the reason why I ask is, if you look at the global positioning of India and you go anywhere abroad, sometimes you get into a cab and the cab driver will say, are you an IT professional? If you go to the Midwest in the US, the whole impression about India and the way the world perceives India is very driven by how India has been successful in IT. And of course, you've played such a stellar role in how India has emerged as a global leader in IT. Based on your huge experience at NASSCOM and in different industries, what is it that you saw? And we are privileged to have you talk about patients for patient safety, but what is the advice that you would give to us in healthcare on how we should reimagine the future and finally get rid of the silos that exist? I'm just going to come and give you a microphone.
Thank you so much for this opportunity. I think we've got stalwarts here, and you did mention about the IT sector. I think one thing which is really common between healthcare and IT is us people, right? So I think at IT, there is nothing else but people. right? Who are software engineers or people who work hard. And similarly, when you look at healthcare, technology is common, whether it's US, India, Japan, we can get the same technology because technology is to buy. The difference is in people. I think what we did in the tech sector was educate people, continuous learning. And this is, I'm not confusing it with CME. CME is a necessity, but I think skilling people, reskilling people, changing technology and how you did that. In case of the IT sector as well, I think the turnover is very high. We created processes which were changing constantly, but were repeatable, right? So the first country that did a CMMI level certification, and by the way, it's very different from the way accreditation happens here, right? They one by one, so we moved from CMM 2 to 3 to 4 to 5. And India was the country which had the largest CMMI level 5 certification in the world. Customers used to come to us and saying, hey, you know what? I run a big software company in the US. I'm level 3, you're level 5. Show me what are you doing? So it wasn't an audit that was done periodically. It was any time. So I think what the IT industry is was we were never ever preparing ourselves for an audit. It was any time. You don't prepare for a cybersecurity audit. You have to do it every day because in between audit, you're going to be affected. So I think we're on the right track. We have people, we have hospitals, we have colleges, but I think we need that commitment that we can all do it. I think we are on the track, but I don't see any reason where tomorrow the cab driver or the immigration officer in US is going to say, "Ab healthcare ke ho gaya."
Absolutely. Thank you, Somji. Thank you for that. Yeah, that day is not far. We are producing 107,000 MBBS doctors, going to go up to 120,000 a year. All of Australia has 100,000 doctors. So eventually the shortfall of the 3 million that the World Health Organization predicts by 2035 is going to have to come from a country like India, where English is the spoken language and is the language of communication for healthcare training. But great point, Somji. And I think a lesson, and I guess in the debate yesterday, we talked about those 5 days versus the 360 days that you should be ready for accreditation. But very importantly, you said it's not about CMEs, it's about continuous education. And clearly there is a void when we look at us in healthcare in terms of communication. We might be very good at communicating the medical bits, but the whole communication and actually changing the way the patient today perceives healthcare and their expectation is, I think, a huge area where I think we can all improve. We now have to bring this to a close, but I'm going to ask any of our panelists for their final comments.
So before we wind up the session, could I request the other 4 panelists?
Yes.
To just give a 2-liner or a 2-pointer message or a mantra, how do you wish to break the silos across departments, across industries? We'll begin with Dr. Rakesh Gupta, sir.
I have already emphasized the role of multidisciplinary meetings, especially the NABS committee meetings, which are held in closed doors and the message doesn't get across to all the stakeholders, especially the people who are the real caregivers, whether they are from the CSSD or they are the nurses or they are the OT technicians or anybody else. That is one important element to break the silos. It is on a micro level, of course, definitely agreed. So we should have platforms of this such kind. Similarly, in the ICU, what we feel is a patient is seen by a number of doctors. A doctor X comes, prescribes something, talks to the family, writes 4 references, A, B, C, and D. Person B comes, and then without consulting the primary person, he starts talking to the family and advises 4 more tests, which are now getting more complications done with the patient. So we need to break these small silos. It is all the way at a micro level. I fully understand that breaking silos at macro level would be different and micro level will be different. But clinically, micro is very, very, very important because that ultimately impacts the patients in an adverse way. It may impact. And once there it's taken care of, it can then improve the clinical outcome in a very, very nice manner. With these words, I thank the organizers for giving us this opportunity at CAHOCON. Thank you.
Thank you, Dr. Gupta, for gracing the occasion. Dr. P.M. Uttappa, sir, question to you. 2-line mantras or 2 messages.
Thank you. Thank you. I just want to go back to what Anupam was talking about. The rest of the world, India is famous for IT. No, it's also famous for doctors. Whether you go to UK or any other English-speaking countries, lots of Indian doctors are very revered and respected.
And why do these doctors thrive in these countries? I worked in England for 20 years. It's one simple reason. It's not that we are less hardworking here or more hardworking there. They work within a framework, they work within a system, they follow the rules. And there are systems. The problem, the challenge we have in Indian healthcare systems is we do not have processes, we do not have proper regulatory methods, and nobody works within those frameworks. So culture, safety culture is not built in a day. Safety culture is built every day and through proper leadership. So I suggest that we need to have proper mechanism to regulate or have proper processes, guidelines, and make sure that these doctors and healthcare workers work within the system. I think just talking to them or doing CMVs or saying, oh, look after the patient well, it's not going to work. It has to be enforced and asserted. Thank you.
Thank you, Dr. Thapa. Mr. Prashant Sharma, just 2 pointers, 2 messages.
To continue learning from other industries and incorporating them in our sector. For example, from hotels, we can learn property leasing models. They have amazing property mechanisms. We can learn people management. You take out one room division clerk, put him in another hospital, he will do the same thing. You take out one GM from one hotel, put him in another hotel, he will do the same thing. But in our sector, we are very, very people dependent. We are not very much process dependent. We can't replace people that fast. So I think growth of people and people management is what we can learn from hotels very well. From airlines, I would say we can learn equipment leasing models. They have dry lease, they have wet lease, they have damp lease, they have moist lease, all sorts of advanced leasing options. We can learn from there. We can adopt in our healthcare ecosystem for equipments and machineries, which are very capex heavy. We can also learn efficiencies because for one aircraft to leave on time and arrive on time, there are a million things which have to go right to make it happen. In our healthcare also, there are dynamics that the dynamics are quite similar, and we can learn that from airlines and probably incorporate that so that we can have minimum failures possible.
Thank you, Mr. Sharma. Dr. Shenoshiro, 2 messages or just 2 words, which is your summary take.
Okay, I'd like to highlight with 2 words. The first word is leadership. In my country, when a hospital director is selected, he has to have or she has to have experience on patient safety. So leadership involving other stakeholders is quite important. Another topic is a periodical evaluation by stakeholders. I mentioned patient safety audit committee in the presence of patient. So the periodical assessment is quite important for improvement. Thank you very much.
Thank you so much. I think in summary, the take-home messages, break the barriers of departments, break the barriers of industries, and learn from them. But I think the most important is break the barriers of your mindset, be open to adopt and learn and adapt. Thank you all for your time. I would request all the speakers and the chair to please come for a group photo.
I'd like to thank the moderators, Dr. Sibal and Dr. Samir Singh, for facilitating and wrapping up the discussion. A huge thank you to all the esteemed speakers for sharing their insights. Thank you so much. I'd like to call upon Vidya Mani and Frida for taking over for the coming sessions. Thank you, Dr. Bobby and Dr. Samir. So, ladies and gentlemen, a warm morning, I can say still, and I'm Miss Frida D'Souza.
And myself, Miss Vidya Mani. We will be your MCs for session 13 and 14 for the day.
The session 13 is all about potpourri. So let's see what we have in this and what is unfolding through this session. So to chair the session, we have with us our chairpersons, Dr. Venkatesh Tuppil, CEO and Director, Foundation of Quality India, FQI. So we request you to kindly come over the stage. The second chairperson, Dr. Nareen Sehgal, Medical Director and Head Department of MAS, Metabolic and Bariatric Surgery, Sehgal Neo Hospital. May I kindly request our chairpersons to occupy the seat on the stage.
A big round of applause to the chairpersons, please.
To deliver the keynote address for the session 13, we have our keynote speaker, Dr. B.N. Gangadhar, Chairman, National Medical Commission, India. And sir will be delivering the topic, Redeeming the Spirit of Medicine, Improving Patient Outcomes by Creating a Joyful Workplace. May I call upon Dr. Santosh Kraleti to introduce our keynote speaker.
A very good morning to everyone. It's really my pleasure to introduce today to all of you who needs no introduction, Professor Dr. B.N. Gangadhar sir. Gangadhar sir has been the professor and the director of psychiatry at National Institute for Mental Health and Neurosciences, NIMHANS, in Bangalore. He is currently the chairman of National Medical Commission. He was responsible for doing some of the very primary research, especially yoga and psychology, yoga and psychiatry, yoga and neurosciences, and many, many psychiatric disorders, and has published more than 450 publications, with nearly 100 of them having an H&H of more than 55. So you can understand the kind of rich scientific knowledge and research that he brings in this conversation that he's going to have with us. Along with that, having worked with him at National Medical Commission, I can tell you that he is one of those very, very few leaders with whom I have worked and have seen, who pays very, very keen attention and who gives an ear to all our conversations and thoughts. At National Medical Commission, he has led from the front in hearing the problems, the issues of postgraduate students, undergraduate students, and has brought many, many changes in the system, especially giving a 6-month maternity leave to the PG students, understanding the stress that they are undergoing, having a yoga curriculum for relaxing and also for, the spirituality for the MBBS and postgraduate students, and many, many such changes. Today, we have with him basically to share his experiences and deliver the keynote address. And more importantly, I would like to bring forth before all of you the spirit of medicine with which we all have come, we all have joined. We all see a lot of burnouts, a lot of stress, a lot of pressure during our clinical work or after our clinical work. And basically, sometimes we might forget our purpose of why we are here. And today, Dr. Gangadhar sir is here to remind us the purpose of, all of us being doctors, clinicians, being in the work, in the field of quality. And we warmly welcome him on behalf of Institute for Healthcare Improvement and CAHO. Thank you, sir. Thank you for sparing your time. Over to you.
Before Professor Gangadhar starts delivering keynote address, I must tell you one thing. There are two giants here, one on the stage, one in front of the stage. I'll tell you why. The first Institute of National Importance, NIMHANS, not a small one, huge like an ocean. He was instrumental in getting that accredited, full accreditation, for which another giant sitting here, Dr. Alexander Thomas, please stand, please stand. He is the one who provided full support with CAHO, and therefore we have a unique combination of a quality achievement. Over to you, Dr. Gangadhar.
I'm so happy to welcome Professor Gangadhar. He's going to speak about redeeming the spirit of medicine, improving patient outcomes by creating a joyful workforce. In the evolving landscape of healthcare, patient outcomes are no longer driven by clinical excellence alone. The well-being, motivation, and emotional resilience of healthcare workers are equally critical. Let's learn from him what he has to say about this. Sir.
Permit me.
Yes, yes.
I don't want to come in between a delicious lunch of this conference and you. I would try to be as brief and as focused as it can be. We are, of course, discussing a very practical but yet very difficult subject of how to find a purpose which will end up in a joyful outcome in medical profession and as a profession of a medical teacher as well. Seeing the logo here of the CAHO, care and make it safe, reminds me of a anecdote. People who may have heard me earlier would have perhaps listened to this anecdote from me on the talk. But that perhaps summarizes what the small font part of the logo which is there on the screen. Care and ensure that it is safe. It seems all of you, of course, have heard Mahabharata was written by Ganesha on a condition that the person who is dictating him, the Vyasa, will dictate it without any break. And Vyasa has to connect the strings of the entire Mahabharata episode. Whenever he forgets a string, instead of stopping, he has to make sure that this person continues to write, because otherwise he would run away and he would start telling some other trailer stories, and then the main story will continue. It goes on. A movie, a longest movie with the highest number of trailers is what is Mahabharata. All of you have heard, of course. The Upakathas will go on. In fact, the Upakathas are more than the Katha there. Nonetheless, at the end of all writing, when the last words is said, Ganesha by then is exasperated. He can't express his anger because person who is dictating was Vedavyasa himself. He still expresses his discontent. You made me write so much. I think you have tortured me, and so on. Then the Vyasa have become old. I've been writing all my life, and I have written so many things. So I got tired. So I asked your help. So please don't mistake me. This is what I've been doing all my life. Ganesha is very amused. What did you write? You would never have written so much what I wrote now. So he takes him to his library and shows him all what he has written, the Vedas, the Vedangas, the Upanishads, the Puranas, and so on and so forth. He says crores and crores of verses have been written, and Mahabharata in that sense has been a smaller version of what all I have written here. So Ganesha gets amused and says, why did you write all these things? No, I wrote these things so that by reading these things, people will become very good. Bad people will become good, and the good people will become better, and better people will become the best. So only to teach how to be good, I have written all these things. So Ganesha says, to become good, if I have to read so many books, be assured nobody would be wanting to become good and nobody would have time to read all these things. You have to give an executive summary in a court judgment. You know, there are pages and pages of discussions go on, and an executive summary is whether I have been relieved from the jail or not. So be a focused executive summary of these things. Crores and crores of shlokas you have written, be a executive. So then he says, why in one shloka, I will tell in half a shloka, what is the summary of all I have written. Shlokardhena pravakshyami, yaduktam grantha kotibihi. In half the shloka, I will tell you what I have written in all the crores and crores of these verses. Paropakara punyaya, papaya paripidanam. Being good to others, being useful to others is what is punya. Sorry, there is no good English translation for this word punya though. Papaya paripidanam. I'm sure you know that. Whatever that is done bad to others would give you that sin. In fact, you go to any culture, any philosophy, whichever is part of the world, and this is the essence of what we have to lead our life as. And this precisely tells me care, paropakara, papaya, being unsafe is papa. So in the process of doing good, we also have to keep reminding ourselves that we are not to be doing anything bad, even unintentionally. And that's where we learn from people who keep sensitizing, bringing this awareness on standards. And so I thought in this conference, this verse would probably take home an important message at the end of our talk today. Coming back to the spirit of serving, spirit of this purpose of medical service, medical education for that matter, being in the thick of the medical education, I have always felt that there are three important pillars in the success of medical education. They keep telling that you have to provide quality education, and this word quality education has become now even more important now that the quantity is increasing. So everybody has to oppose the quantity, divert our mind away from quantity, and to make sure that we remain focused only on quality. And so time and again, wherever I have gone, wherever I have spoken, people tell me that you have to ensure that the quality education should happen. When it comes to quality, I am reminded of a couple of anecdotes in my own life, but more importantly, a recent anecdote that I have had. I've been interacting, of course, in the last 40 years of my service as a doctor, teacher, and various administrative roles I have been doing. I've been interacting with a lot of people, a lot of doctors. Each time I meet a set of doctors and I come back, I feel very proud. I feel a sense of goodness that I have been with such excellent people in their profession. I want to repeat this because I have seen, at least in my coming across in the 40 years, doctors, I have seen people who have been so dedicated, so motivated, and so good in their medical skills and profession. And to be said that I should further improve this quality, sometimes I feel we are perhaps belittling our own medical profession. Medical profession in our country perhaps is one of the very good. I have to give you one anecdote just to, I'm sure you would probably recall hundreds of such anecdotes. A cardiology friend of us, a common friend, my friend was a very senior orthopedic doctor. We were having some discussion and we were having, I think, we were together on a dinner table late in the evening at about 9 o'clock or 9:30. this common friend who is a cardiologist had a neck of the femur fracture in one of the countries abroad, very developed country. I don't want to name the country though. And he was calling him, look, I have been scheduled for a surgery. Would you like to have a word with the surgeon who is going to be operating me? So this is a senior cardiologist asking his friend in India, a classmate, who is a orthopedic surgeon, about the surgery to be done there in that country. So he wishes, he says, I'll be happy to talk to your surgeon, orthopedic surgeon, because we are could be in the same wavelength. We will discuss this and let you know. I am sure you should be reassured. So they talk for some time, etc., and he talks to this cardiologist. Everything is over. It's about 20 minutes of conversation that goes on, during which time I'm sitting with other people chatting, but I'm observing what is happening. At the end of the talk, he tells me, he was concerned. He wanted to inquire whether the surgery was fine, okay, best surgery, etc., this process is they're going to be using is a good thing, etc. At the end of it, he told me that this country, which is selling these products to us as well, we are importing from them, this person is doing a surgery which is about 15 years old surgery. Whereas today, many of our orthopedic surgeons are doing a even more modern surgery in our country. So which made me feel very, very good in the sense that we are perhaps up to date. At the same time, just about 3-4 days back, when I was in the National Medical Commission, I got a phone call from a lady doctor who is a senior, who is a consultant, or who is actually a faculty in a medical college. I don't want to name the medical college nor this person, wanting to go to some other country and wants a good standing certificate. He says, sir, in 3-4 days I have to leave unless I get the good standing. This I keep getting these calls at very odd hours, and this was at almost at about 11 o'clock in the night, and this girl had called me and saying that I want this certificate. Anyway, certificate was organized, given, etc. But I was talking to her, why was this hurry to get this certificate? Where are you going? Some country X. Okay, again, I don't want to name the country, a country which is perhaps not as big as even Delhi city itself. So that's the country she is going, and she wants this certificate. Perfectly all right. What are you going to do there? Yes, I'm going to work in a hospital under so-and-so. Under so-and-so means what? You're already a consultant, you are already a faculty. What do you mean working under? Then she said, no. Once we go there, unless we work for 3 years under a senior person, we won't get an independent registration. To be independent consultants, I have to be working under somebody. This left a very, very emotional mark in my mind. And the last 4 or 5 nights, whenever I went to bed, this conversation keeps haunting me. In a country which few months back, I heard that my friend saying that we are doing the most modern surgery vis-a-vis that very developed country which is still doing 10 to 20 years old surgery for these people. As again as that, people who are getting graduated there, the world vision is perhaps different. They view that we, in spite of being postgraduates, in spite of being teachers to postgraduates, I'm going there, they will still feel that they have to see my work for the next 3 years before I be declared as fit to be practicing in that country, not as big as even Delhi. This made a very emotional impact on me. And while I'm seeing the best doctors around me, and I know they are the best people, and I have myself had personal experience of being exposed to them and of course interacting with them. But whereas the world view has been different, where is our goal to be? The goal to be is that we produce, get out the best medical doctors. Indian medical graduate should be the prototype example as the best medical doctor in the world. Can we achieve this? This is a thought that has been going on for the last 4 or 5 days. It's just coincidental that I've been called to talk in this thing. I cannot forget this episode of conversing with this lady who is a senior PG with a gold medal and then goes on to work under somebody. Leave all these issues apart. The point I'm trying to make is how we finally achieve that best medical education than the quality medical education, which is what has been one of the objectives, the only objective, the main objective of the National Medical Commission ever since it came into picture. And I've seen people like Dr. Sharma, who was the earlier chairman, and now, of course, Dr. Achal, who has been with me even before I went into National Medical Commission. Achal Gulati was known to me in the National Medical Commission. I have seen that spirit of how to get the best out of this medical student as a doctor, and the best doctor, the best specialist, and of course, the best teacher or a best consultant or whatever you want to call it. If that best has to come out, what is the ingredient that should go in? What is the ingredient that finally results in that best output as the doctor? To be fair, I'm not asking a big list of things to come in to make that end product that is the best medical doctor in the world. There are three ingredients which I think are irrefutable. There is no compromise. And if these three things happen, the outcome is the best. One of them is, although I'm not going to put them in that order, but the three things, the three pillars of the best and the quality medical education would be a very happy student. Number two, a satisfied patient. Number three is a motivated and dedicated teacher. These three things are there. The best outcome in the medical student or a PG will happen. You may not have the best medical equipment. You may not have an overcrowding outpatient. You may not have a highly paying PG job. You may not have the what is called as a very posh classrooms, air-conditioned office rooms, air-conditioned library, and internet that will get you any information on your palm top. You may not have all these things, but if these three things are not there, a happy resident, a happy medical student, a satisfied patient in good numbers, and of course, the motivated and the dedicated teacher. This last part actually is the central thing. A happy student is a result of a dedicated teacher. As long as the teacher is dedicated to teaching and service, a student cannot be happy. Again, a satisfied patient comes as a result of this teacher who is also a clinician, who is also a person who is helping him with the laboratory reports and so on and so forth. So the central person is this dedicated teacher. All of us have that part of our medical profession in ourselves. Not just being good clinicians, I'm sure formally or informally, we have all operated as in the role of being a teacher. Some way or other, to a junior consultant, to a nurse, to a PG who is getting posted under us, or a person who is doing his thesis, or a medical student in our classroom where we have taken a class, demonstrated some experiments to him, etc., etc. So this part of it perhaps is the central thing that is going to bring out the best doctor, not only in the skill, but also in terms of that spirit of having to serve the same way that this medical teacher has been serving the other person. And this senior consultant, the way he is functioning, that I am also going to function the same way. So this essential principle of being a happy, skilled doctor, to be useful to the patient, making the most satisfied patient, is the purpose of my education. And this comes by way of my paralleling, mirroring that most dedicated and motivated teacher. So these three ingredients are centrally important. We have recognized it time and again. And in fact, the stress to a medical doctor who is pursuing, or even a medical student who is pursuing the education, has figured very important to us. And we in the National Medical Commission have debated how to reduce the stress levels and how to work towards well-being of the medical student or a PG. There are several things that we have introduced. I don't want to boast by giving a list of things that we have done, but a few things I just have to mention. Anti-ragging regulations, ensuring that the PG student gets the best in terms of prescribing some minimum conditions for a good working. In fact, the PGMER also mentions that there should be some, I wouldn't say fixed number of hours, but should be a considerable amount of overworking should be avoided. Like the point was said, maternity leave, because by the time we come into PG, very often the students would be expecting mothers, and it's fair that they are stress-free both for the child and for their education. So this was also facilitated. And we, of course, went into the suicide attempts which have come up, and we have made a something like a grievance committee. I don't want to use the word grievance committee. Any related events are being examined in the college, asking the college to come and give an information. We have also made a survey of what is the stress levels, the junior consultants, the teachers, the medical students, and the PGs are experiencing, and how we have a list of concerns that we have to address, that also we have prepared. And in fact, the number of recommendations to mitigate those concerns have been again very extensive. Those have been recommended. This entire book volume is available on the website of the National Medical Commission. And lastly, of course, many teachers may be angry on that issue, that at the end of 3 years, a person has to give his thesis. Until the thesis is approved by the guide and the college, he or she couldn't write the examination. This condition, again, we have made it different. You should do the thesis with that interest, wanting to have a research coming out of your work. Need not necessarily be controlled for whatever may be the reason by the teacher. You write, submit the thesis. Thesis will have a mark. And the examiner, who could well be your guide, who could well be your dean, could give you 0 mark, but other examiners could give you a different mark. It does not mean that this person is giving 0 and you are fully not eligible to even appear for the examination. This concern also was observed. So the PG board took a decision that he has to submit the thesis like any other answer paper he submits at the end of the examination, and complete the examination processes. Thesis is a part of rest of the evaluation that happens to this individual, and not the only issue on which he will be barred or debarred from taking the examination. So these issues have been brought out to make sure that the course of one's work in the hospital is as smooth, as joyful, as pleasant as it should have happened to the individual. At the same time, we of course keep seeing that there are overworked residents, a lot of clinical work that they have to do, a lot of expectations from the seniors, and the same unit is handled just by 2-3 consultants, whereas the 1 or 2 residents working under them have to do the entire work. So these are all concerns that have cropped up, and more importantly also the safety concerns of the doctors who are working there. These are all issues which have now come up in light, and the national task force in which I have had the good opportunity to work and put up some recommendations to the Honorable Supreme Court, which now we are also trying to bring them into a part of the condition of working in a medical college, hospital, and so on and so forth. All these things, mind you, most medical colleges have already practicing many of these things by letter and spirit, writing it to them. There could be some situations where something has been missed out, something has not happened, and so a trouble starts. So to make sure that these things don't happen also, more and more safety measures as a precaution have been talked about. And this is precisely what the standards groups of people, whether NABH or whatever it is, they keep telling us, you do all these things, you are likely to mitigate a complication having to occur. And this is precisely what we also believe in the National Medical Commission. When it comes to education that goes on, you follow all these things, it is least likely that the student will experience any discomfort, and he is continuing to be there without any burnout and complete this education with most satisfaction and with best result. So having said all these things, I probably will conclude now with a small observation about what a senior can teach a junior. I am reminded of this anecdote happened in 78. One very senior director of an institute whose driver lived in the same campus, but whereas the director lived about 6-8 kilometers away, and he used to bring him home and drop him home and bring him to the work and drop him. This driver was doing this work. And one day the director found that this man honked more while he was driving him from home to the hospital into his office. And he also found that when he parked the vehicle, more often than not, he would be so brisk to come and open the door for the director. This time it took some time. Very spontaneously, the director also had gotten out by then. By the time he came there, it would not happen. And then he would walk the director till the room, his office room. Although he wouldn't carry the bag, the director did not allow him to carry the bag. He, by nature, was a different person. So he carried the bag, but he didn't accompany him till the gate. He, after the director got down, the person went into the car and went down, drove the car back. In the daytime also, in the work, he did not see him while taking him to the wards or while taking him to the outpatient. As a different person. And after about 11:30, 12 o'clock, this person was different, was more joyful, was more efficient. He was like the original person. During the lunch hour, when he was about to be going home for lunch, director, who was a very astute observer of this behavior in his junior most colleague, asked him, look, this is the thing I have observed. What happened? Something was different in the morning. And afternoon, post coffee break, sometime around that time, you were a different person. Then he told what happened. His daughter was expecting, and she was at home. And when he was about to start the car to come to pick up the director in his house, the daughter developed the delivery pains. And at home, his wife and a younger son, the only two people were there. But this man said, my duty has to bring the director to the office. So he told the son to take her, the sister, to the hospital in an auto and make sure that it is followed up there. Mind you, in 1978, no cell phones. His home did not have a phone. The son did not have a scooter to bring and message whether the person delivered or not. They went to the hospital, delivery happened. The hospital where delivery happened, the ambulance driver happens to know him. He came on his own two-wheeler and told him that your daughter delivered or whatever problem. After that, his demeanor changed. He narrated the whole thing to the director. He told me, I felt so moved by this person's behavior. When the daughter had delivery pains, he could have taken the same car and could have come half an hour late. I wouldn't have perhaps mattered. But still, this man's dedication is something that was very appreciative. But in the narration, what I observed was that director's astuteness to observe all these changes in his junior. So dedication in this person perhaps might have come by that senior being so concerned about the junior. All these things made me change, made me learn a lot of lessons over a period of time. Bringing back to the first shloka which I said, Paropakara Punyaya Papaya Paripidanam. all through my time, can I always be thinking of being helpful to others and making sure that no one else is pained. And if that principle, if I have been following, perhaps I would probably succeed. I don't know whether I have followed or not. That's a different issue altogether. But the point is that one formula in our life, in a medical education as well, and becoming a doctor, perhaps will bring out the best experiences to that medical education process and continuing to be as a medical professional over the time. Towards the end, another anecdote of an examination, which I have to say, we always keep saying that we're all overworked, there's a lot of clinical load and so on and so forth. There was an examination which went on. The logbooks of these students were being examined to give a gold medal to a person X, looking at the logbook. And in the logbook, person X had done almost 5 folds more surgeries than the other 6 other classmates of him. And the experts thought that this man fraudulently has written more surgeries in his logbook. So he was called again and was asked to explain, how is it that you have done almost 5-6 times more surgeries than your colleagues? So this chap said, look, I was in the hostel. When I was doing duties, I used to find, I wish I had one more person to help me because there were some surgeries that had to be done. A burial had to be done, decompression has to happen. And suddenly some complication happened in the ward and I have to take the patient again to a surgery theater. All these things were happening. So whenever my classmates were doing duties, and if I was free in the night, I would come and tell them that I'm available. If there's any SOS, you take my help. And so they would let me go to do the emergency surgeries, etc., etc. In the process, I ended up doing more surgeries. It is not because it's just that I was given more surgeries. The hospital did not make me do overwork, nor would I have written anything erroneously. This all happened spontaneously. Just because I felt for my classmates, I thought I should try to be of help to them. I used to come there. I just chance that I have operated more than other people. So this anecdote, which my senior colleague told me that he found it in one of the examination days when he had gone as an examiner, again made me feel that this concept of overwork seems to be so relative, and the purpose this man had to be helpful to his own classmates, his own colleagues, made him the gold medalist, in spite of the fact that he did more work in the hospital, in the ward. So essentially, we keep our purpose in our mind, and the processes, again, being paropakaraya, and making sure that we practice all the safety procedures very spontaneously, not necessarily to have another separate department for ensuring quality and safety. Quality and safety should go along with our work. Being perfect in our work is what is called as yoga in the Mahabharata, in the Bhagavad Gita. Yoga karmasu kaushalam. The best output, the safest output is the natural thing that we should be doing it, rather than having to be dictated that you should follow these standards. Nonetheless, keep reminding us standards groups are required, but I think that should become ingrained into our professional work. With these few words, perhaps I will stop here. I thank the organizers for letting me come here and share some of my sentiments and observations on this matter. Wish you all the best. Thank you very much.
Thank you, sir. Thank you for this insightful talk. May I now call upon stage the other speakers for the session, Mr. Kalyan Shivashailam, co-founder of 5C Network India, Dr. Manodeep Sen, Professor, Department of Microbiology, Dr. RML Institute of Medical Sciences, Lucknow, and also Dr. Arun Kemaria, Senior Clinical Specialist, Elsevier. Please join us on the stage, please. Over to the session chairs. Thank you.
Can I just take one minute? You know, Professor Gangadhar, he is a great, you are a great chef, great cook. I tell you, because the types of ingredients he has brought out, the type of ingredients in medical training he brought out, all of them are meticulously when used. The dish which comes out will definitely take care of the, see, safer healthcare to everybody, including me. Thank you, sir. Thank you very much.
Thank you so much. It was a very engaging talk, sir. And we have to move on to our next sessions. We are a little short of time. The next session is by Kalyan Sivasayalam. He's the founder at 5C Network. And by and large, I think most of the conferences, I see him around engaging with people, telling about his venture. And I had an experience to meet him for the first time when he met me was 6-7 years back, I think, when 6 years back. And he had just introduced this concept of teleradiology and reporting. And I was very skeptical about it. But when he explained and when we actually implemented it, it is a really very useful tool. And now that artificial intelligence is revolutionizing radiology by enhancing accuracy, efficiency, and diagnostic confidence, they can rapidly analyze medical images, detect patterns, and highlight anomalies that may be missed by the human eye. Let us hear from him what he's doing further to reduce the turnaround time and prioritizing critical cases. Let's hear from him.
Good afternoon, everybody. My name is Kalyan, and I run a company called 5C based in Bangalore. Proud to say that many of the hospitals that keep showing up, including Sehgal sir on the stage, are delighted customers of 5C. I wanted to talk about, I know that there are a bunch of hospital administrators here, and I wanted to actually talk about what AI has done, not for radiology, but what AI has done for radiology in the context of hospital administration. And as any decent speaker would do, I want to cut right to the chase. And I want to tell you the first thing that AI in radiology has done for radiology from the perspective of hospital administrators. And that is that radiology has gone from a service or from a commodity into actually a strategy that all of you need to utilize in order to make your hospitals better, more efficient, better performing, etc. And that's actually the punchline that I want to leave you all with. That today with AI, radiology is not just a commodity, not just a service. Radiology is actually a strategy. And I'm going to give you 3 examples and then share one problem at the end of this, and we can take it from there. A brief credentials about 5C. We are leaders in multimodal AI applied to medical imaging. Today, we read approximately 1.5 to 2% of all the scans that happen in the country. So that is a lot of data. 5 of the top 10 largest hospitals in the country are also my customers. And like I said, I'm going to talk about 3 things that have changed, that AI has changed in radiology that I really want you to know. And the first one is that radiology today is not in a siloed department. Radiology is actually on the CFO's table. And I'm going to give you an example. One of the largest hospitals in the country, who is also a 5C customer, uses AI to not only understand, not only triage between normal or abnormal cases, but then further utilizes that immediately to triage abnormal cases as either surgical and emergency. We were able to cut down their general overall TAT, even for surgical cases, from 24 hours to 39 minutes. 24 hours to 39 minutes. This absolutely ensured that any case that needed surgical intervention or emergency intervention was taken up immediately. this dashboard that we have built for them is now seen by the operations head and by the CFO of this hospital on a daily basis. So radiology for this customer is not just a department. It is a source of information, a source of intelligence for them to make better decisions and for revenue improvement. Another good example, a customer of 5C is the government of Karnataka. We work very closely with them across many district hospitals and medical colleges for AI-based reporting. There is a dashboard that we have built for the medical education minister who looks at it once a week, and he's a doctor himself, just to understand what is the disease burden across each of the districts and what are the tools that he needs to equip his medical colleges with to ensure that treatments are better. So again, radiology is not a department anymore. Radiology is sitting at the operations leadership and at the CFO's table. The second is that AI has ensured that radiologists are not just delivering outputs, but they're actually able to ensure outcomes. Many hospital leaders here will be thinking that radiology in many cases fails them because reports are not as actionable as they need to be. With AI, and we have seen this live, that today radiologists can not just focus on just giving outputs in terms of number of reports that they're able to do in a day, they can actually focus on the outcomes that they want to ensure. A very good, example of this would be, again, if there is a case that, for example, needs a surgery, AI can not only flag that as a surgery case, but also based on the follow-up X-ray, help understand when the next X-ray needs to be taken, what the duration of that follow-up should be, and even identify next steps. These are screenshots of not just, of course, name changed, but these are screenshots of live products that are being utilized thousands of times on a daily basis. And so today, radiology departments don't need to just focus on what the output of the report is, but what the outcomes they can drive are. And finally, something that I'm very deeply passionate about is that imaging is the new biomarker. I personally believe that the most underutilized and underrated medical equipment in the world is actually the MRI machine. And I'm sure if I take a poll around the number of people who are using an MRI machine and let's say doing a Dixon or an ideal sequence to understand brown adipose tissue versus white adipose tissue, I'm sure there will not be many of you guys here, even though most MRIs today are capable. And imaging is actually the new biomarker. Along with Dr. Alexander Thomas, I was speaking at the Longevity India conference recently, where 5C actually runs a full body MRI protocol to actually help doctors understand their patient's longevity cycle a lot better. There are many other use cases of imaging as the new biomarker. Today, with a very large hospital in Kerala, we're already running imaging biomarker trials for predicting neurodegenerative diseases like Alzheimer's and Parkinson's. We are working with a leading hospital in Bangalore on a research around using fat infiltration in the liver as a biomarker for longevity. So imaging is not just reactive anymore. Imaging can genuinely be proactive. And AI has played a huge role. So let me go back to what I just said. I said that today, radiology is not just a department, it's sitting on the CFO's table. Radiology can now help you deliver outcomes and is not just a place of outputs. And AI is today helping imaging transform from just being a reactive product to being something truly, truly proactive. But in spite of all this, most hospitals still think about radiology as a commodity and not a strategy. A really good example is we've spoken in depth about Wopanch, then NABH, etc. But again, if I take a poll of NABH accredited hospitals, which will be all of you in this room today, and I ask you how many of you report all your X-rays, I am pretty sure in an honest room like this one, I'm pretty sure I will not get many hands up. Many of the largest customers we work with are not able to get all their X-rays reported, even though AI is live, is available, and is making radiology labor pretty much infinite. And that's the problem that I wanted to share with all of you, which is that where AI is getting today is very, very far from where the rubber is actually hitting the road in the hospitals. And that is what I want to leave you guys with and tell you that AI has really transformed radiology and imaging in a way that is genuinely unimaginable even 3 years back. Today, we have an opportunity to do all these amazing things, which is bring in radiology to the core of your operations, deliver outcomes using AI, not just outputs, and actually doing proactive AI-based imaging rather than reactive. But can we start with getting all our X-rays reported? I think that would be a very good start. And AI can really help with this. If all of you have not seen the 5C stall yet, we are at stall number 20. And my team and I would be delighted to welcome you over coffee and have a talk about how radiology should not be a department in your hospital, but actually a strategy. I hope I made this worth your time. Thank you all.
Thank you so much for finishing in time. I think it saves us a lot of problems. One thing I want to know from you, Siva, all the reports that you are sending to all your centers, how much of feedback do you really get and you take if there is any erroneous reporting? And what are the corrective methods? Because ultimately, all those reports are not only reported by AI, they are reported by some radiologists also, where the caliber may differ. Second point is, all those reports which are basically reported by AI, what is the mechanism of finding out, is that actually right, or is there error in that also?
So 2 questions, sir. One is the fundamental question around quality control, at our scale. Today, we're doing 8,000, 9,000 reports every day. And quality control is basically at the center of everything that we're trying to do. We have a very large quality control and continuous improvement department of 2 sides. So we have a human side and an algorithmic side. We try to make it as easy as possible for our customers to give us feedback on the reports. They can do it on call, they can do it on WhatsApp, they can do it even with the single click of a button on our platform. And when we realize that there is a discrepancy between the final outcome, and I will not pretend here that we have never made a mistake. Hospitals make mistakes, healthcare is fraught with it, but it is our responsibility to be as responsible with those mistakes as possible and to minimize them as much as possible. And so when we find a discrepancy, there are usually 2 loops that we run. We run a human loop and an AI loop. The AI loop is actually a lot easier, sir. We understand whether if the AI has made a mistake, we have to retrain it specifically on that type of mistake that it has made. So for example, if it has misclassified an NG tube in, let's say, an ICU chest X-ray, we have to ensure that the AI that is deployed there is correctly identifying NG tubes. On the human side, it's a little more complicated because humans are more complicated. And so we have to first give this feedback, communicate it with the radiologist who made this error in a professional and not in a punishing manner. And then also at the same time, we track errors by person, by modality, and by pathology. So if a radiologist misses an appendicitis once, it's a problem. But if they miss it twice, if they miss an appendicitis on a CT abdomen twice, that means they're not focusing. That time they go into a separate loop. The second question that you asked is around quality control on AI, right? I think that was your question, sir. Quality control on AI. For AI quality control, I think the fundamental answer to AI quality control is as much oversight as possible. And so we ensure that we're always giving the AI to a human at the moment to ensure that we are delivering output. And each customer can kind of customize their output, sir. So usually there's a threshold of 0.5, 50%, where we predict something. But you always want to make the AI predict more and the radiologist to validate the prediction rather than, tell a radiologist that something is not there when it is actually there. So we will make our models more sensitive, less precise, because we know that there is human oversight. I hope that answers your questions.
Yeah, thank you so much. Basically, that means the future of radio imaging lies in the collaborative synergy between human expertise and machine intelligence. And that's
100%.
what we are aiming for and hoping for good.
100%.
Now, going on to next session, we'll try to keep it short by reducing 2 minutes for each one of them if they can manage. Let me invite Dr. Manodeep Sen. Dr. Manodeep Sen is the professor of Department of Microbiology, Dr. RML Institute of Medical Sciences, Lucknow. And he has a lot of academic contributions and a lot of workshops and research activities which he has been conducting over a period of time. So he is going to speak on standards in hand hygiene, the right hand rub. Thank you so much.
So a very good afternoon to respected speakers, chairpersons, and the audience. So I'll be talking about the standards in hand hygiene, how to choose the right hand rub. So the reason I'm talking about hand hygiene is because hand hygiene is the primary measure which has been proven to be effective in prevention of healthcare associated infections as well as spread of antimicrobial resistance. So first international guidelines came in around 2009, and we know that contaminated hands are the commonest route of the transmission of these healthcare associated infections. So hand hygiene is the actually the umbrella term for inclusion of hand wash as well as hand rub, which we'll be discussing and comparing later on, along with surgical hand hygiene. So a bit of microbiology behind the hand hygiene. So the skin flora is either the resident one and the transient one. So the resident flora is less likely to be associated with these healthcare associated infections, and it is the transient flora which actually colonizes the hand and is transferred from the healthcare workers to the patient. And this is what we must concentrate upon. So from social hand hygiene to clinical hand hygiene and finally to the surgical hand hygiene, it is the transient flora which we are focused upon, and gradually on and on, the resident flora also is substantially reduced as we go on to the surgical hand hygiene. So it's not only the product, it is the identification of right moment of hand hygiene as per World Health Organization and the correct technique of hand hygiene of hand washing within 40 to 60 seconds and of hand rub within 20 to 30 seconds. So it is the technique and the identification of moment which will make our hand hygiene effective. So when are we to concentrate only on hand wash and not hand rub? So we have to do exclusive hand wash when our hands are visibly soiled. If there is exposure to Clostridioides difficile, to infectious diarrhea or during norovirus outbreaks, or if there is exposure to Bacillus anthracis. Also, we know that with hand washing with soap, it is better for enteric and respiratory viral reduction than ethanol-based hand disinfectants. So just to compare hand washing with hand rubs, they fare better because of ease of use, accessibility, short time required, and effectiveness in killing these communicable pathogens, while the recommendations for hand wash we have already discussed. So to select an appropriate product, the product must contain an isopropyl alcohol, ethanol, or a combination of both in concentration between 65 to 95%. It may contain an antimicrobial or non-antimicrobial soap for all routine hand hygiene. For surgical antisepsis, there's again alcoholic-based hand rub, 0.5 to 1% of chlorhexidine gluconate for persistent activity, while 2 to 4% chlorhexidine gluconate for maximum persistent activity. So to select an effective hand rub, first, that product should have the efficacy for decontamination of hands and should be efficacious in clinical use. And it should comply with the current standards. And it is our awareness regarding these standards and certifications of the product, which is vital for selection of an effective hand rub. So just a moment regarding the chlorhexidine. Chlorhexidine itself is a cationic biguanide. It's available both as a solution and as a scrubbing agent, and it has a very broad spectrum of antibacterial activity in which gram-positive coverage is better than gram-negative. However, it has some limitations of activities, is pH dependent. It cannot, cleaning is required because activity is reduced in presence of organic matter. So, main thing is that on the basis of previous RCTs and studies, we know that alcoholic-based preparations are more effective as a hand hygiene agent. So again, since we have already, it is known that alcohols, they are strongest and fastest activity against a wide spectrum of pathogenic, both bacteria, fungi, they have low toxicity and mode of application is simple. Some of the products have sporicidal effect as well as virucidal effect, like the Zuagard CHI hand rub. So the European guidelines are some of the most stringent ones, that is mainly sporicidal, bactericidal, mycobactericidal, virucidal, fungicidal, yeasticidal, and even hand hygiene and surgical hand disinfection. So this product has a standard 70% ethanol with 2.5% of chlorhexidine gluconate, containing all the European certifications. So best practice for implementing this is audits, which have to be regularly feedbacks to the healthcare workers, and local programs of education, social marketing, audit and feedback should be there to consolidate the same. Single interventions will have limited and short-term influence. Reminder, feedback, accessibility, and multifaceted approach will consolidate these hand hygiene protocols. So to summarize, hand hygiene is the single most effective measure to prevent healthcare associated infections. I'll reiterate again, it's not only the product, it's the identification of the right moment and the right technique of hand hygiene, which is going to make it effective. Standard is 70%, 65 to 95% ethanol with chlorhexidine, which we have already discussed. One thing I wanted to discuss, that with repeated use, the hands may be dry. So incorporation of emollients like glycerol and lanostrol, they are better tolerated with fewer these adverse skin events. And how to choose is, so validation of this product as well as based on WHO, CDC, or European guidelines with certification is important prior to its clinical use. I thank you all for the patient listening.
Thank you so much, Dr. Manodeep. I think the message is very clear. The right hand rub at the right time in the right way. Thank you so much. Let's move on to the next topic. Let me invite Dr. Himaria. He is a clinical specialist with Elsevier, and he is not only a doctor, but also an MBA, and is working on AI, and that also on generative AI. What we need to listen from him, his view about ensuring responsible deployment of generative AI.
So good afternoon, everyone. Thanks to the speakers and chair for allowing me the opportunity. And I know we are a bit behind the schedule, but happily sacrifice some of my time to listen to more anecdotes from Dr. Gangadhar, our teacher. So it was great. Can you sort of switch the slides, please? No. So in the meantime, while the slides come up, I'll just introduce the whole concept of generative AI and ethical deployment. AI, as Kalyan also mentioned, is at the forefront of everything. And yeah, thank you. So my topic is ethical deployment of generative AI. And from the representative image, you can see that there is a doctor who's consulting a patient with an iPad, which sort of is like what we are trying to suggest. The doctor is using the iPad and not the patient. So it's always the technology is for the clinician to make use of. So what we will sort of discuss and learn by the end of my session is that how generative AI is impacting healthcare, what kind of application there are for generative AI, what kind of ethical deployment strategies can be utilized, what are the common pitfalls that an organization can encounter while using generative AI, and then we'll try and learn some of the pillars, how we can efficiently manage those pitfalls. So AI is not a new thing. Dr. Alan Turing, famous from the imitation game, in the 1950 paper, did describe or did ask the profound question, can machines think? And then Arthur Samuels developed some sort of a machine learning algorithm to play a game of checkers, and then they coined the term machine learning. A lot of different adoptions, evolutions happened over time. But then 30th of November 2022 is the date marked in history when GPT came to public, consciousness. Everyone discovered that there can be a tool, there can be a chatbot where you ask question, it replies back, it gives you something interesting to sort of ponder upon. So that is the present milestone, historical milestone in the AI development. That is 30th November when GPT came out. The difference essentially being that AI is where machine is asked to think like a human and solve problems, while generative AI is where you, on a pre-existing data, where the machine learns and creates text, image, music, videos, deepfakes, whatnot. And then it's not perfect because the image, those who can see well, and maybe afterwards you can zoom in, I asked the generative AI to create the definition of generative AI on a monitor, and it does have its own mistakes. I think a good look can see the kind of mistake it does. So it's not perfect. Potential applications, some of the very innovative organizations like the one Kalyan represents are working on a lot of different use cases, the predictive modeling ones, the kind of where imaging is being used to create better results. But I'm going to focus on two parts. One is the personalized treatment one, and one is the clinical decision support, because these are the ones which are heavily influenced or have a very good future with generative AI. So just humor me for a minute. Here is a generative AI. You're trying to ask a question. What is the latest in epilepsy management? What it does, it looks into the query. It breaks it down into various kinds of terms. Then it looks at various kinds of resources that may have answer to this question. And then through the capabilities of large language model, it creates a human-like answer to the question. Again, you can follow up that question with asking another question, that what if the patient is a pregnant female? So then it again has to dwell into literature, dwell into journals, dwell into books, and then find out an appropriate response to that. This is how the generative AI system works. It converses with you, takes into account what you have asked previously, and then generates a response accordingly. Now, before we go on to the further implications of generative AI, let's see what pitfalls are there to be avoided. The first and foremost is the black box phenomena. Black box certainly means that you do not know how the answers are getting generated, where the answers are coming from. So some of the organizations like ours, which has through history done what is considered the scientific good, which means that promoting peer review content, we have always felt that the black box does not serve well in the healthcare industry. You have to know that what kind of studies, what kind of research supports any kind of interpretation. So removing the black box is important. The other part is the administrative pushback is always there, because like any other technology, it requires you to sort of modify your ways. It requires you to change your approach towards patients. There is always the phenomena of, or the danger of, letting the generative AI do everything alone. So the lack of oversight is a definite pitfall. There always has to be someone looking after it. That's why I'm saying that the clinician in the loop should always be there. Then there is the twin side of it, where you try and make a hurried implementation. You try and find out how best you can utilize AI. And then you look at ROI from that point of view, that from tomorrow I get to get more efficient, I get to save money on some other kind of processes. So that's not the right approach. It takes time to get established. It takes time for your clinician teams to get understanding of how this can best help them save time and save cost. The evolving role of a clinician is also very important, that it's not there to replace clinician. It is a digital second opinion for the clinician, not for the patient. It is for the clinician. The clinician remains a touch point for the patient. They have to do the clinical validation. They have to do some kind of overriding protocols as and when required. The system also learns. They have to make sure the edge case scenarios where socioeconomic factors and other kind of self-harm scenarios where a generative AI cannot supposedly take a call. Like Dr. Gangadhar was explaining some of the anecdotes, where a human factor decides why the driver was going through what he was going through. That only a human can understand. So those kind of edge case scenarios, clinicians are always required. There is an interdepartmental coordination that is required to create the best use of any kind of AI. Now, these are the pillars. So first and foremost comes transparency, which means that rather than a black box, there should be a glass box. Wherever and from whatever sources the output is coming, we should know what is going behind from those sources. What is the fundamental basis of that information? That is very important. Same is with accountability, that some teams, someone has to be accountable for the final answers. There is an important phenomena which is called clinician in the loop. I think Kalyan also mentioned it, which means that internally and externally from both sides, clinicians always take charge. Wherever you feel the generative AI is not given a response which is up to date or which has some lacuna which can be better, there is always an option of feedback. And then from us, from our side, the teams look at that response and do make those kind of changes. So those are required. And then there is always the phenomena of data privacy that the DPDP Act looks at. You have to make sure that you do not put in any kind of information that the patient can be harmed through. So the continuous improvement part is very important. Any technology gets outdated very often. So there has to be continuous improvement. There has to be coordination between teams. Again, I tried the same thing with generative AI and you can see it's not perfect. So that's what I'm saying, that if you look at generative AI as something which can replace you in some sort of a context, it's very difficult. It is not that there yet. So in conclusion, generative AI is here to stay. It is coming. Second is that it is always, it is a very good digital second helping hand. It's not replacing anyone. There is always a need for the clinician to remain oversight of what is going to be done with it. Continuous improvement is the key. We have to make sure that continuously it gets updated. The kind of sources from where data is coming also needs to be more and more robust in terms of their nature. The guidelines, the consensus have to be more and more data driven. That's where the whole process can become very, very smooth and the organizations can make use of generative AI to sort of have more efficiency and more cost. Before I go off, one plugin from Elsevier, we have a generative AI. We are at booth number 29. Clinical Key AI is a generative AI conversational platform which is powered through the content that is derived from books, journals, drug monographs, all kinds of verified resources. It converses you in a manner another clinician would. It tries to help you give insights into any kind of patient scenarios. It does give you that opportunity to create a kind of a history of a patient with various kinds of parameters coming in, various kinds of responses coming in. So it's something very fascinating for a clinician to do. Please do try out. We are at 29 number stall. It's at the low ground floor. Thanks a lot.
Thank you so much, Arun. So it was really a potpourri where we could listen to different topics and different ideas. Before I end this session, which was very beautiful to listen, let me ask Dr. Thupil if he has to give some final comments.
Thank you very much. It was a wonderful feast. First, we heard keynote speaker telling us how to prepare good professionals for patient safety, patient care. At the same time, following that, we had experts who have come out with how to achieve with the technology. It's a fantastic combination of two things. Let us give a big hand To all of them, thank you very much. Thank you, sir. Thank you. Thank you. Maybe at lunchtime you can interact with them and get your inquisitiveness, other clarifications from them. Okay, over to you.
Thank you, chairpersons and the speakers for the wonderful session of potpourri. So now may I request our chairpersons and the speakers to step forward for a group photograph, please. Thank you. The next will be a lively session, the MOU signing between CAHO and the various other organizations. To begin with, MOU with Mahatma Gandhi University of Medical Science and Technology. The purpose of this MOU is to set forth the terms and conditions pursuant to CAHO's educational training, consultancy, and research services with Mahatma Gandhi University of Medical Science and Technology for students and industry professionals, external training, consultancy, and research. May I call upon the team from MGU MST Jaipur and also the CAHO organization, Dr. Vijay Agarwal, Dr. Lalu Joseph, Professor Dr. Achal Gulati, Dr. Sandeep Narula on stage, please. May I also call upon Air Marshal Professor Dr. Pavan Kapoor on stage, please. Dr. Pavan. As the MOU is being signed between the two organizations, may I request our audiences to applaud and encourage the members on stage.
Ladies and gentlemen, we are extremely proud that we are signing this MOU. And this is again like reaching one milestone after the other for CAHO to reach out to every segment. How do we reach out with the message of promoting patient safety and quality? And extremely proud that today we are having this MOU with one of the most prestigious institutions of the country in Jaipur, of the Mahatma Gandhi University, of which Dr. Achal Gulati is the Vice Chancellor. So, or the Chancellor, so thank you. Thank you for signing this MOU.
Thank you for the opportunity, sir, and everybody over here. I can only assure CAHO on one aspect. After the signing of this MOU, Delhi Police has a motto. I'll steal that motto and modify it to with you, for you, always. Thank you so much.
Well said, sir. Thank you. May I request the team for a group photograph, please? Thank you.
Thank you. May I request Vijay sir, Lalu ma'am, and Air Marshal Pavan Kapoor sir to please stay on the stage, please. We now move on to a significant moment in today's proceedings, the formal signing of Memorandum of Understanding between CAHO and EBEC Med Adventures Private Limited. EBEC Med is committed to upskilling of healthcare professionals through its SHINE, Skills in Healthcare Integration for Nursing Excellence, using OSCE-based assessments and simulation-based learning, thus ensuring enhanced clinical competency, improved quality of care, and ultimately better patient safety. This MOU marks the beginning of a collaborative partnership focused on strengthening nursing education, promoting patient safety, and initiating joint research and development in healthcare practices.
Through this alliance, EBEC joins CAHO as a knowledge partner, contributing to skill development and capacity building quality healthcare initiatives across India. Through this alliance, EBEC joins CAHO as a knowledge partner, also contributing towards building a safer healthcare. We have on the stage Mr. G. Shrikant, Chairman and Managing Director, EBEC Dr. Jyoti Clara Michael, Founder, HealthBridge and Chief Strategic Advisor, EBEC and the team CAHO.
So thrilled we are aligning with CAHO. So what we plan to do is do a detailed skill gap analysis along with CAHO. And I thank every stakeholder for giving us this opportunity. Thank you.
As we can see the smiles radiating on stage, let the MOU signing be a beginning of all upcomings and the new ventures. Thank you, everyone on stage. May I request the team for a group photograph, please?
Thank you. Thank you, everyone. Moving on to the session 14, Walking the Tightrope. The topic on balancing compliance and practicality in healthcare quality management. We have the moderators for the day, Mr. Gaurav Loria, Senior Vice President, Head Operations and Service Excellence from Apollo Hospitals Enterprise Limited, and Dr. Anna George, Group Head Quality, Aster DM Healthcare Limited, India.
The topic for session 14, balancing compliance and practicality in healthcare quality management. Along with the moderators, we have our speakers, Dr. Shravan Kumar, MHA, FACHE, CPQH, HACP, Head of Quality and Patient Safety, Mediclinic City Hospital, Dubai, UAE. Kindly welcome with a round of applause. Thank you. Dr. Deepinder Singh, Regional Head, Patient Safety and Quality, NMC Healthcare UAE. A round of applause, please. Dr. Nisha Nair, AGM Medical Affairs, Quality and Patient Safety, Aster DM Healthcare, GCC Dubai, UAE. Ms. Rashmi Srivastava, Vice President, Group Quality, Narayan Health, Bengaluru, India. Dr. Sheikh Moeddin, Chief Quality Officer, Al Dafra Hospitals, Abu Dhabi, UAE. Dr. Jennifer Kozeli, Director of Risk Management, American Hospital, Dubai, UAE. Mrs. Gracie Matai, Group Chief, Quality and Governance, Baby Memorial Hospital. Welcome you all on the stage, and I hand over the session to our moderators, Mr. Gaurav and Dr. Anna. Thank you.
So very good afternoon to you all. We completely understand that some of you have had your lunch and you are back here. So I'm assuring and assuming that all of you are going to stay back, and people who are a little hungry, just manage it for some more time. We'll try our best to give you a lot of good details from this session, which will be hopefully helpful, and look at some of the smarter things that all our panelists here are going to talk about. So starting with, the epic of Mahabharata. During the war at Kurukshetra, it was actually, Krishna asked Yudhishthir, who was the embodiment of, all the good things and wisdom, to announce that Ashwathama is dead. It was half truth. He was not dead per se, but what it resulted in is it resulted in winning the war at that point of time, which was likely of good over evil. Now, what does it actually tells us? It actually tells us that sometimes these moments teach us something which is very critical. Something that, it's not that you have to do everything and comply to everything to make sure that you always have a good outcome, right? In one of the WHO 2022 clinical reports, it just came out that 56% of the professional healthcare professions, they spoke about and said that too much focus on compliance reduces their work output. In one of the other studies also, it was looked at that, 60% of the people felt that more of clinical documentation actually detracts them from, putting in an effort towards patient care on the ground. So that's what the data talks to us, and that's what the data is, or the reality is all about. Now, if I have to ask all of you sitting in the audience 2 questions. One, how many of you would, if you have to choose between what you are actually doing as per what the policy says and what is right for the patient, how many of you feel that there is a difference? That, the policy says something, but what is actually right for the patient is something else. Can you just raise your hands? Cool. And now I really want all of you to be a little honest. How many of you have actually uploaded a policy just for the heck of a survey? I know that yesterday there was a debate about it, but you've just uploaded a policy or prepared a policy that it's not going to help you. It's not gonna be implemented well in your organization, but you have uploaded it for the heck of it. How many of you feel that ways? Okay, I see a less participation in it. Looks like most of you are very confident about it. But with that, I just want to say that these are just not the questions, right? These are kind of signals that largely tells us that good patient outcome is not about breaking rules, breaking the policies or not following the policies, but bending them for the right reasons when they are required largely to be done in the service of safety, compassion, and good outcomes, whether clinical or non-clinical. So that's largely about a quick intro about the topic. This is not a debate session. This is more of a discussion session. And I would request my co-moderator to talk to all of us about her inputs.
Thanks, Gaurav. Very good afternoon, everyone. And I think Gaurav has set the context
right for this discussion. So these couple of questions that Gaurav just asked, I'm sure all of you relate to. I've been a quality manager for most of my career, and these are questions that keep popping into our minds as well. And along with that, I'd like to also ask how many of us have actually put a policy in place because we wanted to close a non-compliance, which has come up in our NABH report. So many times, we may feel it needs to be closed because the standard says so. How do we convince stakeholders? And who are these stakeholders? Yes, at the forefront, we have our patients, but they are not the only stakeholders. We have a lot of other people we have to deal with, people who work at the ground level, people who are in the boardroom. It's very important that the solutions, or rather the statements we make, are aligned to everybody who are involved. Now, saying something which is a standard is one thing, and putting it into practicality is another thing. Second thing is, at the end of the day, why are we doing this? Unless we are all convinced why we are doing this, we may not be able to sustain this. So quality in general are not just about meeting some standards for the sake of an external accrediting body. It's also about enabling people and ensuring these solutions have, there is an effectiveness seen at the ground level from the operations perspective, as well as enabling patient-centered care. So a lot of questions and a lot of trials that we have undergone, I'm sure at all your level, our level, will be addressed today. And these are some of the industry experts who have had years of experience working in quality as well as in administrative levels. And these are going to be some real scenarios, and I'm sure it's going to be interesting for all of you. And let's hear it from the experts. Over to you, Gaurav.
Thanks, Anna, again. So today we have the leaders with us who are just not, who have faced the heats of the corridors, but also looked at the policies and how to improve different policies and systems on the ground. And we are going to pose some interesting questions to them to understand from them how did they handle situations when the compliance met actually chaos. So we have 3 rounds largely for this session. The first round is when compliance hits reality. So my first question for that is to Dr. Sheikh Moinuddin. A system-wide compliance dashboard shows declining scores in multiple departments. Leadership wants immediate corrective actions. As such, any leader look at it, I want it now. Even that may take some time to get it improved, but obviously they want it now. And when they ask for it, departments say that I have got my operational constraints and I really can't work much on that. How would you respond as a chief quality officer for your institution? Central push or a unit level flexibility?
Thank you. Hope you're able to hear me. Yes. Thank you, Gaurav, for that question. I think the topic and the question, they both gel together, walking the tightrope. And that's what exactly happens when what to do. Is it the central push, or is it a kind of a hospital level kind of empowerment? But I would balance, and I would stand in the middle saying, yes, both are required, but there should be some sort of approach to it. And I think the best approach is, I call it as an ABCDE approach. And what I mean by that is, A is alignment. So that's a very important thing to begin with. There should be a very clear alignment on non-compensatory issues. We cannot compromise on certain things. And that comes from the governance, that comes from the leadership, that comes from the central push. And that has to be there, because if that is not strong, then the organizations or the hospitals, they will not have a very clear sight on where to progress. So that central push needs to be there on at a group level. And then what happens is how you deliver that needs to be kind of decentralized, and let the front-enders speak and put the plans that can actually work for them. And I think the question mentions a lot of departments. So one size cannot fit all. Again, it has to be tailored to that particular department. So that's about A, alignment. B, I think as the group, you need to create a very good blueprint of success for those people on the ground, because you are the leadership
for those hospitals. So that the blueprint should be co-designed with the ownership of hospitals. When I say C is your corporate leadership has to have a very clear communication plan on what you're going to do. And again, you cannot run and do all at once. So kind of a tiered approach on level 1, 2, 3. These are the ones which need complete ownership and complete support from the centralized approach. Whereas maybe tier 2, they can do a partial approach where one of the person can represent onto that hospital leadership and govern them. And maybe tier 1 or those who can self-manage and we can push them, just provide the support necessary from the top. So that's about C. And D and E can be clubbed together. One is the data information should be available and the data should be available for the board. And when I say E is about education. So there could be a lot of peer learning, groups to groups, departments to departments. One that is growing well, improving well, can learn from the others. So I think that's in summarizing ABCD approach would suit for this kind of.
Thank you
things.
so much.
Thank you.
Though you took a little extra time, but very gently he's introduced one more acronym that can get into what could be called as a policy for the future. So thank you for that. And I would request the other panelists to please restrict to 3 minutes. My next question goes to Dr. Jennifer. You are notified of a near miss serious medication error in your particular hospital. Obviously, you do have all the policies in place, but then the awareness among the frontline staff is a little poor on that. How do you balance a rapid risk response with sustainable learning across the hospital, which is largely a challenge for most of the healthcare institutions?
Thank you for this important question. Basically, this is something that we face every day. How do we go around near misses and how do we do those investigations and how do we have the frontliners be involved and engage in reporting the near miss? The first thing that we have to look into whenever patient safety event happens is we need to make sure that the patient is not harmed. That is the first thing that we need to look into. Now, this is a near miss. It means that it did not reach the patient, so the patient is not harmed, but that does not mean that we just have to sit and do nothing about it. This time, nothing happened, but next time, something would happen to the patient. And talking about a high alert medication, we're talking about basically a sentinel event could occur because of that. So the first thing we have to do a rapid response, risk response, which is do a prompt investigation to see what actually happened on the ground, involve the stakeholders, the nursing, the physicians, the pharmacy, to identify what happened. Was it an ordering? Was it a prescribing error? Was it a dispensing? Was it administration error, monitoring error, or even was it a storage error? So that is the rapid response investigation within 24 hours to identify what happens and engaging the stakeholders to make sure that everybody is involved and engaged. Then we have to make sure that this result is being discussed and communicated in safety huddles, in the morning huddles of the nursing team, pharmacy, and the leadership rounds as well. This is for us the rapid response risk team, let's say. The next thing is you want to prevent this from happening and you want people to be more engaged. So we need to do a root cause analysis because we all know that when a gap happens, it's not only one issue that led to the safety event, it's multiple gaps happening in our different safety layers that happen at the same time that led to the event. So we do an in-depth analysis. We do use the 5 whys to identify what are our system failures, human failures, equipment, environment, policies, processes. So we kind of identify those gaps. We come up with recommendations and action plans. We identify the stakeholders that need to be involved in those action plans and recommendations, and we put a timeline for implementation. And usually what we need to do is our risk department or quality department needs to make sure that these are being followed up. And we need to engage the stakeholders in these recommendations. Learning, education has to be part of it. So we need to do modules of education related to our gaps identified. And it shouldn't be just one-time thing. It has to be continuous learning and it has to be mandatory for all our staff as well. That is for me, this is our response. I'm trying to be on time. One more thing I want to add, adding to Dr. Sheikh, is leadership support and the culture is the most important thing. We can do all of those, but however, if you don't have a leadership that's orchestrating, that's managing, that ensuring that the culture of safety is there, and it's important to have that, we're not going to be able to implement any changes. So thank you.
So thank you. I think very well articulated the next steps on what happens if there is an incident. Please stick to timelines once again. My next question is to Ms. Gracie. You are kind of rolling out a digital handover system in your hospital. Technology is great. You have done all the training. Obviously, compliance is poor. So what strategy would you adopt to increase the uptake without compromising either the timelines that you have been given or making sure that you don't lose out on clinician trust?
Thank you, Gaurav, for that question. Now, what is happening in my own hospital with the same experience I'm going to tell you. See, first we may have to engage our clinicians at the early stage. And then we also should have a task force for the digital intervention. And that task force should approach to our clinicians maybe on a departmental basis or an individual basis. And then you see that where they are lacking and that particular base, you may have to talk to them. That's the second thing. But and you realign your training based on the requirement of the doctor. See what has happened. Now today, the EMR and the IT is so difficult that even you have to go to a patient data, you have to click 5 times or 10 times. So that's one of the major problem what they are facing. See that will be seamlessly adopted by everyone so that they will use that. Now, again, you can build an accountability between the people. When I say accountability, I don't want to tell you that you punish the people. It should not be punitive. But at the same time, maybe we can have a small incentive. At the same time, we can have a pilot study at one, maybe basically to the high risk areas, ICU and all. And that success you can bring and that you can put it into other areas. So that may work. And you also can take the help of some early users. So there will be some people who will be already accustomed to that. So you can call them and let them be your spokesperson for that. This is what again I see. Another thing, you make your data visible. See what you are doing, people are not knowing. So let it visible to them. Let them understand, yes, they have introduced and this happened to their department. So I'll also do that. So this will be benefit of that. Let them understand. Otherwise, they don't know the benefit. They think more work is being given, double documentation. So those is the feeling of those people. I think if you can do that, that will be better in our hospital, but we do that. And that I think that we can do everywhere. Thank you.
So thank you. I think you did touch on some of the pain points that all of us face. I also face similar pain points. We have been trying and working hard towards making hospital digital. Though all of us claim that we are very digital savvy, we do everything digital, but then when it comes to implementation, it's a challenge. So thank you for sharing that information.
We move on to our next panelist, Ms. Rashmi Srivastava. That side, yes. So during a routine group level quality review, a high performing hospital reports lower scores due to a patient-centric workload that bypasses a mandated protocol. How do you handle innovation versus policy uniformity across units?
Thank you, Anna, for asking this. I'm sure, I think you are aware that Narayana Health as a group, we are a JCI Enterprise accredited organization, and consistency and standardization is a key for us, right? And that has to be maintained across the group. So your question is right. I mean, this is our regular scenario which we face, that, that units are taking or the hospitals are taking work around. But that is something is a marker that, something is happening at the unit because innovation is happening and we have to encourage or open that loop that, the local innovation comes to us and which can be incorporated in our policy. But as we know that, the balancing between the consistency, protocol, standardization versus the local innovation has to be balanced for any good system. If you want to make a good system, you have to balance both, right? So for that, we have a very structured process, which we call it in our group is either approved variation or we call it structured flexibility, right? So any unit or any hospital or any department which wants to do an innovation or they want to do a workaround with the policy which is standardized at the group level, they send us the requirement that this is a requirement and why we have done is what is the trigger, why, what is going to change, what is the impact of that. And that gets reviewed at the corporate level or maybe a hospital leadership level. And post that, we decide whether it has to be incorporated or it has to be moved into a shared learning model, which can be incorporated across the group. So, I mean, we don't give them a low score. We always value that value-based behavior, because local innovation will not come if the unit is not, or the hospital is not aware that what is happening on the ground, and they are not aware of the policies and procedures. So they look at the policy procedure, they look at the ground practice, they come with the local innovation, and which is one of the best marker for the continuous improvement. So we always encourage that, and we get that flexibility and try to incorporate in our system. And that is giving us a culture of continuous improvement in entire Narayana Health. Thank you.
Thanks,
So
Rashmi.
I'm on time.
That's a great balancing act, what quality managers do often, right? And there needs to be a balancing act at the leadership level too, and probably certain non-negotiables which need to be looked into. Moving on to our next panelist, Dr. Shravan Kumar. This is something that's quite a familiar thing, in most of our units. JCI reaccreditation is due. Staff fatigue is high. A few critical safety drills haven't been done. Do you prioritize documentation readiness or ground level drill execution with limited time left?
Thank you for the question, Dr. Anna. So for me, it's a no-brainer. We would have to do the drills because your accreditation would be at stake. But the whole point of doing the accreditation, we need to understand, is for patient safety. So at the same time, you need to alleviate the fatigue and stress among employees. So as a quality professional, I would do 4 things to address this. One is communication, clear communication on why do we do what we're doing. Driving the narrative using patient safety as the component versus accreditation. The second thing would be risk assessment to prioritize which areas added patient safety risks when it comes to not doing these drills. For example, a fire drill in a utility systems area versus in an outpatient department, a chemical spill in a laboratory versus again in patient care areas. The third thing is integrating the drills into the daily workflow and making it fun. The standards, no matter what standards you take, they're not prescriptive. How should you do these drills? So often it's the quality professionals who interpret these things in different ways. So there are multiple ways you can do the drills, doing unit-based drills or tabletop exercises or just simulation exercises without having to involve everyone disrupting the function of the entire hospital. The fourth thing would be providing some support in terms of documentation. Maybe a member of the quality team or administration could go up to the unit and help them in documenting the drills and making sure that the staff don't feel the burden that it is their responsibility to do the drills and also document. So these are the 4 things I would do. Thank you.
Thank you. Thank you, Dr. Shravan. So to add to that, I think drills should be a part of everyday activity with a proper strategy and not something done just before. So we don't face that situation of fatigue and you're ever ready for any external assessment. Moving on to our next panelist, Dr. Dipminder Singh. One of your regional hospitals has had a recurring patient complaint related to, and I'm sure we all experience this, related to waiting time and discharge time. How do you approach system level practical changes without breaking compliance rules?
Sure. Thank you for the question. In fact, this is a problem for most of the hospital when we talk about the waiting time. And of course, discharge is one of the commonest thing, including the OPD also is the next one. So what we do in our scenario and practicality is that understand exactly what are the requirements. Now, what we do is that we generally get everything right except for engagement of patients. We somehow fail to ask the way it should be, that how much is your expected waiting time? When that is not asked, probably we are ending up in a wrong footing. So that's the first thing. And when we are talking about expectation, setting expectation, this should be set at every point. Like every interaction with the staff and the patient should be setting an expectation, which is often missing out at the time of discharge, how much you will have to wait at the time of billing, waiting for the doctor, consultation. So I think every point, if like, all of us have been patients at any point of time. If we know exactly how much is the time approximate, we don't mind. Okay, if I'm going for a movie ticket and it's a new movie release, and imagine there's no online booking, I will have to stand in a queue, and I don't mind like 1 hour, 2 hour also. But if I'm just like, out of like, people are coming to the hospital, they're not happy people. Okay, they're somebody is not well, I'm not well, my father is not well, mother is not well. So they're not happy people. So to set them expectation, they're already frustrated is very, very important. So that's important channel to set the expectation. And also we need to have a monitoring mechanism in which they can engage. So like, you have seen discharge boards in the patient rooms. So that plays a huge role. A digital board we have recently replaced. So a digital board which patient can interact, patient can know what is the time for me to discharge out of the hospital, who is coming to care for me throughout the day. That's important. And there is no best way to do the things. That's one of the things which I personally learned. We need to start towards an improvement. We cannot wait, okay, this is a time when we will be launching this to have this kind of outcome. Every improvement, a small improvement is an improvement. So we need to appreciate staff. I think staff appreciation is also missing in most of the hospital, including where I work sometimes. So appreciation at every point of time, even a small improvement in the waiting time should be appreciated, should be celebrated, and then move on to the next target. So engagement with the leadership, engagement with the patients, and also with the staff is important role, which helps us to make sure that we are on the same page. Thank you.
Thank you. Thank you, Dr. Singh. We move on to our next panelist, Dr. Nisha Nair. So, hi. So you're designing a group-wide audit checklist. Some hospitals in the network are highly digitized. Others still use paper-based system. Again, something we can relate to when you're working as, at a group level. So how do you build a framework that's both scalable and fair across units?
Thank you, Dr. Anna, for this question. So when we are handling group, it's a big diverse network. So it's very important that we include ingredients of flexibility. It's very important that we are inclusive and we are consistent. Okay. Define a universal standard of your checklist. First thing you can do is start with a survey. But then again, that can be cold. So it's very important that you include some interviews and discuss with your team members across the group that, what's the current status. Once you have the information in place, this would have also helped you contact, understand the challenges. Next, move to defining a universal audit criteria. What is it that you would like to look into so that you can include it in the checklist? Try to develop a modular checklist, so you can have some universal parameters in it, and then you can have sections where units can customize it. Now, when you have a group which is digitalized and few of your hospitals are paper-based, again, it becomes very important that you have structured formats when it comes to your paper-based checklist, which matches to your digital components also. Now, there are multiple tools that are available. One of them, you need to leverage technology. And during this time, you also need to understand that when you're designing this, how are you going to, have a transition from paper-based to a digital model of your units? This is your opportunity for change management. So again, here, you can use multiple tools like Microsoft Forms. You have Jot Forms, which are subscription-based. If you have total paper-based audit tools, which are standardized, maybe you can convert them into an Excel and upload it on your QMS systems. Like, for example, we have MedBlaze, which can, give you standardized dashboards once this data is uploaded. We have newer technologies like OCR, these can also be looked into. But again, the challenge would be the cost, the server storage and all that. And also, if you are aiming to go green, it may, not serve the purpose, or it may be somewhere like, again, you're storing papers. So think in a way that, you can incorporate it well. Google Sheets are also available, which are the easiest to use. But again, some countries may have limitations because where the data is getting stored, that's one important thing to be looked into. So accordingly, you choose a module or a platform that, can be utilized. And that's how you move forward. Very important to do pilots, very important to do data validation. And the last important thing I would like to mention is that because of the challenges of not being fully digitalized, not let your units feel that they are being penalized. It should be a uniform standard method to, making everyone inclusive and introduced.
Thank you, Dr. Nisha. We move on to round 2 and Gaurav, over to you.
Thanks. So you've heard all their insights. Now it's time to pitch. The next session that we have is called the Shock Tank or the Shark Tank moment. So this particular moment is about asking them a particular situation in which they are going to pitch their solution, what's on their mind in 60 seconds. And you need to tell them if you're going to implement that solution in your hospital. Now, this session is not about, asking you for any funding. We're not going to ask you for any money. But they're going to fight for the impact that they're going to create with their ideas. So I'll move to, and please, you need to restrict to 60 seconds, which is exactly a minute and not more than that. So please make sure you have put in your points. And after each one of them finish their pitch, I would request the audience to kind of either by showing your hands if you agree with their pitch, or clap for them to make them understand, whether it is this or whether it is this. Okay, so we start with Sheikh, back you again. Your challenge is, how would you embed quality ownership across all levels without losing out on standardization?
So I will start with a simple idea that we sometime back implemented. So we create a box, okay? The box is basically your idea box. And since we have got many hospitals, we make this box travel across the hospital to collect ideas from the people at the forefront. Once those ideas are collected, you have a standardized approach. So you're not losing standardization, but at the same time, you are giving enough opportunity for everyone at the bedside to participate in that. So once you collect those ideas, they all get collated, they all get formalized into some sort of group to get that standardization. And then we work on those key pain points of the organization, so that we work in uniformity, we work with standardized approach, yet we maintain to resolve the problems at the bedside very quickly with the ground team. Hope I get some thumbs up.
So great, 60-second solution. How many of you would agree and would want to implement this idea in your hospital? Raise your hands, clap, please show him support. Great, thank you. Moving to Dr. Jennifer. What's one bold step to normalize open risk reporting in hospitals? One bold step, 60 seconds.
So let me start with a story. So once upon a time, and once upon a shift in a hospital not so far away, a nurse caught a near miss, a medication that was not labeled right. She paused, she thought, am I going to be reporting this or not? What did she do, you think? She ignored and she moved on. So the problem, the villain here is not the nurse, it's a system that does not encourage us to report errors. And how do we have to move around it and have a bold step to change this? By creating a culture that's reporting, a culture that celebrates reporting. So moving from punishment of reporting to encouraging people to report. How do we do that? I create a program that's called Catch One and Report One. So catch one, share one, report one. This is a strategy to be used every week. There is every unit, every department will have to report at least, catch and report at least one near miss or one risk to be shared as a team. So what do we do with this? This win is usually spotlighted in newsletter, in leadership rounds, and of course, in safety huddles. So here we are actually valuing risk reporting, we are encouraging, we are recognizing, and we are changing a culture of risk reporting from fear to a culture of, reporting with pride, okay? So this is—
Jennifer, you're out of time. Thank you so much. How many of you would pitch in for this idea? Hands, clap. Thank you.
Thank you.
Moving on to Ms. Gracie. You're facing EMR fatigue. How do you make quality tech a friend, not a foe?
See, the EMR fatigue is being considered as the cognitive and physical exertion of a particular person due to excessive use of EMR. First, we have to identify what can be the causes of that. Specifically, that your design is not proper, poorly managed, and then repeated documentation. So you have to see that it will be a collaborative one. That's what I just would like to say. And the users have to be taken into confidence and take the benefit or take the knowledge from the users and let them say that which is much benefited to them so that that fatigue can be avoided. That is my foremost thing what I think about.
Thank you. Thank you. Clap or hands for her. Great. Please map the time. Rashmi, when accreditation feels overwhelming, how do you keep teams aligned with patient first thinking?
Okay. So Gaurav, shall I call you shark or shock?
It's up to you.
Okay.
Your 20 seconds gone.
No. So I want to pitch for the, the debate what happened yesterday is about wo panch din, right? So I don't want that wo panch din scenario in any of the hospital. Okay. So we have developed a system which is an over and above, which embeds all your accreditation standard as a tool to all your policies and processes, and the process owners can continue to do their daily work. Okay. So we are always in the 60 to 70% readiness status. So that's the impact. And the second one is another 20%. So we introduce an accreditation tracker or an AI-based tracker, which can be used to, monitor all the steps, what is required to ensure that you are in the readiness stage. So by, end of your 3 months or before 3 months, you are ready for the accreditation.
Rashmi, time over. Can I please request the team to map 60 seconds only? You will get less responses here. Sorry for that. Hands or clap for her. Though half, but solution accepted by many of them. Shravan, next question to you. In a multicultural, high in turnover environment, how do you build a resilient patient safety culture? 60 seconds.
Daily or weekly safety huddles in each and every unit, and sharing stories of the incidents that have happened, and then talking about corrective actions done without naming or taking any names. I think that would go a long way in improving or setting up a culture of patient safety.
Great. Hands or clap for her. For him, sorry. I'm sorry, I apologize. Dr. Dipinder, compliance fatigue is real. How do you simplify audits and documentation without compromising on quality?
Great. A practical example. So first of all, we need to audit whatever is important. We should not audit because there is a checklist or somebody has told us. So value is more important than volume. That's first thing. What we had tried out is that we were finding a challenge that doctors' medical documentation is like not being properly done. Like documentation is not great. So we asked every doctor of a hospital to do one audit of another doctor, okay, name conceal, once in a month. That's it. So once in a month, we got like 300 doctors in that particular hospital. We got 300 records. Not only that improved that what is important for me, but that also meant that 300 records are added to a quantification every year. So every person, and same thing we replicated to the different departments, that every person does one audit on a particular topic, which made a big feel in that. And everybody not only learned, but also imbibed on the practice. Thank you.
Thank you. For him, your response. Good. And the last question to Dr. Nisha. How do you maintain high reliability in healthcare when budgets and resources are constantly stretched?
So very important that we look into reliable processes in the hospital for patient safety and care. One of the solutions which I would like to put forward is a simple bedside early warning scoring system, which is a low-tech, high-impact tool which empowers frontline staff to detect the early warning signs of patient decline, using just a small template. So we have used this in our low resource settings. Implementing this tool, it can help you reduce unplanned admissions, ICU admissions, which the statistic shows that around 25% of reduction has been there, and errors can go down by 15%. So through this, you can maintain high reliable care and also ensure patient safety.
Thank you. Love or support for her pitch. Great. So over to you, Anna.
Thanks, Gaurav. So this is towards the end of our session, but we want to do a crystal ball moment because we've heard a lot, right? But we're looking into the future. This is exactly what has been happening around. We have experienced many of the situations and we heard some wonderful thoughts and solutions from our panelists. So this is going to be a 10-second crystal ball moment where you have to prophesy, where do you see the future of healthcare quality in 2030? So it's going to be quick and we start from Dr. Jennifer and
Okay,
as
I
we
would
go
see it in risk awareness culture. I think this is something that we're lacking and we need to have more risk awareness in our everyday activities in the hospital.
Thank you. Rashmi.
From quality department to become a compliance gatekeeper to strategic care enablers, or maybe from policing to a purposeful partnership with the process owners.
Lovely. Next.
Moving away of the accreditation bodies, the state healthcare authorities will become accreditation bodies themselves, setting up standards and monitoring compliance with the hospitals.
Thank you.
Everything will be monitored. Everything means every activity of a patient or voice I'm speaking or something will be monitored, recorded, actions will be triggered, responses will be requested, and actions will be like implemented. So healthcare, I perceive, is getting more safer. Be it be AI or be it be technology, health is definitely going to be a safer, I hope, in 2030. Thank you.
Thank you. Dr. Nisha.
So accreditation bodies will need to revise their standards to include quality and patient safety indicators related to healthcare services provided by robo-doctors. Okay, these robo-doctors will not only offer treatment plans, but also create personalized TikTok dance challenges for rehabilitation exercises. And as physical doctors become increasingly rare, we will conduct clinical indicator review meetings using holographic doctors. This approach will ensure 100% committee compliance, elevating the burden on hospitals to prepare meetings just before the survey.
Thank you. Slightly over 10 seconds. Over to you, Dr. Sheikh.
So one is my prediction and one is my wish. And the wish is I want all the quality professionals to become data scientists. And one prediction is that we will be more of a predictive in nature. So to go there, that's the reason I said we should be data scientists as we move along. Thank you.
Nice. Ma'am, Gracie Madam.
Phone drop.
I just would like to say the entire country, the whole hospital must go for accreditation.
Go for
Accreditation.
accreditation.
And then one another thing, we may have to redesign our thing to match the latest or the current need of the healthcare requirement.
Lovely. I thought, it would be somebody would say the CQO would be above the CEO.
You never know.
But lovely session and thanks, Dr. Parag. So thank you all. We had a great session. I'm sure that you also had some great insights. A big thank you to all the panelists for spending their time. Thanks, Gaurav, for being a wonderful co-moderator.
Thank you.
He did all the work.
But I think all the panelists and the people here on the stage deserve a round of applause. All the people, including Dr. Parag, who stressed us out to finish this early, deserves a round of applause. And all of you sitting there deserve a round of applause. So thank you. Thank you.
Thank you. Thank you, speakers and moderators. May we now request you to please come on to the center of the stage for a group photo, please. Thank you.
Now is the time of the much awaited launches. And we have quite a lot in the bucket coming up for the noon session. But before entering into the noon sessions, let's go for the launches. The first one to go with CAHO Health Tech Excellence Forum. And CAHO proudly introduces the launch, CAHO Healthcare Excellence Forum, a dynamic platform designed to unite members and stakeholders in a collaborative effort to advance digital transformation in India, enhancing safety and quality through shared knowledge, best practices, and leadership. May I call upon the lead, Dr. Manish Kohli and team on stage, please. Also, the members from CAHO, Dr. Air Marshal Dr. Pavan, Dr. Nagendra Swami, sir, and Dr. Lallu on stage, please.
Dr. Manish Kohli and team.
Do we have with us Dr. Manish?
Okay, we'll move on to the next launch. I request Dr. Pawan Kapoor and Swami sir to please be on the stage. Please be on the stage. Requesting Lalu ma'am to join them. Presenting a pioneering initiative in the field of healthcare industry. The launch of the Laundry Excellence Program in association with Bandbox Cleaners Kolkata. The Bandbox Kolkata Kaho Laundry Academy. This first of its kind collaboration aims to elevate the standards of linen management in healthcare by equipping primary linen handlers with essential knowledge and practical skills. May we now invite Mr. Vishal Motwani, Senior Partner, Bandbox Cleaners, and Mr. Akshat Motwani, Partner, Bandbox Cleaners, onto the stage, please. Mr. Vishal and Mr. Akshat. Okay, they are joining us online, I suppose. Are they connected online? Yeah, the launch of the Bandbox Kaho Laundry Academy.
It's regrettable, and I sincerely apologize that neither of us could be there at the CAHOCON conference to represent our brand. But there have been certain personal reasons. There has been a demise in our family, which is why we are still in our mourning period. But having said that, I'd like to laud CAHO for putting up such a grand spectacle. I think they're a one of a kind organization that is really helping set the benchmark standards of excellence for private healthcare across the country. And the beautiful way in which they work is what deserves praise here. How they're able to get all the brands under one roof, brands that are not just directly involved in healthcare as well, but technology providers, so on and so forth. About this particular initiative, it's been sort of the brainchild of my father as well as Mrs. Joseph, who worked pretty closely over the last couple of months to put this together. In some, it's potentially done so that the unorganized nature of the laundry industry is sort of structurized, or it's our sort of humble way of trying to structurize that segment by passing on our 35 to 40 years of legacy and exposure to ensure that the end goal, which is the client satisfaction and patient safety, is kept as paramount importance. Having said that, yeah, I think that this initiative will come with a lot of activities, so you should definitely watch this space. Right from curating a team of highly esteemed individuals from multidisciplinary approaches, we'd be looking at attacking laundry from a horizon of different perspectives. And with that, we will sort of have deep dive brainstorming sessions and come up with a bunch of initiatives, including things on the practical side of things, as well as like theoretical aspects such as research papers. We aim to be a first of its kind collaboration where we're really trying to add value to the healthcare ecosystem. So you have programs like seminars where we are educating frontline linen keepers on what are the correct practices, as well as things on the commercial laundry aspects where we'll be running out like certification programs to ensure that the absolute best is provided to the hospitals. So yeah, in sum or in conclusion, like I said before, the idea is to structurize the unstructurized with the platform that CAHO provides us, as well as pass on our years of experience to all stakeholders in the healthcare ecosystem.
Thank you.
Thank you so very much, all of you. A special thanks to Lalu ma'am. We are honored to be part and humbled to of your organization to be part of this amazing concept of yours. Thank you so very much once again.
Thank you, and hope you'll have a fantastic day.
Thank you. I request our guests to be on stage, please. We have our next most awaited award for the afternoon or for the day. That is nothing but, any guesses? Then we'll finish. Yes. Sorry for a little interruptions over here, but at the same time, we humbly request all our members who are occupying the backstage to come forward. Also, I request our volunteers to please call all the members who are outside the venue to come in, as we have our esteemed chief guest coming in next 5 minutes. Please requesting all the members to please come forward. Requesting our volunteers to please call all the members who are out in. In the meantime, we would like to finish or to move on with the next schedule, that is the Best Faculty Award. For this, I would call upon Dr. Vijay Agarwal sir, Dr. Shankar Sengupta, Dr. Bishnu.
Please join us on stage, please.
Air Marshal Dr. Pavan, Dr. Nagendra Swami sir, and Dr. Lallu Joseph on stage, please. This is for the Best Faculty Award 2024-25. This much or this much? So are we ready for the Josh? Any guesses for the Best Faculty Award?
Who? We
Yes?
can't hear.
Oh, any more guesses?
But you guessed it right. The Best Faculty Award 2025 goes to Dr. Sunil C. Munkar.
Wow.
Dr. Sunil C. Munkar, the Professor of Pediatrics at KFC Manipal, is a distinguished academician, clinician, and quality expert with over 25 years of experience. A seasoned NABH assessor and an ISO auditor, he has assisted over 400 hospitals globally.
As a passionate teacher and CAHO faculty, he has conducted 27 training programs in 2024 alone, receiving outstanding feedback. With a strong foundation in clinical excellence, quality standards, and ethics, Dr. Sunil's contribution to building healthcare capacity is unparalleled. His dedication, versatility, and impact make him a truly deserving recipient of the Best Faculty Award for 24-25. Congratulations, sir. Also, we have the next award in line. That is the Best Chairperson Award 2025.
The Best State Chairperson Award 2025 goes to Mr. Sudeep Dey. Mr. Sudeep Dey, as State Chairperson for the West Bengal region of CAHO, has transformed the healthcare quality landscape with his visionary leadership. During his first term, 22-24, he enabled 15 HCOs to join as the institutional member and 50 plus life members. He has led multiple high-impact training programs as part of CAHO initiatives too. His second term from 24-26 has already seen over 35 new institutional membership.
Congratulations, sir. Congratulations and thank you. I now call upon Mr. Gaurav and Deepa to take over the stage and to introduce our chief guest and take over the session. Thank you.
Thank you so much. A very good afternoon once again to you all. The next session is Star Trek Coffee Pitch Charcha. May I request our moderator for this session, Dr. Narottam Puri, Principal Advisor and QCI Advisor, also Advisor FICCI Healthcare, to kindly escort our staff for the evening, Dr. Kiran Bedi. With a huge round of applause, all of you, please, for Dr. Kiran Bedi. Dr. Kiran is the first lady to join the officer ranks of the Indian Police Service. She served as the 24th Lieutenant Governor of Puducherry, worked with the United Nations as Civilian Police Advisor in peacekeeping operations, holds a PhD degree from IIT Delhi with postdoctoral Nehru Fellowship. She has been an author of several books, including Fearless Governance, which was translated also in Hindi, Tamil, Marathi, and Malayalam. She has been a recipient of a Gallantry Award, winner of Magsaysay Award known as Asia's Nobel Peace Prize, subject of an Australian-made biopic titled Yes, Madam Sir, founder of two organizations, Navjyoti and Indian Vision Foundation, serving underprivileged communities in rural urban areas and prisons for 30 plus years. She has been rated as India's most trusted and admired woman in past surveys by Reader's Digest and Week magazine. She also runs a YouTube channel called Demonstration Learning, featuring programs for youth book readings and celebrity interviews. I can go on and on, but I think I'll just stop here, and also would like to request Dr. Lalu Joseph and Dr. Vijay Agarwal to please welcome Dr. Kiran Bedi and please join here. Thank you. Thank you so much. May I request Dr. Puri to please take over the session. Thank you.
Thank you, Gaurav, and good afternoon, everyone. Gaurav has made the job easier. Otherwise, the convention is for somebody whom you're talking to give an introduction by starting by saying that so-and-so does not need any introduction. And then we spend 10 minutes reading the CV. So I don't have to do that. Dr. Kiran Bedi, may I call you Kiran as I usually do? So is somebody who many of you have admired for different reasons. I hope nobody's a politician here, of course. I'll start off by just one question, Kiran. Do you have a list of the people whom you have not peeved? You have not caused any hurt or peeved. I mean, virtually there is a long list of people whom you have not spared. So, so is there a list that says, okay, I'm not going to touch you?
Very good question. First time I'm being asked to think like this. So what's your question again? Because I will take time to think.
See, what I'm trying to tell the audience is that she's somebody who suffers no fools. She's ruthless in expressing the truth. She's absolutely in your face if that is required. She has suffered a lot in her
Are
life.
you talking about yourself?
Suffered a lot in life, as any one of us who lived in Delhi and have followed her career will know. But something you may not know is that she has not spared anybody, including her sister-in-law, whom she chalaned. She has lathi charged the BJP delegation. She has arrested people from Congress. She has, I mean, there is nobody who she has not allowed to get away if she thought that there was a transgression of the law. And that is something that's a rare trait to find in any human being. And when it comes to being the first woman IPS officer, that's a rarer trait. So I think there are certain elements of her life which are not encapsulated in Google or in Wikipedia, if you were to look. So by the way, this list that I've got here only has the list of people she has arrested. So it is full on both sides.
Can I see that?
No, you can't. So
I can put it in my next edition of the biography.
So my point is that it's a question of not just the law, it's a question of her conscience. She's not someone who decides things only by the head. Her heart has a lot of contribution to it. And if her heart tells her that this is the right thing to do, the brain follows. I know the neurologists here will not agree, but that's how it is with her. But very few of you will know, and that's when I first saw her as a tennis player. She was India's junior national champion. She was India's national champion. She was also the Asian champion. And of course, coming from a small city like Amritsar, it was a revelation for many in the tennis world. Those days, DLTA wasn't there. So matches used to be held in courts. And unfortunately, Indian tennis, particularly women's tennis, was not very well recognized or reported. Therefore, you haven't heard about her being an established tennis player in the country. Of course, following her, then Nirupama Mankad came, and of course, Sania Mirza took it to a different level. But Kiran, you grew up in a family which gave also Anu Peshavaria, your sister also played good level of tennis. Was there a sporting background to everyone in your family? Or did you just pick it up because you liked the sport?
No, Dr. Puri, my daddy was a tennis player. Papa used to love playing tennis. The family had hotels in property in Amritsar, but he was never that he was not commercial in his head. He was a player in his head. So he would leave work with his own father and brothers and go to the tennis court by 2 o'clock and spend the rest of the time on tennis court. And since mummy never wanted my father to be like my grandfather, who would be at the club without his wife. So My grandmother used to be left behind waiting for the grandfather to return from the club. Whereas my mom didn't want to see this happen to her. So she said, and daddy used to go by 2 o'clock, 3 o'clock to play competitive club tennis. And then, of course, he went on to play the competitive tennis also. But my mother used to follow her. So by 4 o'clock onwards, she would be at the tennis court with him. And since parents were on the tennis court, we from the school went to the tennis court. And the tennis club was halfway through to our homes. If my school was on this side, the home was on this side, and the courts were in the center. So what we would do is we will break journey, me and my sister, we to break journey, drop to the club, and then my mother used to come with the thermoses of juices and fruits, etc. And we would change and drink milk, juice, whatever she'd brought in, and go play tennis. So I started to play tennis from at the age of 9, I was taken to the tennis court, age of 9. And after that, school, tennis court, home. And during tennis court, so it was a family time on the tennis court. It's such a luxury of these times where mother's there, daddy's playing, daddy's teaching you. And then there was a coaching center. Then I was put into a coaching center as well. So I was learning from him, and he loved tennis. He would watch tennis, he would read tennis, he would listen tennis, everything. And at that time, you had those DVD players of tennis matches. So Doordarshan Mes, and we used to see you so much, Narottam. You know what has brought me here today? Is you. Yeah. we all used to look up to Narottam when he used to come on the cricket commentary. Oh, he was a hero of our time, a legend of our time. And I'm so very happy, Dr. Agarwal, that you brought me to meet him today. I didn't know where he was living. We lost track of him. And he was one of the finest programs when he used to hold on Doordarshan. You see, Doordarshan us waqt itna acha tha, it was so good that there was one program for the entire country and everybody watched it. So everybody was watching Narottam.
Nobody believes you here.
No. Well, if you are my age, you will have watched it. If you're half my age, then you wouldn't. I don't know. But those people who are in that age category cannot have missed Dr. Puri. And we used to love the way he would interview, the way he would speak, the way he would do his commentary, and also what a fine doctor he was. So I have come because of you, Dr. Agarwal, because of him. To be honest, I'm very straightforward. I haven't come because of your conference. I've come here to meet him. So, and I'm so happy that you co-opted him because he's so much to give. He's such a versatile all-rounder in this country of ours. All-rounder. Has he got a Padma Shri or not yet? Hasn't he got it?
Have you got it?
Not
yet. I'll follow you.
But so very good. We got some, these are legends of our country, of our times. Legends and living legends, thank God. Healthy and fit.
So I don't have a veil to hide my face in, but the thing is, your career was one part. The other part of it is, which is unknown to most people, is how did you start? Coming from Amritsar, you hear only two names, and that is Bishan Bedi and Dinesh Khanna. Bishan Bedi for cricket and Dinesh Khanna for being the Asian badminton champion. And Bishan, unfortunately, we lost recently. Dinesh, fortunately, is alive. But we didn't hear anything about it because those days, as I said, women's tennis wasn't very well known. Your education, school, college, everything was in Amritsar. And then when you came here to Delhi, you did law. You're, of course, a doctor because you got your PhD from IIT Delhi. And you joined IPS. And I think a lot of people in the government must be very happy that you didn't join IFS because we would be fighting a lot of wars with our, and the and many of them will be very happy you didn't join the IAS because I don't know, the ministers will be hiding under the tables. So great that you joined IPS, but what made you join IPS?
I think the way I grew up. To be honest, I love the medical profession because I found it is the doctors who give you life, who give you health. Because my father got his health back because of a doctor. My daddy had a very near fatal accident when I was just about 6, 7, 8 years old. And that was in Amritsar. Very near. It was I get the scene also when my mother, when he got the message, how she ran running barefooted to go to the Vijay hospital in Amritsar. And we followed our mother saying, Mama, kahan ja rahe ho? Bhag ke. She didn't even have a dupatta on. She just ran. She got a call that daddy's in hospital. And we girls, we were 4 of us. The 4th wasn't born yet. So we ran after her and it took us to a hospital. And I remember when daddy was lying on the bed, all soaked in blood, and he asked for one person. And he says, Dr. Mohanlal ko bula lo. He was his tennis friend. And he says, Dr. Mohanlal ko bula lo. Agar wo aa gaye, to main bach jaunga. And it was a Sunday, friends. And I heard that. See, I heard the word doctor. And he said, main bach jaunga. And then Dr. Mohanlal came. Luckily, he was available. And as my father told the doctor, डॉक्टर मैंने इतनी देर आंखें बंद नहीं की हैं, अब आप आ रहे हो, अब मैं आंखें बंद कर रहा हूं, मेरे पीछे 3 बच्चियां हैं, 3 बेटियां, we were 4 later, 3. And उसने कहा, डॉक्टर साहब ने कहा, प्रकाश, जोर से सांस लो. Daddy took a deep breath and he clutched his entire, clutched all these ribs because his ribs were fractured. And he clapped them and Papa shut his eyes. And my Dr. Mohanlal told my mother, if he survives for the next 12 hours, he's safe. Daddy survived. Who gave him life? That doctor. That doctor, I owe everything to myself, to that Dr. Mohanlal from Amritsar. I've never ever forgotten this, that we all owe our lives to and you see how I remember him even now. And Dr. Mohanlal, if he was alive today, would have been maybe 120 years old today. But you see, I every day have him in my gratitude prayer, that I owe whoever I am is to that doctor in whom he trusted. The key was he trusted Dr. Mohanlal. And I said, okay, when I grow up, I'll also be like a doctor. But friends, I was very poor in mathematics. And science did not enter my head. So mathematics didn't enter my head. I became a liberal arts student. I wanted to be in medicine, but I was not as bright as you all are, because you have to be very bright to do medicine, very bright. So I took up liberal arts and I was very good in administration, political science, geography, history, psychology. I loved literature. I did honors in English. I loved literature. I couldn't do science. So what happened? But love of liberal arts, NCC, tennis, sports, track suits, uniform at that time, Pathan suit like this, no saris, frocks, tennis shorts. How could I ever change the way? It had to be. It didn't matter whether it was an Amritsar or tier 2 city. My home was just brilliant. My home was all inspirational, sports, reading, positive thinking, inspirational, visionary, because that's what my parents were. So I'm a product of that event. But after that, the grooming is totally by the parents, value-based, very secular. My grandmother was going to the Darbar Sahib, and my mother would go to Durgana Mandir. We all had Mandir and everything together. Everything was, I went to a Catholic school. I grew up as God is one. And what matters most is your trustworthiness, your value systems. So And policing was so attractive to me. While I saw them terribly corrupt as I grew up, I saw them terribly corrupt. But I also saw the power of policing. And I said, oh God, if I'm value-based, then I can do so much. I can be, if not a doctor in white uniform, white coat, I can be a doctor in uniform. And believe me, I have worked as a doctor in khaki. I want to let you know. So that is what attracted me to the profession, that agar ye nahi, to ye to sahi. And due to which, you know what? Just as you treat your patients the way you do, I treated every complainant like my patient. I looked after my patient like a doctor. I never let any patient complainant in my life go away not satisfied that he or she has not got a reply. Not one. And I've not with one let justice not get met. I made sure. And if I was tough, you're right. If I was tough with somebody who would like to pull strings or think कि वो बहुत कुछ होंगे, तुम कौन हो? तो मैंने कहा तुम कौन नहीं है? There's no competition. There's no competition. तुम हो, मैं हूं. चाहे मैं गद की छोटी हूं, लेकिन मैं हूं, तुम हो. I'll apply my law, you apply your power. So I was never afraid of using my power, whatever the power was needed. So that is how I think my policing came out of very sensitive upbringing. It just grows every day, friends. That sensitivity, that compassion, that empathy and love for justice grows. It grew when I was a child, and I'm so glad that I got into a profession where I wanted to be, where I was, and I was exactly the way the way I grew up. So I think it was a totally authentic growth all along, but no temptations came my way. There were a lot of temptations which were offered. Nothing came in my way because the grounding was so very strong.
Right. So was it odd or was it tough being the only woman in a group of 80, 85, 90, whatever what number there used to be at the National Academy at Missouri and then at Mount Abu?
See, I'm so glad you asked this question after I've answered my earlier one, because I grew up so brilliantly, so strongly, with so much of clarity, with so much of balance, and so much of collaborative spirit, that I found I was not competing with the boys. I never was competing with the boys, but I put them to shame. I'll tell you how. How? Because I had more stamina than those IPS probationers who were smokers. Because smokers don't have stamina. I had more stamina than the smokers. And those boys who had not been playing games at all, I used to beat them. So I was a tennis champion of my academy of 80 boys and 1 girl. So they knew me as a champion. So I think I got accepted by the boys who they started to look up to. So not wanting to shame them in any way, they were actually looking up to, because I became an example saying, agar wo kar sakti hai, to tum kyun nahi kar sakte? So I became an example for them. That is where they got shamed. कि देखो वो किरण चढ़ गई, वो देखो रस्से पे चढ़ गई, वो वहां तक चढ़ गई, तुम क्यों नहीं चढ़ सकते? तो हर लड़के को दिखा रहे थे मेरा उस्ताद कि अगर वो कर सकती है तो तुम क्यों नहीं कर सकते? So that is where they were feeling. So I never made I didn't make them jealous or envious, but and of course I had मेरे से थोड़ा सा छोटा, थोड़ा सा लंबा एक लड़का था, Rajan Bakshi. He lives in Gurgaon, IPS officer. Now we had to do judo and karate. We had to do all those exercises, and they had to find. So there was no girl for me. So they found this junior for me. He had such a big, thick neck, इतनी बड़ी neck. तो मेरे हाथ में नहीं आती थी उसकी गर्दन, और मेरी गर्दन उसके हाथ में आ जाती थी. So I got a lot of jhatkas from him, but he didn't spare me. I didn't spare him. But if I did get beaten up, was when he held my neck. He had strong hands and I had a thick neck, and I couldn't hold all his neck with me. So Rajan and he in fact became a very gallant officer from J&K police, who actually, when there was a major blast, got a shrapnel here and something and got injured. But this was the way the academy and was. So I didn't compete, I teamed up with them and just loved being with them.
So you also worked for a short while as a teacher.
Oh, yeah.
What was it, the experience of teaching? Did it translate somewhere down the line when you became a senior officer to teach the cadets, to teach the junior officers?
I loved teaching. In fact, if I had not joined the police service, I would have gone into teaching because I loved education. So I did do, before I joined the Indian police and sat for the examination, I had a year and a half in between the preparation, etc. So I joined the Khalsa College for Women, Amritsar, to teach graduate classes in political science. I was more of a player than a teacher. I wouldn't play with the students. And I would say, kai bari पढ़ा रही होती तो मैं देखती हूँ कि अगर they want to do something different, I say चलो बाहर खो खो खेले. तो मैं इनको क्लास से बाहर ले जाती थी खो खो खेलने की. और जब खो खो खेल लेते थे चलो आप वापस आके पढ़ते हैं. So it was like a teacher who would sense whether the students are absorbing or not. And when I found that students were in a different mood, I would not inflict a lecture on them. I would be one of them, one of the players with them. Second thing I found very different in teaching at that time, which is now being done, is telling them कि पढ़ के आना और क्लास में सुनाना. So मैंने कभी लाला लाजपत राय if it was a chapter, तो मैंने ये नहीं बताया उनको लाला लाजपत राय क्या थे. मैंने बोला पढ़ के आना, तुम सुनाना. And I would sit on one of their desks and listen to them. So I was a teacher come friend. So I loved that little portion of mine. But they were so loving, so affectionate that when I went for my Asian tennis championships while I was teaching, do you know what? I carried a bag full of prayers from them. Every one of them said, Madam, jeet ke aana, pratna karte ab jeet ke aana, jeet ke aana. And I carried all that bag with me to my championship. And I know why I won. I won because of their prayers. So I used to love teaching. Had I not made it to the police service, I would have gone to be a teacher. And if I had quit the service at any time, if I had an issue, I would have gone back to teaching, because that's the reason I continue to study further, upgrade my skills, whether it was a law degree or doing a PhD, all done while in service. So I was basically a teacher at heart. I'm still a teacher at heart, because when I ran the police training college here, became special commissioner training, that was one of the finest period of my career, because I reached out to every man, every woman in the in the Delhi police service, and saw how they needed what they needed. They were cared, had the best food, they had a weekend break, their families were incorporated. I took care of them like a mother. So I think I'm basically a teacher at heart, but I converted my policing to communicative policing. Teacher is basically a communicator. And I am actually a very communicative police officer. And that is what actually made me do very good policing.
So you've been given some, how should I say, punishment postings for not being liked by the politicians, etc., etc. But you converted them into a completely different set of circumstances which were to improve the lot. For example, when you went to Mizoram as IG, or when you were DIG, when you were heading the Delhi prison, Tihar jail, you completely reformed Tihar jail. And did that come from a sense of frustration that should have been in actual policing, but they've put me into the prison part because nobody would go there during those days? So do you see in your career, was there any frustration because of, we all believed that you should have been the Delhi Police Commissioner. You were not, because of the actions that you took against politicians and particularly the lawyers' strike. And by the way, she used to be called Crane Bedi. Not Kiran Bedi, Crane Bedi, because she introduced this concept of getting the cars which were wrongly parked picked up by the crane and transported to the police station. And she also introduced the concept of stat fines. So she wasn't popular with a lot of people because she challaned some very important people. And I guess that must have contributed to your being transferred from one place to the other, not becoming the police commissioner. Now that you reflect back on your life, is there frustration because you could have been, or it's a sense of comfort that you did not allow your principles to be sacrificed? Sorry, long question.
No, no, it's okay. I'm trying to see which part of the question do I focus on? You know, I have a habit which stood me in good stead, is make do the best with what I have. In certain things, I don't have a choice. I realize in certain positions, I don't have a choice. And if I have to accept this, then I will take it as it is. Or I'll reject it all right and walk away. If I take it, it belongs to me. If I don't take it, I'm not responsible. That's what happened with the prison assignment, which was considered a punishment posting. So I took it because I knew my heart was in it. They needed my heart more than the head. The prison needed my heart more than my head, because they were all people who had committed accused of crimes, some of them terrible crimes. And I'd sent many of them into the prison myself from policing outside. I knew who they were, but they were now in a healing station. Prison is a healing station, a rehabilitation station, where what is the purpose of that, to my mind, was make them go up in such a way that once they go out from here, they are not revengeful, and they don't have friends here so that they want to go back to the friends. So neither are friends here, nor are they comfortable here. Make them feel uncomfortable, but not physically, but mentally, in the way, educate them in such a way that they want to go, but not come back. That was the purpose. So I've always gone by, make the best of what you have, put your heart and soul in it once you accept it. You asked me the question whether I had issues with the politicians and they gave me punishment postings. Do you know, my issues was not with politicians. Politicians don't compete with me. Politicians can fix me once in a while. One or two can. It is the bureaucracy. It is the bureaucracy which competes with the services. It's the inter-services, and within your own service, it is those who are losing out on popularity. What happened was, because of my access to the people and my communication skill and serving with sensitivity and serving with empathy and being visible with the people and treating every complainant as my patient and to be cared for, I got a lot of goodwill. And I earned a lot of trust of the people. So with the result, I got more visibility. That was the point of envy with certain aspects of civil service. And my peers or seniors, even seniors were envious. Why? How did I detect? I detected if I would be going along with my DIG, and if my IG was here, or my politician if I'm going with my senior was brushed aside and they wanted to take my autographs. And I was very embarrassed that my senior is brushed aside and the students are coming, children would come back to say, ma'am, autograph, autograph, autograph. And I had to shove myself away because that senior had to wait for me till I finished the autograph. So I know it was not easy. So in my service, what has given me postings which were not considered prize postings were because of the bureaucracy, which was competing with me because of my visibility. So they tried to give me positions and postings which were not visible. So junior postings were visible. But as I climbed up, the visibility would go up. They would say, move her out because this visibility will go up top many notch. That is why one of my major reasons for them sending me to prison assignment was visibility. And it was a bureaucratic decision, which they regretted hugely later, because later on they realized it became more visible.
Yeah, I remember that because I think what you managed to do there, starting Vipassana centers and completely transforming the prison system, having different barracks for people who were habitual offenders, etc., etc. So kudos. But my final question to you, I can go on for hours at end, but your daughter is a doctor. Did she fulfill a part of your ambition not becoming a doctor, or was it her choice?
No, she didn't. My God, she found it too tough. It's not everybody's cup of tea, and she did not. And that was quite a setback for me because I wanted her to become one of you. But she was not that strongly academic. She was also a tennis player, but the fault is not hers in a way that she actually grew up with nephrotic syndrome from the age of 3 till the age of 13. So her schooling was not grounded. So she was in and out of school. So she didn't become a strong academic. But somehow she got a seat from Mizoram. When she's qualified for it, she sat for the examination. And luckily, Mizoram had about 10 seats, where 3 seats were to go for children of officers who would come from outside. But she went through a merit test. And in the merit test, she stood 3rd. And she got a Lady Harding medical seat. Guess what? I sent her away to join the Lady Harding Medical College. She was very happy, finally, but she found it just too tough. That's another story. But guess what happened in Mizoram? Mizoram went on an agitation, statewide agitation. Why are non-Mizos getting the medical seats? And there was a statewide agitation, and there was a band against me for my daughter having made it to medical. But I said, she's done it because you had your test. She stood 3rd in the list and said there were 5 seats or something. I was called by the minister and said, Kiran, by tomorrow, if you do not surrender your daughter's seat, medical seat, they will burn your house. So I said, but sir, I've not taken the test. It's my daughter's decision. She wants to do medical or not. They said, no, you let us know by tomorrow whether you will surrender the seat or not. Because others had surrendered, other non-Mizos had said. I said, sir, can I call back my family and check with her once if she wants to? I came back home, and at midnight, with my open house, I left with no clothing. I left Mizoram. I said, I'll not surrender a seat, and I'll not concede to your irregular, unjust demand. I left by road midnight, leaving my house to my orderly. And I said, जो तुमने करना करो, अब मैं यहाँ से जा रही हूँ, क्योंकि ना मैंने घर जलाना है, ना मैंने अपनी बेटी की सीट देनी है, और ना ही मैंने इनजस्टिस की इनकी गलत बात माननी है. मैं जा रही हूँ. तो उनको पता ही नहीं चला. मैंने ऑर्डरली को बोला, कहाँ जा रहे हो? मैं नाइट पेट्रोलिंग के लिए जा रही हूँ. And I drove from Mizoram, Aizawl to Silchar. And by the time I'd left Mizoram, they could not have called me back. Morning, when they realized, the minister called for me, Kiran kahan hai? Where's Dr. Kiran Bedi? I was not doctor then either. Kiran, Madam Bedi kahan hai? ढूंढने लगे, कोई नहीं मिला. कहाँ गई? ढूंढते रहे, wireless भी नहीं बोला. So this is how, friends, the agitation got called off. Agitation got called off. And then my house did not get burned. I did not surrender the seat. These Mizos people went up to the Supreme Court to see why should these Mizos and non-Mizos get a seat. Supreme Court didn't even entertain the petition, saying this is India. There's not Mizoram. So friends, this is a little background story. Of course, she did not do the medicine. She went into psychology and other aspects. But these are the background stories. And she did not get proper subjects when she went to a central school in Aizawl. She didn't get all the subjects. She didn't get the teachers. But she got the seat because she qualified in that test. But this is how it is. But I think one lesson learned as a mother for me is that we have no business to force a profession on our children. Best not to do that. And certainly not engineering and medicine. They're very tough. They are very tough, and we have to judge. We have to assess whether our child is ready for this kind of test. Because medical seats, this examination, these books were just too much for her. Just too much for her. And I kept working on her. It was a huge rebellion in the house. So I think one of the biggest challenge I have faced is being a mother, rather than a police officer.
Sure. So Kiran, you run the Navjyoti Foundation, of which I'm very familiar with, because of which, again, a huge credit came your way. You started a center in a police station, I think Sarai Rohilla, if I remember right. And you started yoga classes for de-addiction. And then now you run an NGO, India Vision Foundation. How, if you look back on your career, which of all these activities has given you the most pleasure and satisfaction?
In my life, I've only made an effort to keep adding to my joy. So if you look at my progression, there was always an effort to do everything to add. And my whole professional portfolio getting expanded. Friends, if I were to share a lesson of my life, is we all have an opportunity to expand our portfolios. My portfolio became education. My portfolio was my profession. My portfolio was sports. I added writing to it as an author. And while in service, I founded foundations to work for the poor. And drug abuse treatment centers in the police stations, while in service, added to my portfolio because it became a foundation to treat drug addicts. Now, how am I as a police officer to be having drug abuse treatment centers in a police station? Why? Because I wanted to prevent crime. I wanted to treat them before they would get back to another case of rape or thefts or robberies, because drugs leads to that. And those little actions of mine getting consolidated to become foundations. But they added variety to my life. They added volunteerism to my life. When I got the Raman Magsaysay Award in 1994, the India Vision Foundation, it came with an award money. Guess what happened? I founded a second foundation, now on prison reforms, announcing that this award is now dedicated to a birth of a new foundation called India Vision, which works for prisoners' reforms. So, friends, authorship, foundations, volunteerism, education, opening up your professions, added so much of variety to my life. And what am I doing now? While I'm doing foundations, I'm reaching out to people. I'm connecting with people. And it's helping you reconnect with the people like you. So I think if we continue as medical professionals, wherever you are, but you keep adding to your portfolio and keep expanding your day. And I'm telling you, the nature has its own ways of creating energy and time to you. Life becomes rich. I am very rich. I'm exceedingly rich, so many times over. Not richness in the crores I have in the bank, but by the kind of activities I kept adding to my life as solutions to problems which I encountered. Solutions, so that without looking at what's in it for me, without being transactional, everything was transformational. And with the result, life becomes very rich and very, very blessed. So friends, we are all in a wonderful profession. If we all look at what more can I do while I'm around, be of value to others, and continue to enrich. I think not being saying what's in it for me. Will I have a photograph in this? Will I get a Padam Shri for it? Will I get a name for it? Will I get a photograph? No, I'm doing it because this is needed. And I'm in a great position to do it. If you keep doing it, and as you grow, things keep self-driven. It keeps running by themselves while you keep adding. And this is all sustainable. So I would think this has been a philosophy of my life. Keep adding to your portfolio. Don't stop where you are. Find out where all can you do. It's like Velour, CMC teaches you working with the villagers when you're small. I have Dr. Cherian as my friend who and I worked, and we worked together. Where is Dr. Cherian? Is you? There you are. This young lady. See, he and I are working together for educating prisoners' children. She's adding to her own portfolios. So friends, if you can do, this is what my lesson of life is. Don't stick just to where you are. Keep looking at what more can you do, and keep giving. Keep giving and be grateful for what you've been allowed to give. And then keep growing and keep giving. Growing and giving. This has been my profession and my philosophy of life. Keep growing and keep giving and remain grateful.
It's been an honor and a privilege to get an opportunity to chat to you on this forum. Thank you very much for joining us. Ladies and gentlemen, you'll agree. Yeah, I was about to say so, that I think she deserves it.
I think, yes, a grand applause for the session and largely for the contribution to our country. So thank you so much, man, for actually a real star presence here today and taking out your time to share your thoughts and experiences. And thank you, Dr. Puri, for moderating the session. Thank you.
Thank you, sir. I would now like to request Team Pentathlon to please come on the stage for the next session. I would like to request Dr. Arindam Kar, Dr. Darshana Rathod, and Dr. Debata Das to please come on the stage. Okay, I'm sorry, there is a slight change in the program. We are now going ahead with the launch of the Health Tech Forum. Please give a huge round of applause. Okay, now I welcome you all. I would like to now welcome you to the next session of Impact of Forum in Enhancing Good Practices. For moderating the session, I would like to welcome Dr. Vijay Agarwal sir on the stage and Dr. Lalu Joseph on the stage. Please give them a huge round of applause. For the session, I would like to invite the speakers, Dr. Saril V.S., DGM, Sakra Institute of Rehabilitation Sciences. Dr. Saril V.S. Our next speaker is Dr. Sangamitra Chakraborty, Head of the Department of Nutrition and Dietetics, Medica Super Specialty Hospital, Kolkata. Please give her a huge round of applause. Miss Manisha Paul, EC, Indian Pharmaceutical Association, Hospital Division. Please give our speakers a huge round of applause. Our next speaker is Dr. Elizabeth David, Director, Nursing and Organizational Excellence at Rajgiri Hospital, Kerala. Our next speaker, Mr. Vinod Kumar, Engineering Consultant, Rajgiri Hospital, Kochi. Yeah, please. Our next speaker is Dr. Uma Shankar Raju, General Manager, Operations and Quality, Apollo Hospitals Enterprise, Bangalore. And the next speaker, Ms. Kirti D'Souza, Director, Life Giver Professional Services, India. Please give her a huge round of applause, everyone. And Dr. Shankar Sen Gupta, Medical Superintendent at Chittaranjan National Institute, Kolkata. Please, I would now hand over the dais to our moderators.
So good afternoon, good evening. Guys, I think to me this particular session representing the forums of CAHO in a way is one of the game changers, one of the most important initiatives of CAHO to reach out to everybody. And therefore, we have all the people here representing, and I'm sure that next time there'll be one couple of them more. So I would like to, because we are very short of time, and let's try to kind of give very crisp and concrete kind of answers to bring home a message. So I would like to know from you as to what has been the focus of your particular forum. And let me start with Saril, because you are one of the most successful ones. I can say congratulations.
Thank you.
Please see that what has been your focus or things that you have been able to, what have you been able to achieve in the last 1 year? And do you think it was worth creating this forum?
Thank you so much. Unlike other forums, rehab it's not just one profession. So we have PMR, physiotherapists, occupational therapists, speech therapists, and at least 10 different professionals to be baptized. So it has not been that easy. But if I say that as forums, what we do is we are like the silent missionaries of CAHO, and we are successfully converting a lot of like-minded professionals into the religion called quality. And that is our mission, that's our focus, and we want to channelize all the energies to work very hard and achieve what our vision is, that quality-driven rehabilitation for all. So all this while it was only rehabilitation, now we want everybody to talk about quality-driven rehabilitation. Thank you.
So same question, actually, if all of you can just start giving, it is the same question. And I will request people who are at the back, if you people can come forward, it will give great comfort to the speakers that they are speaking, not to the empty chairs. So please come forward. That's my request to you. Kindly come forward. Yeah. Yeah, Sangeeta.
I'm from the Clinical Dietetics Forum. First of all, thank you, sir. Thank you, Dr. Lalu, for inviting me to be the chair of the Clinical Dietetics Forum. This was much needed because clinical dietetics has always taken a backseat in our healthcare, wherein actually it should be integrated into the healthcare. So in the last year, I have come across a team with very like-minded professionals. So we all think on the same plane. We would like to integrate the science of clinical dietetics into healthcare and work in a collaborative manner with the other professionals. The second focus is that we want to integrate all hospitals. There are many hospitals which do not have dietitians, or many small places where the doctors also do not know or do not have the time to think about the diet. So we would like to get all these hospitals under one roof and kind of explain to them the importance of clinical nutrition and dietetics, and also to set quality standards in our field. So that is the focus of our forum.
Good afternoon, everybody, and thank you, sir and ma'am, for this opportunity. So I represent the Global Patient Safety Nurse Forum as the chairperson for this particular forum. Now, this is a very unique forum, which is a culmination and a collaboration of three very important platforms within our country. First, of course, is CAHO, and we also have ANI, which is the Association of Nurse Executives of India, and the Infusion Nurses Society. So we're trying to get all of these forums together to kind of create a synergy where we have to create people or nurses who are to be known as patient safety nurse champions. And we know that nurses are at the forefront of everything that we do when we talk about patient care. So we want to create this group of people who are going to be knowledgeable, to understand patient safety more, and be able to take the front foot forward to be, bring about a change in patient safety. Thank you.
Good evening, everyone. Thank you, Vijay sir, and thank you, Lalu ma'am. Being part of Pharmacist Forum, I totally believe that we deal with medication, pharmacists deal with medication, and where we have to have a good collaboration with doctors, nurses. And in this year, we had lots of learning program where we engaged in different kinds of educational seminars, workshop, where we have been identified what are the areas where we need to focus, the way how we can put forward our problems and speak to doctors, how streamline the process of procurement and medication safety can be taken into nurses and doctors together along with the pharmacist, we can work towards patient safety and deliver quality of services. Thank you so much.
Good afternoon, everybody. Vinod from the Engineering Forum. First of all, a big thank you to Dr. Vijay sir and Lalu ma'am for having made this program, the Engineering Forum, a big forum among the whole quality fraternity. And we started with myself and Arul as a co-chair. Now we have increased the numbers almost close to 400. A big, I think we should have a big hand for Dr. Vijay and Dr. Lalu ma'am for actually giving us that opportunity to showcase the importance of engineers. And as far as the future plan is concerned, is that we are planning to move into the different zones across the different country, bring in more engineers into the engineering forum, and build good engineering safety, environmental control, and patient safety overall. Thank you.
I'm Kirti here. I come from the Sustainability Forum along with Dr. Karan. We have had a great year. In the last year, we spent a lot of time in concretizing our research with respect to sustainability in healthcare. We had taken efforts in the previous years to write what are the issues connected with healthcare sector. And this year gave us a platform to publish international 2 papers on sustainability in healthcare and also on sustainable procurement. How do healthcare sector harness sustainable procurement? We reached out to cities incarnating the guidelines that we have been pushing to BIS with the guidance of Mr. Anil Juari, the ex-CEO of NABCB. So the guidance is going to help the organizations because now QCI has come up, NABH has come up, everybody has come up with sustainability inbuilt into the guidelines. So this guidance document is going to help. So coming year, our focus is going to be help organizations to understand sustainability to be part and parcel of their process within the organization. And we look forward for sustainable event tool that has been launched yesterday to be effectively used in all your events in the hospital. We are very grateful for the leadership of CAHO, Dr. Vijay Agarwal and Dr. Lalu Joseph for pushing sustainability hard as one of the great agendas.
I think international is a little bit different to everybody else, where we started off trying to understand what's the problem in each specific country that we go and share time with. So the challenges we saw in Nepal and Sri Lanka, where we've had events so far, are very different to what we sometimes take for granted in India. Their top 3 things are very different to ours. The 2 events, I'll tell you, it's exactly what CAHO does, right? It builds a family we didn't know we didn't have, right? To a lot of people around here, we get a home. Even though we all have homes at home, we don't really know the quality of the home until we come to CAHO. So I think that family culture, that we understand each other, we have a group to go to get help and feel that we're part of a fellowship group. I think that's desired in every country. So far, we've been requested in so many more countries. I think our challenge is making sure we're sustainable in the countries we go to and we build the quality of life like we have here. So that's what we are. If any of you have any contacts, please touch any of the members of our team. We have Uma, Chakra, Shashank, many other stars. But I think this year's main agenda item for us is get WHO to partner with CAHO as an integrative partner. If we can deliver that, I think it'll be great for WHO and it'll also be good for CAHO.
Thank you, Sam. And let's pass on to Shankar sir. Dr. Shankar Sen Gupta, the Vice President of CAHO. What do you think has been the impact the forums have created? Your opinion, your thoughts.
Yeah. Good afternoon, everybody. As all of you know, the CAHO is not an organization. CAHO is a movement. And in that movement, what CAHO wants, that to make the champion of quality of each and every healthcare system, each and every sub-branches. To deal with that, I would say this was an excellent approach towards the healthcare quality to have the different forums. Number 1, like it's being told by Detmar Kramer, the man who made the West Germany the World Cup champion, that if you really want to get the talent, you have to go to the micro level. So through this forum, actually you can address the micro level problems and then solution for them. That will really enhance the quality. Number 1. Number 2 is that everybody knows the basic structure of quality comes with the making a structure, then process, and then outcome. If you look at as a whole, holistically, the quality, it is not possible. What we have seen by introduction of all these forums throughout these years, and now last year, it has been a huge success that each and every sub-branches have got a much more, the structured approach towards their quality implementation. At the same time, outcome indicators assays and outcome indicators analysis. And last one is sabka alag alag pehchan hoti hai. Everyone are healthcare professional over here who are in CAHO, but everyone is different from others. So all the other forums in CAHO itself have got a different kind of pehchan. That is very much important, and which will definitely take care. It's called like unity in the diversity, and that will definitely take the organization also to a very different level, as well as all the sub branches will definitely go much more ahead in coming future. That's what is my intent.
Absolutely. I think we really want to have a good session. Unfortunately, due to want of time, we would like to close this session. I would like to just mention to you that these forums are created for professionals. We have Dr. Saril here who's taking care of the Global Rehab Forum of CAHO. They've done an excellent job in bringing OT, PT, therapists, PMR doctors, and let's give them a big round of applause. This year, we had a pre-conference workshop conducted by them at the in ISIC with over 300 participants. And that's the power of this forum. This is the voice for the rehab professionals. And we have with us Madam Sangamitra. They've done wonderful job. There are about 5 or 6 dietitians from across the country who have taken the leadership. They've come together. If you are in clinical dietetics, wish to be part of this forum, please join. Because it is a collective synergy. Healthcare is not just one group of people, all of us together. So we have to sing the same tune of quality patient safety. Dr. Elizabeth David here, the Global Nursing Champion for Patient Safety Forum, and they've done a great job. They're going to be coming to all the nurses in the country. I think they've got a repository of huge number of nurses who are willing to join this forum. They'll be taking it to the next level of excellence this year, I'm sure. And of course, Dr. Manisha and her team, we ran one pre-conference workshop. 4,000 pharmacists across the country joined that workshop. So that's the power of pharmacists in this country, and they are integral part of medication safety. Of course, our own healthcare engineers. Now they are divided into 3 verticals: clinical engineers, maintenance, planning, and they've done excellent job. So if you are healthcare engineers, you wish to contribute to quality patient safety, please join the movement. Samir Mehta here, we have gone to 3 countries. We'll be going to several other countries, not just preaching CAHOing or, trying to see whether we can build CAHO there. But it's also to learn best practices from these countries to try and incorporate those principles here as well. They've done a great job. So if you wish to be part of the forum, please connect with Samir Mehta, our power bank here, power lady, Madam Kirti D'Souza. Lot of sustainability talk in the country. Everybody is doing something or the other towards sustainability. If you're interested to take this forward, kindly connect with Kirti D'Souza. CAHO believes in collective synergy. CAHO believes in taking everybody together. It's one family together for quality and patient safety. With that, we end this session. Thank you so much for being brilliant participants. Yes.
What I would like to say is that there is one family that we need to bring together more actively, and that are our clinicians. So we are now requesting all of you who are present over here and who have some connection with various specialties. I think to go around is that how do we reach to the specialty organizations? To the specialty organizations, the approach is that please understand that all these specialties are doing excellent work. Understand what happens. Sometimes we talk negative. We are able to not communicate our message. So the message is that all these people, if you look at the ophthalmologists, the orthopedicians, the pediatricians, neonatologists, everybody, if you look at in general, they are doing excellent work. But unfortunately, along with the excellent work, sometimes the harm is also getting delivered unintentionally, or the reason that they have not tried to become the captain of their team. They have not tried to work as a team. So we have to try to give them a message that it is just like the moon has a dark spot. We have to work on that dark spot. We have to work on the harm that is getting delivered along with the excellent care. And it is towards that they have to start focusing on how do I make each of that specialty organization focus on making the healthcare delivery safer. So we require your indulgence to reach out to anybody and everybody, and reach out to us that if we have to go and meet anybody, I'm saying that is our next agenda in this next 1 year. We have already made inroads to the anesthesiologists. We have made inroads to the emergency people, but let's try to reach out to many more people. Thank you.
Thank you. Thank you so much. Let's give them all a big round of applause. And
Thank you so much, speakers. I would request our panelists to please come forward for a group photograph.
We will now be starting with our valedictory session. I would request Dr. Girdhar Gyani to please come on stage. Thank you, sir. I would request Dr. Alexander Thomas, sir, to please come on stage. Dr. Pawan Kapoor, Dr. Venkatesh Thupil, Dr. Anupam Sibbal, Dr. Upasna Arora, Dr. Sanjeev Singh, and Dr. Lalu Joseph to please be on stage. And Dr. Vijay Agarwal, sir. Okay, Mr. Satish Kapoor to please come on stage. Please give them a huge round of applause.
So we will begin with the valedictory address. May I also request Dr. Shankar Sen Gupta to please come on the stage, Vice President CAHO. Dr. Shankar Sen, are you there? Okay.
I would request Dr. Yashpal Bhatia to please join us on stage.
So we'll start with the proceedings of the valedictory session. May I now request Dr. Vijay Agarwal and Dr. Lalu Joseph to please make some important announcements regarding the next year's conferences.
Good evening. Very good evening, everyone. I know you're all eagerly waiting for the announcement of all the prizes. We will go through all of them very quickly. So it's our, I think we have to take this moment to announce the next CAHOCON. I request Dr. Vijay Agarwal to announce the venue, the date for the next CAHOCON, CAHOCON 2026.
So the next CAHOCON will be in Chennai. And the dates are 10th, 11th, and 12th of April. That will be again a Friday, Saturday, and Sunday of April. So ladies and gentlemen, please block your dates right away. You are going to see the greatest ever CAHOCON probably in our history, because you know who is there in Chennai. It's it's Lalu Joseph and her energy. So you can imagine what is going to happen, the magic. Thank you.
Thank you. I think the large contingent from Chennai was here. I do not know where they are. Mr. Adil, yeah, the entire team of Chennai. Are you all here? Yes, please come to the stage. Let's have the music begin. Chennai rocks. Let everybody come on stage from Chennai, please.
Yeah, guys.
I think the team is still not ready with all the AV and announcements.
Doesn't matter. So.
Are you ready with the AV? Let's give them a big round of applause. I think there are several others who are going to be joining from the Chennai team.
Who is coming? Yeah, it's come. Oh. Thank you. Thank you. Thank you. Is Satapathy here?
So for the CAHOCON this year, 2025, any guesswork as to where we are going to be having CAHOCON? Are you all joining CAHOCON? Yes.
Yes, the CAHOCON is going to happen in a wonderful city of Bhubaneswar with the Kalinga Institute. And do we have Dr. Satapathy to please come here?
A big round of applause to the Kalinga Institute. They'll be hosting CAHOCON in the month of November.
On the 15th and 15th, 16th November. On the 15th and 16th of November 2025, we are going to see
I would like to invite all of you from the East Zone to be a part of this CAHOCON. May not be a tsunami like CAHOCON Chennai, but it will definitely be a mini tsunami. I can guarantee you. Thank you.
yes. The organizing chairperson of this conference is going to be one of the most iconic, remarkable person that you will meet him there if you will come, and that is Mr. Achyut Samanta. He is the head of the Kalinga Institute of Kalinga Institute of Technical Sciences, KITS, and Kalinga Institute of Social Sciences. Ladies and gentlemen, we were there, and I can tell you it's like a marvel that needs to be unfolded. The institute has 40,000 students, which they give all kinds of education and everything free of cost. You have to see that to believe. So kudos to Kalinga Institute and for partnering us for hosting the CAHOCON 2025. And we are told that our Mr. Prashant Sharma of Kolkata will be the organizing secretary of CAHOCON 2025. Is he there?
Mr. Prashant, are you around?
Anyway, is his sister, what's her name?
Shweta.
Shweta, is she there? I'm sure both of them. All right. So thank you. Thank you for. Also, I think we need to know that the diagnosticon dates are in January. I don't think we have a video for that. We have?
No, the diagnostic con will happen at
Indore, in the beautiful city of Indore, one of the cleanest cities in the country. So that will happen in January end or February. We'll come to you with the exact date.
And the CAHO Student Engagement Committee, CAHO SACCON, will happen at Hyderabad, and Apollo Institute will be hosting CAHO SACCON.
In September. It will happen. And this year, so far, we had been reaching out to the hospital administration students, but we are also going to now reach out to the nursing students and to the medical students. So, second, we are calling, do we have Amita Marla and her team here to take the medal? Who is here? Hi, come on. The Apollo Institute people. Ask them the dates. So please block the dates, 19th and 20th of September. 19th will be the pre-conference workshops of CAHOCON, and the 20th September will be the main conference at Indore. That's now. Award? Yeah.
Thank you, sir. I would now request Dr. Girdhar Gyani to make the announcement of Lifetime Achievement Award and read the citation, sir.
Okay. Chair has to be in the front, no? Okay. So we are waiting for this moment. You see, the Lifetime Achievement Award, as the name itself is there, is you see based on the work done by a person over the, let us say, past minimum 40 years. Because lifetime cannot be given to a person who is less than 60 years. I got the first Lifetime Achievement Award by CAHO. And since then, I think Dr. Vijay has made me a permanent convener for selecting a person based on the consultation with my fellow patrons and of course other few experts available in the market. Of market, when I am saying market of the quality. Now, after a lot of effort done, we took very limited time because the person was so distinguished that we didn't take much time to identify a person sitting here, Dr. Nagendra Swami. Currently, as you know, may I invite Dr. Swami, please come over. He is a distinguished healthcare leader with an over 4 decades of impactful contributions in hospital administration and quality management. He is MBBS and MD in hospital administration. Currently, he is the president of Ramaya Memorial Hospital, Bangalore, and founder chairman of Medisync Health Management Services. He has led transformational changes in healthcare delivery. Let me tell you, he is the former Group Medical Director and Chairman Quality Council at Manipal Health Enterprise. In fact, the quality at Manipal is attributed largely to the effort by Dr. Nagendra Swami. And he is also incidentally patron of CAHO. And Dr. Swami has been passionate advocate for patient safety in India, mentoring institutional and professional nationwide. His global experience and steadfast commitment to excellence continue to inspire healthcare fraternity. CAHO is very privileged to announce him as the Lifetime Achievement Awardee this time.
Dr. Swami, and many congratulations. May I now request Professor Ravindran Jagasoti, Chair of International CAHO Committee, to announce the Lifetime Achievement Award for International, and please read the citation as well.
At the outset, I'm very humbled by this recognition given by my own family. I think any award or a recognition is a responsibility bestowed on you to be more vigilant and more participant in the movement. CAHO as a movement I have seen it from the beginning. It has grown into a mega movement today, and a small initiative is changing the country, and which we saw all the international speakers very clearly recognize the contribution that CAHO is doing. Receiving this award is not for me, it's for all of you who are working for quality. And I thank the patrons and the CAHO Governing Council for having given this to me. But with true humble beginning, I would like to tell it belongs to you and totally to all quality champions. Thank you.
We now come to the announcement of the Lifetime Achievement Award 2025 International. This award this year goes to Dr. Peter Lackman. Can you come forward? Dr. Peter Lackman is a globally respected leader in patient safety and quality improvement. With a distinguished career spanning continents, he has dedicated himself to advancing healthcare systems through leadership, education, and innovation. As director of the Global Patient Safety Fellowship at the Patient Safety Movement Foundation and former CEO of ISQA, he has shaped global discourse on quality in healthcare. In Ireland, he leads clinical leadership programs at the RCPI, and in Africa, he drives quality initiatives across multiple nations. A renowned pediatrician and a thought leader, Dr. Lackman's contributions include many seminal works. His visionary efforts have left an indelible mark on global healthcare transformation, making him a truly deserving recipient of the Lifetime Achievement Award International 2025.
Thank you. Many congratulations, Dr. Lackman. May I request you to speak a few words, please?
Thank you for this award. The journey with CAHO started in 1917 when I met Anu in Kuala Lumpur at the ISPRA conference, a chance meeting that's now ending here. But it's not an end, it's continuing of a journey. I've been humbled by the actual quality improvement journey across the world, and particularly in the countries that I visit most of the time, and now in India. The work that you've been doing has been phenomenal. And I'm just one small cog in the process of making it better for children, for adults, and healthcare workers around the world to make quality safer and better for all. So I want to thank CAHO for this recognition, and I want you to continue the work that you're doing, which is making a difference to every person every day in the hospitals that are participating. So thank you very much.
I would now request Dr. Sanjeev Singh to please make the announcement for Quality Champion Award and read the citation.
The Quality Champion Award for 2025 goes to Dr. Vasundhara Atre. Dr. Vasundhara Atre, a seasoned anesthesiologist and a visionary healthcare leader, has been recognized with the Quality Champion Award for 2025 for her unwavering commitment to quality improvement, innovation, and patient safety. With over 4 decades of rich experience across clinical, administrative, strategic roles, she has consistently driven transformative initiatives in major healthcare organizations. Currently, she is an associate director, medical services at Manipal, Bangalore, and she has played a pivotal role in advancing quality standards, digital health, clinical governance, and capacity building. A principal assessor, digital health standard assessor, a CAHO Life member, Dr. Atre pioneering efforts including COVID innovations, telehealth integration, quality publications, grassroots education, reflects a deep passion making healthcare safer. Congratulations to Dr. Vasundhara.
I would request Dr. Sanjeev Singh to please announce the Young Quality Achiever Award and read the citation.
So the Young Quality Achievers Award goes for 2025 goes to two fantastic quality champions, Dr. Malti Murugeshan and Dr. Sana Amreen Syed. So can I call upon Dr. Malti first? Dr. Malti is recognized with the Young Quality Achievers Award 2025 for her outstanding contributions to infection prevention, antibiotic stewardship, and patient safety. With decades of experience across leading institutions like CMC Vellore, Meenakshi Super Speciality Hospital, she has led impactful initiatives in quality improvement and digital infection control. A passionate educator and a researcher, she has authored high-impact publications, mentored healthcare professionals, and contributed to WHO-supported programs. As a GC member of CAHO, she exemplifies leadership, innovation, dedication to advancing healthcare quality at both the institutions. Congratulations, Dr. Malti Murugesh. I would like to call upon Dr. Sana Amreen Syed. Dr. Sana is honored with Young Quality Achievers Award 2025 for her exemplary dedication to public health quality in India. A dynamic leader, she has been instrumental in achieving NABH accreditation for 47 and NQA certification for 25 public health facilities in Pune district. An unprecedented feat that earned Maharashtra the NHRC Quality Award in 2018. As a national mentor for Lakshya and NQAS, she has driven quality improvement across 200 facilities. Passionate about training and innovation, she has empowered over 1,000 healthcare workers and continues to inspire through her leadership, commitment, and excellence. Congratulations to Dr. Sahana.
We would now like to announce the Young Clinical Leader in Quality and Patient Safety, Dr. Joseph Fidelis Memorial Award. This award honors a young clinician who exemplifies exceptional leadership and commitment to healthcare quality and patient safety. It recognizes those driving positive change within their institution and the broader healthcare community. Dr. Joseph Fidelis, a passionate advocate for quality improvement, began his journey with CAHO in 2017 as a student and rose to become a certified trainer and governing committee member. His work at AVH Hospital Tirunelveli as Chief Operating Officer reflected his dedication to clinical excellence, mentorship, and system-wide quality initiatives. I would like to invite late Dr. Joseph's mother, Dr. Gigi Selvan, obstetrician and MD of Arna Vilkeli Group of Hospitals, his wife, Dr. Madhu, an obstetrician, and his sister, Dr. Jane Augustine, an orthopedician, to give the award. Please give them a huge round of applause.
So Dr. Joseph Fidelis Memorial Award goes to Dr. Faris Hussain, KN. Congratulations, Dr. Faris. Dr. Faris Hussain is awarded with the Quality Clinical Leader in Patient Safety for 2025 for his extraordinary leadership in transforming critical care quality. As a head of critical care medicine in ICRA International Hospital, he has pioneered patient safety initiatives like remote patient monitoring and tele-ICU, significantly improving outcomes in undeserved areas. Despite no formal training in quality, his commitment to clinical audits, infection control, digital innovation, and staff engagement has set new standards. As mentor, researcher, and passionate advocate for quality, Dr. Faris exemplifies the spirit of clinical excellence, innovation, and compassionate care that this award seeks to honor. Congratulations, Dr. Faris.
A truly memorable moment, and thank you for this. I would like to announce the National Patient Safety Champion Award and Scholarship. Would like to invite Dr. Nisha Nair to give away the Nirmala Devi Endowment Prize, recognizing heroic actions and vigilance in patient safety. There are two winners in this. Winner will get a cash prize of 10,000 rupees and 10,000 CAHO training programs scholarship. So the winner is Ms. Bharani from Apollo Hospitals, Chennai. On her behalf, it's a team who's gonna collect this award. Thank you. The runner-up for this award would get 5,000 CAHO training program scholarship. And the runner-up is Ms. LG Matthew, Rajagiri Hospital, Kochi. Ms. Dhanya Michael from Rajagiri Hospital will be collecting on her behalf.
So we would now be announcing the results of the platform presentations. The results of platform presentations for clinical services. The first prize goes to Dr. Saril V.S., Sakura World Hospital. Please give him a huge round of applause. The second prize goes to Dr. Yakuta from Esther Clinics UAE for platform presentation for clinical services. The third prize for this goes to Dr. Makesh Rangaswamy, JSS Academy of Higher Education and Research. And third is. The next award is for nursing platform presentations. The first prize goes to Miss Ashwati Venugopal from Rajgiri Hospital. The second prize goes to Mr. Hari Harkan Sankaraj, Regency Hospital. And the third prize goes to Mr. Mandipya Ghosh from Tata Medical Center. Please give them a huge round of applause. Okay. Please give them a huge round of applause. Third category of platform presentations is for general support. The first prize goes to Mr. Prem Chandar M. Christian Medical College, Vellore. Mr. Prem. The second prize goes to Mr. Tanmoy Sen Gupta, ILS Hospital, Dum Dum. And the third prize goes to Mrs. Sudha Mohan, Apollo Main Hospitals. Please give them a huge round of applause. The next category of award is for platform presentation. Student goes to Miss Aishwarya Sumesh Rao, AJ Institute of Hospital Management. Miss Aishwarya Sumesh Rao. Are you there, Aishwarya? And the second prize in the student category goes to Dr. Soumya Rawat, KGMU. Please give our participant a huge round of applause, please. The next set of awards for the lightning talks. In the delegates category, the first prize goes to Ms. Shalini Sharma from Fortis Healthcare. Ms. Shalini Sharma from Fortis Healthcare. Lightning talk presentation, please, audience. Give our winners a huge round of applause. They worked hard for this. The second prize goes to Ms. Sindhu Pavitra Mehta Multi-Speciality Hospitals. And the third prize goes to Ms. Dhanya Michael from Rajgiri Hospital. Dhanya Michael. Lightning Talks Award student category. The first prize goes to Dr. Shruti Surekha from Rajasthan Hospital. Dr. Shruti Surekha. Our next round of awards are for clinical poster presentation. The first prize goes to Miss Stella Marie Townsend, Skill for Men. Please give them a huge round of applause. The next prize goes to Dr. Saril V.S. Sakra World Hospital. Dr. Saril. The next prize goes to Miss Momita Saha, Fortis Hospital, Kolkata. The poster competition award for nursing. Next set of awards are poster. The first prize goes to Ms. Tripti Nanda, Noble Hospitals and Research Center, Pune. Mrs. Tripti Nanda for poster competition nursing. The next prize goes to Mrs. Momita Saha, Fortis Hospital, Anandpur, Kolkata. And the third prize goes to Mr. Lavlesh Singh, Bombay Hospital College of Nursing, Indore. Our next set of awards are for poster competition, general and support. The first prize goes to Mr. Shiva Kumar. Third prize, Miss Lavlesh Singh, Bombay Hospital College of Nursing, Indore. The poster nursing awards. First prize goes to Mrs. Tripti Nanda, Noble Hospitals and Research Center, Pune. Second prize goes to Mrs. Momita Saha, Fortis Hospital, Anandpur, Kolkata. And the third prize goes to Mr. Lavlesh Singh, Bombay Hospital College of Nursing, Indore.
You guys should not stop clapping for them.
Our next set of awards are for poster competition, journal and support. The first prize goes to Dr. Priyank Tripathi, HCG Hospital, and Mr. Shiva Kumar from HCG Hospital.
Guys, I hope you guys are not tired. Even if you are, you should applause for the achievements and the hard work.
The next set of award goes to Dr. Komal Agarwal, Sakra World Hospital. And the third prize goes to Mr. Jagin P. Apollo Main Hospitals. The next category is for poster competition student. It goes to Mrs. Ujwala Chaudhary, MGM Medical College and Hospital, Kamothe, Navi, Mumbai. And the second prize goes to Mr. Unni Krishnan SV, Sarvodaya Healthcare. Our next set of awards are for clinical audit. The first prize goes to Dr. Neeraj Amrita Institute of Medical Sciences, Kerala. And the second prize goes to Dr. Vasu Vashishta, Sir Gangaram Hospital. And the third prize goes to Dr. Priyadarshan Ponar, Fearless Hospital, Kolkata. Please give our winners a huge round of applause. First prize, Dr. Neeraj Amrita Institute of Medical Sciences. Second prize, Dr. Vasu, Sir Gangaram Hospital. Second prize goes to Dr. Vasu Vashisht from Sir Gangaram Hospital. And the third prize goes to Dr. Priyadarshan Ponar, Fearless Hospital, Kolkata. Our next set of awards are for research and publication. The first prize is shared by two participants, Ms. Zarina Ziauddin from Sri Ramchandra Institute of Higher Education and Research, Chennai, and Ms. Vaishnavi V from Flab Healthcare, Chennai. This is the first prize for research and publication. It's shared by two participants. The second prize for research and publication goes to Ms. Kasturi Hajra from Center of Chronic Disease Control, New Delhi. Second prize, Ms. Kasturi Hajra. The third prize goes to Dr. Yamuna Devi VR from Apollo Hospital, Chennai. The next set of awards for the video presentation. The third prize goes to Dr. Yamuna Devi VR from Apollo Hospital, Chennai. Please continue applauding our winners. Our next set of awards are for video presentations. The first prize goes to Mr. Anthony Vijay Raj from Narayana Hridayalaya. The second prize goes to Dr. Shamim KU from KIMS Healthcare. This is for video presentation. Second prize, Dr. Shamim KU from KIMS Healthcare. And the third prize is again shared by two candidates. Ms. Dhanya Michael from Rajgiri Hospital and Ms. Padma Vati M from Manipal Hospital. I would request to audience to please give our winners a huge round of applause. The next set of awards is for Fire and Life Safety Excellence Award for hospitals. So for this category, the first national award goes to Majumdar Shaw Medical Center, Bangalore. The national runner-up for our Fire and Life Safety Excellence Award goes to Yashoda Hospitals, Hyderabad. Next set of award is for Fire and Life Safety Excellence Award. North Zone goes to CK Birla Hospitals, Jaipur.
So the Yashoda Hospital's national runner-up.
North Zone winner is CK Birla Hospitals, Jaipur. The South Zone winner is Shri Kamachi Medical Center, Tanjore. South Zone award is Shri Kamachi Medical Center. The Best Zone award goes to Care Hospitals, High Tech City, Hyderabad. Care Hospitals, High Tech City, Hyderabad. Best Zone for Fire and Life Safety Excellence Award. Please give our winners a huge round of applause, audience. Please. The Central Zone Award goes to Regency Hospitals Limited, Kanpur. The East Zone Award. Regency Hospital, Central Zone. The East Zone Awards for Fire and Life Safety Excellence goes to BM Birla Heart Hospital, Kolkata. Please give our winners a huge round of applause. East Zone Award for BM Birla Heart Hospital, Kolkata. Our next set of awards are for sustainability. And the first place national goes to Indraprastha Apollo Hospital, New Delhi. Please give a huge round of applause for Sustainability Award, Indraprastha Apollo Hospital, New Delhi. The runner-up for sustainability is Amrita Institute of Medical Sciences and Research Center, Faridabad. Runner-up award for sustainability. The North Zone Award goes to CK Birla Hospital, Jaipur. The North Zone Award goes to CK Birla Hospital, Jaipur. The South Zone Award goes to Christian Medical College, Vellore. The East Zone Award goes to Fortis Hospital, Anandpur, Kolkata. Fortis Hospital, Anandpur, Kolkata. East Zone Award, Fortis Hospital, Anandpur, Kolkata. The West Zone Award goes to Care Hospitals, High Tech City, Hyderabad. West Zone Award, Care Hospitals. And the Central Zone Award goes to Ramakrishna Care Hospitals, Rajpur. Ramakrishna Care Hospitals, Rajpur. Raipur. Ramakrishna Care Hospitals, Raipur. Now, third, Central Zone Prize, Ramakrishna Care Hospitals, Raipur. Now request Dr. Lalu Joseph to please give a vote of thanks.
Thank you so much. I request Dr. Jeet Patwari to come up on stage and make the announcement for the IIM Shillong program. Over to you, Jeet.
Good evening, everyone. I'm here to announce the launch of the second batch for IIM Shillong and CAHO. We run a program on executive management in healthcare in collaboration with CAHO and IIM. The first batch we have successfully completed. We have some of the participants there. The second batch we are going to start from the month of May. 14, 15, 16, 17th would be the immersion program there in Shillong. Then we have the online sessions and the practical and the other things. And we have a valedictory towards the end of the program for 3 days. The details are available on CAHO website, caho.in. Request you to please go through. Thank you so much.
Thank you so much. Now it's time once again to announce the venue for CAHOCON 2026. I request the team from Tamil Nadu to please come forward. Request all the dignitaries on the dais to join them. The organizing chairperson will be Dr. Nalla G. Palanisamy. The co-chair, let's give them a big round of applause again. The co-chairperson is Dr. Manivandan from Kaveri Group of Hospitals, and the organizing secretary is Dr. Satish Devadas. And the entire team here request everyone from Tamil Nadu to please come and join and take over CAHOCON 2026. Let's give them a big round of applause, please. Thank you so much. Lot of people to thank for CAHOCON 2025. I will have to go for hours if I have to thank everyone. Let me take this opportunity first to thank all the delegates. Let's give ourselves a big round of applause for taking 3 full days off your busy schedule and for being here with us and for gracing the occasion. Thank you, chairpersons, several chairpersons and co-chairpersons for each of the sessions, wonderful sessions organized. All the moderators of the various sessions, thank you so much. The speakers who have traveled from all over the globe, various parts of the country for being here. Thank you so much for being here and for enlightening the audience and for making CAHOCON 2025 very special for us. Big thanks to all the jury. We had 250 submissions for platform, about 70 submissions, research publications, 70 plus clinical audits and 50 video presentations. Big round of applause to all the jury who took the time, very carefully selected the prize winners. Thank you for the pre-evaluation jury, the governing committee members of CAHO. I would like to take this moment to thank the organizing team of Delhi. May I request Dr. Anupam Sibal, Dr. Upasana Arora, Dr. Yashpal Bhatia sir, Sanjeev Singh sir, please come up on stage. And the entire organizing committee of Delhi. If you are present here, please join us. Dr. Satish, Mr. Satish, all of you from the Delhi organizing committee, please join us on stage. Dr. Nareen Sehgal, ladies and gentlemen, let's give them a big round of applause. CAHOCON 2025 comes to a grand close and we had 1,600 participants, delegates here in person, 22 pre-conference workshops, 7 pre-conference workshops across different regions of the state. Let's give them a big round of applause, please. Thank you so much. Thanks to all the forums of CAHO for coming here, gracing the occasion in large numbers. And the various committees of CAHO, the CAHO Research Committee, Student Engagement Committee, the International Advisory Committee. A big round of applause to all our sponsors. This would not have been possible without the support of our dear sponsors. And we wish to thank all our title sponsors, the Joint Commission International, BSI, Institute of Healthcare Improvement, 5C Network, Zuvarlase for the generous contributions and the support given to us. Thank you, Platinum sponsors, AACI, Yashoda Hospitals, DOSI, Johnson Diversey, Bikasa Industries, Sumit's Burger, System Air. The gold sponsor, Shulke, ASP, Advanced Sterilization Products, Rajiv Gandhi Cancer Institute, Pfizer, Narayana Health, Fluke, Medirest. Silver sponsors, I'll have to mention all of them, several silver sponsors. Thank you so much for supporting us. All the bronze sponsors for the event, the technical partners. We had more than 80 partners who supported the event. Big round of applause to all the partners and sponsors, please. Big thanks to all our knowledge partners, ISQA, ASQA, the Quality Council of India, QAI, ANI, Association of Healthcare Providers of India, NABH, NABL, Kimpro Foundation, Skills for Med, AJ Institute, Leeds Global, BMJ Group, Chitkara University, and many more knowledge partners who supported this event. Thank you to all the Centers for Quality Promotion of CAHO. All the 42 Centers of Quality Promotion of CAHO, thank you so much for the support. The exhibitors, the design partners, circus and website partners, IBs, Mice and more. Let's give a big round of applause to Mice and more. They made the event so comfortable for us. Sarthak, Sumit and team, may I request you to kindly come up on stage. Our event partners deserve a big round of applause. Let's have them on stage, please. Ladies and gentlemen, please give a big round of applause to our event partners, Mice and More. We fondly call them Mice. Please join us on stage. Dr. Vijay, please join them on stage. Our dear team from Secretariat request all of you to please come and join our volunteers, our interns, our Secretariat. Kindly join us on stage. Let's all rise for the national anthem, please. Thank you so much, dear participants. Let's honor the national flag. Let's close the event with the national anthem. Request all of you to kindly rise for the national anthem.
जनगणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
The Secretariat, all of you, please come up on stage, please. Let's give them a big round of applause. Thank you, Delhi. Thank you for hosting us. Thank you so much. Request the Secretariat to please come up on stage. All the volunteers too.